Good morning, sir.
Good morning, Dipankar. How much time?
We'll start at the 8:40 around. We can do the lecture, sir. 8:40.
Okay. Should we start or are we waiting for somebody?
Uh, sir, we'll start within a 5 minutes, sir.
Okay.
I'm just coordinating. We'll have the introduction, then we'll start, sir.
Okay.
Hello.
Please come inside. Mask लगा के पहचान हैप्पी कि तुम पंक्चुअल हो पंक्चुअलिटी इज देयर अच्छा लगता है लेकिन बीवी से मुझे आपको लगेगा कि लेट हो गई लड़की
Hello.
Hello.
नीचे करके खाना मतलब नीचे
Good morning, everybody. Am I audible?
Your audible, your screen slide sharing is very clear.
Excellent. So I would introduce myself. I am Sohit Kanotra. I'm one of the pediatric otolaryngologists at University of Iowa, and I direct the complex pediatric airway program. I'd like to thank Dr. Sachdeva for the kind invitation to talk in this program. We are a little bit late, so I'm not exactly sure when I'm supposed to end. So if I go over time, just let me know, and I can stop talking. There's a lot to cover, so I'll try to keep it very short and brief, and will be a little bit fast-paced. So I was requested to talk about management of pediatric airway disorders, and I put prenatal and neonatal as well, because there are lots of stuff which we do even in the prenatal area. And if we get time, we can address that in this talk. So this is my hospital. This is where I work. Many of you are familiar with the Iowa head and neck protocols. So many of the airway protocols have been, pediatric airway protocols have been influenced by what we practice over there. It's a beautiful place. My email is on the top, and the reason I put it first on is I'm pretty sure there'll be lots of questions after the talk. So feel free to reach out to me if there are questions. Pediatric airway seems pretty complex, but it is to a certain extent, but I'll try to simplify it so at least some basic airway management in children can be accomplished. Again, feel free to reach out to me. We do a lot of work internationally. And it's my passion to spread the teaching of pediatric airway throughout the world. So and I'm pretty responsive to email. So please feel free to reach out if there are cases you want to discuss, if there are questions or anything else. So this talk is essentially a synopsis of 3 talks, which I usually give, starting from neonatal airway obstruction, where we talk about exit procedures, to prenatal airway obstruction, then neonatal, and finally we have a full talk on pediatric airway disorders. Each slide in itself is a full 1-hour chat. So again, we'll be pretty fast in this limited time what we have. This slide is more for the residents, just to understand some differences in the infant and the adult larynx. I'll be briefly discussing this and giving some learning tips for the residents. One of the most important difference is the epiglottis is way high in the pediatric larynx, in the neonatal larynx, and the reason nature gave us that is because children can suck, swallow, and breathe at the same time. So the epiglottis actually touches your soft palate, and that's the reason kids are obligate nasal breathers. So that's the first learning point for the residents. Kids are obligate nasal breathers, and they learn how to breathe through the mouth by age 3 to 6 years. So any bilateral nasal obstruction would produce a neonate which is unable to breathe. So that's the first learning point of the talk. Upper airway obstructive sounds. There are 2 sounds which we need to learn. One is stutter, which is your normal snoring sound. This is fine. It's a collapse of the pharyngeal airways. And then the more serious one is the stridor, which is this high pitched sound, which is essentially a hallmark of upper airway obstruction. Many of the kids will have both stutter and stridor. Stutter is okay, stridor is not. So always try to differentiate both the sounds in the children, whether it is stutter or stridor. Now that you have a child who has stridor, what do you do? What is the next step? The next step is to try to figure out, is the stridor in which phase of respiration? Is it inspiratory, is it expiratory, or is biphasic? And that will determine the various causes of stridor. Again, this is available in any textbook, so I'm not going to go over this. But inspiratory stridor, most common cause is laryngomalacia. Expiratory stridor, most common cause is tracheomalacia. Biphasic stridor, most common causes are bilateral vocal fold paralysis or subglottic stenosis or hemangioma. So this is an important thing, and I know I have friends in India and I chat with them a lot. Any child with stridor, that needs to be done. It's a basic evaluation for a child. If you don't have a infant scope, which is a 2.9 millimeter scope, you can use a 4 millimeter scope. Of course, there's always a chance it will be more painful for the baby, but evaluate the larynx in any child who has stridor. Don't label all stridor as laryngomalacia because that is not the truth. So laryngomalacia is the most common cause, but it is not the only cause, and we miss a lot of things because we forget to do a flexible laryngoscopy in a child. So the third learning point: always do a flexible fiber optic laryngoscopy in a child who has stridor. So and when you do that, start your evaluation from the tip of the nose. Don't just make the nose as a pathway to look at the larynx. Start looking for pathology in the tip of the nose. You'll find nasolacrimal duct cyst. You'll find piriform. You'll find retrolingual obstruction. You'll find epiglottic prolapse. You'll find laryngomalacia. So there's a whole plethora of things which you start looking as soon as you put your scope in. So point number 4, always start your evaluation from the tip of the nose, not just look at the larynx, but look at the whole airway from the tip of the nose to the larynx. What if we don't find anything in the larynx and the child is still having symptoms? Then the next step is to do a full bronchoscopy. And most of the time, 100% of the time, we now do bronchoscopy with the child spontaneously breathing. So, and this is a simple bronch. We just use a Hopkins rod telescope. We don't put a full bronch in nowadays. And then you evaluate the subglottis, you evaluate the trachea, you evaluate, go into the right and the left mainstem bronchus, and you try to evaluate the whole airway to look for other causes of other causes of stridor in the child. So let's move to some common neonatal causes of airway obstruction. One is piriform aperture stenosis. Again, if you start looking for it, you will have tons of children who present in the NICU nursery who are having feeding issues. And when you see them, you will hear them producing a stertor sound. There'll be small newborns producing this stertorous sound. You look at the piriform aperture and it's pretty tiny. If it's usually bilateral. Number one, it's associated with a single central incisor. That's a very important question for the residents. And then it is associated with brain abnormalities like holoprosencephaly or pituitary abnormalities. And for that, we get an MRI head. But learning points in piriform aperture stenosis is try to manage it medically. Put some Afrin or oxymetazoline in the nose. Don't use it more than 3 days. Put some nasal saline. If the child is still having breathing issues or airway issues or weight gain issues, then you go ahead do a sublabial medial maxillectomy. It's a very simple procedure. It's not complicated. This is a child who presented with, like, you can hear that stertorous sound, and not gaining weight at all. And it's simple. We do make a sublabial incision. I like to use some otological instruments like a round knife or something just to lift up the mucosa, and then you just drill essentially holes in the medial septum and the floor of the maxilla. And some people put stents in. If you feel stents are necessary, you can cut an endotracheal tube and put stents in bilaterally. And this is the baby just 2 weeks after the surgery. So it makes a huge difference in the baby's feeding and the weight gain. So a simple surgery. The second more common which you're going to see is guanole atresia or stenosis. Again, our approach to management of guanole atresia has been simplified by our skilled usage of endoscopic instruments. Previously, we did not have thin scopes which you could pass through a baby's nose, and it was a challenge. Now, with endoscopic instruments, we can very easily take care of this thing. If it is unilateral, you don't have to do anything. We wait up till they are 2 or 3 years because they can still breathe through the other nose. They are not they can survive. So we wait for the child to grow. If it is bilateral, the first step is to establish an airway. So you can put an oral airway. If you don't have access to the oral airway, you can use what we call as the McEwan's nipple. That is essentially a nipple. You cut the nipple, make it like an oral airway, put a mask on it, and then you can put it in the baby's mouth. So you're essentially giving him an oral airway. Approaches are now predominantly transnasal. We reserve transpalatal for revision cases. They are very rare. It's pretty simple. You go in, you use a backbiter. We do a septectomy. We have urethral dilators, or even if you don't have urethral dilators, you can use suction, curved suction tips, your FES equipment essentially, just to puncture through the guanal stenosis. And then we use a giraffe punch, which is again a sinus instrument to remove some of the soft tissues, and a backbiter to do a posterior septectomy. If you have a balloon, you can insert a balloon, dilate it, you can inject steroid in it, bring the patient back within 3 weeks and redo the procedure, and hopefully that's the last time you have to redo in a child. Simple surgery. Again, the diagnose it, and it's easily treatable nowadays with endoscopic instrument. This third common thing which the NICU might call is a child with micrognathia or retrognathia, and you have to rule out a syndrome in a child. And there are 3 syndromes associated with this: Stickler, Tricher-Collin, and hemifacial microsomia. The child might even have a Pierre-Robin sequence, and then he'll be seeing your facial plastics guy for a cleft palate or a cleft glossoptosis as well. Most of the kids do well, so don't jump to surgeries. Again, use oral, a nasopharyngeal airway. You can put it, you can have the child do prone positioning. The treatment of choice nowadays is mandibular distraction osteogenesis. Again, not a difficult surgery, but you need to have set up for doing a distraction osteogenesis with distractors, and it's pretty commonly done now everywhere. Tracheostomy is the last resort for these kids in case everything fails or the child has multiple airway issues. Intubation related airway injury. Again, your NICU might call you. We have intubated a child, we extubated the child, and the child is having stridor. What is going to be your next step? You're going to do a flexible scope in the child awake. Kids don't go into laryngospasm when you scope them. Again, a learning point. It's a misconception. Kids go into laryngospasm. The only time you laryngospasm is if the child is in stage 2 of anesthesia. If he's wide awake, he won't laryngospasm. There's a whole gradation system, but common injuries which you're going to see is an acute lesion, and this is on a bronchoscopy because it's a subglottic lesion. Or you may also find a web in the subglottis. If you see acute lesions, you can debride them. What we do is we essentially, but it is a very simple procedure. This is a child with significant glotto-subglottic edema, lots of granulation tissue and narrowing and failed extubation. So in a simpler setting, we would have ended up doing a tracheostomy on the child to bypass this. But a very simple surgery is to do what we call as a thyroid allograft. You expose this. This is the same child. He's 3 weeks old. You expose the thyroid cartilage, the laryngotracheal complex. You take the superior lamina of the thyroid cartilage, a small piece. There are no muscles attached. There's nothing going to happen to the child if you remove a little bit of the thyroid lamina, and this is 3 millimeters in width. And then you essentially do your cricoid split, and you place the graft in by interrupted sutures. You don't even have to do a vertical mattressing as we do in costal cartilage laryngotracheal reconstruction. And this works beautifully for the child, absolutely beautifully. You'll avoid a tracheostomy. This is the post-op picture. The airway looks great. The thyroid allograft has healed. This is the thyroid allograft which you're looking at, and it works wonderful. So avoid a tracheostomy in a neonate at any cost. If you have to do a tracheostomy, how do we do tracheostomy safely in a neonate? And I'm going to go over this a little bit because many of my friends in India ask me this question: what is the safe way of doing tracheostomy in India, in your setting? And again, we want to do a pediatric tracheostomy safely. So this is how we do it, if at all we have to do it. And the most common reason we do it nowadays is chronic bronchopulmonary dysplasia if the child needs ventilatory support. For all upper airway obstructions, we do all sorts of surgeries to avoid a tracheostomy. So this is the most common indication we do tracheostomy nowadays. So it's simple. You do a vertical midline incision. So this is our vertical midline incision. It's close to a centimeter and a half. You do your retractions. You can use any instrument. The first step is you essentially do what we call as a lipectomy. So you remove all that brown neonatal infant fat because you don't want to leave any dead space between your skin and the trachea. You find the midline musculature, you retract it, you put your stay sutures, which are transcartilaginous through and through, and you label those stay sutures as right and left. And these are, if the trach comes out, you can actually put the trach back in. You do your tracheotomy, which is at ring 2, 2 to 3 tracheal rings. You make a vertical tracheotomy. Um, and then you mature the stoma. And the way we mature the stoma is we use Vicarial sutures from skin to the edge of the tracheotomy, and then you come back through the skin. So it's vertical hemimatris sutures which are used. This is like a laryngectomy, what you do and mature the stoma. It's a similar thing. And this will prevent from the trach false passaging, which is a major complication if the trach comes out in a infant. Um, so and then lastly, you have to cover the neck. This is how we put the trach in. And then we put a flexible scope through the trach just to see the position of the trach and make sure we are not, the trach is not main stemmed. Very, very important to protect the neck in the baby. So we use dressings, and of every institution has their way. This is how finally the baby looks like. So we have protected the neck in every way possible. And then we essentially get a chest x-ray and make sure they know. We do our first trach change on day 5 because the stoma is matured, and then the family is trained and sent home. So again, a full talk on this. Pediatric airway disorders, laryngomalacia, which is our favorite thing. It is the most common congenital anomaly of the larynx, but it is not the only anomaly which produces stridor in children. Classically, it presents a week or two after birth. It increases over several months and resolves by 2 years of age. The classical triad is a tight AE fold, omega-shaped epiglottis, and redundant tissue over the arytenoids. This is a common question the residents get asked. Um, there are 3 types of laryngomalacia. Type 1 laryngomalacia, where you have redundancy over the folds, and you have type 3 laryngomalacia with complete epiglottic prolapse. Um, as an evaluation for the child, we do scopic evaluation in clinic. What it essentially entails is you scope the child, and at the same time, we are feeding the child to evaluate the swallow, and we look out for any aspiration, penetration, premature residue in the child. So if the child is showing penetration, then we counsel the family regarding what sort of diet or thickeners should be used to thicken the diet. So you work with your speech language pathologist. Mild laryngomalacia, meaning it's just a stridor, not causing any feeding issues. You can do reassurance to the family, or you can do anti-reflux precautions, which includes getting the head end up, keeping the baby up for 30 minutes after feeding, or you can start an anti-reflux medication like famotidine or omeprazole for the child. Reflux is closely associated with laryngomalacia, so if the child has a history of reflux and stridor, you should start PPIs, which you can do for 3 to 6 months safely in a child, plus have them do calcium supplementation because the PPIs inhibit your calcium absorption. Indications for surgery. Our indications for surgery have undergone a paradigm shift in the last 5 years or 10 years or so because the surgery has become safer and safer. And so we do it in much lesser severity nowadays. But most commonly, you'll do if the child is failing to thrive, severe stridor, sleep apnea, has started to develop the pectus. The photograph is to your right, or is starting to develop cor pulmonale or pulmonary hypertension. In those instances, you'll take the child back and essentially do supraglottoplasty, a very, very commonly performed operation. We do hundreds of them in a year. This is the position in which we place the child for a supraglottoplasty. As you can see, a couple of things, and this is the position we do our bronchoscopies as well. We have the Lindholm laryngoscope. It's suspended on a Mayo stand. We put a shoulder roll in the child. One side is connected with an endotracheal tube so anesthesia can pump in some oxygen. The child is spontaneously breathing. This is the light source. I use laser, so we are doing some laser precautions, including putting wet patches on the eyes and then wrapping the child with a wet gauze or a wet towel. We ask anesthesia to get their FiO2 down to less than 30% because we are using laser. If you don't have laser, you can use cold steel instrumentation. I like using laser. And this is how it using a laser and just removing that redundant tissue. With lasers, it's bloodless. So, and I like to use the ultra pulse laser, and those are the settings I use it for laryngomalacia. So, simple surgery doesn't take us long, and we just get rid of the floppy tissue or the redundant tissue over the retinoids. The same on the other side. This is a combination of, this is type 2 laryngomalacia. Again, very tight AE folds. Again, very tight AE folds. Extremely to breathe. And then we essentially laser the AE fold. We open it up. Um, Again, the use of laser, you go incise the AE fold, you remove all that redundant tissue, and then this is how it looks like post-operatively. So pretty well healed mucosal eyes. You can start seeing the airway. This is 2 weeks after the surgery, so looks great. The child does really well after these surgeries. Subglottic hemangioma. Subglottic hemangioma is another common cause of stridor in a child. Typical presentation would be biphasic stridor in a child who's 2 months old. That's when hemangiomas present. Uh, I won't go into details of hemangioma. The treatment of choice is propranolol. Hemangiomas anywhere, the treatment of choice is propranolol. You can talk to your cardiologist. They will, if you see this soft tissue bulge in the airway, it's subglottic hemangiomas. Treatment is propranolol. And the cardiologist can start. We do it ourselves over here. So the dose is simple. It's very simple. It's not at all complicated again, but you'll save a child's life if you start them on propranolol because this lesion literally goes down when you start the child on propranolol. You can do steroids. You can inject steroids. You can laser one side at a time, or propranolol is still the treatment of choice. Papillomas, significant reduction in the last decade or so because everybody is getting vaccinated for RRP. Very aggressive disease presents with the triad of hoarseness, stridor, and respiratory distress. Treatment is again, I use a microdebrider plus a CO2 laser for both for these lesions, and I inject cidofovir intralesionally. We have also started doing avastatin for this thing, but that is reserved for more aggressive lesions. Again, there's been a significant reduction in RRP in North America because of aggressive vaccination. This is easily, we debride the lesion. I laser the lesions which are near the vocal folds. And after 4 procedures in this child, the larynx looks pretty good. Laryngeal cleft, you'll hear a lot about laryngeal clefts nowadays. Pneumonias, you do a swallow study, you'll see frank aspiration, and essentially it's a defect in the laryngeal complex. Depending on the depth of the defect, we classify them from type 1 to type 4. Commonly, you're going to see type 1. Again, it is pretty common. We miss it because we are not looking for it. And it's a simple repair, again, not complicated. It's an endoscopic repair. You laser the edges of the cleft, or you can use cold steel instrumentation to demucosalize. Use your scissors and a grasper to demucosalize this area, and then you just put a single stitch using a grasper. It's a 4-0 vicryl we are putting endolaryngally, and then you just suture it down with instruments, and it's pretty simple. Depending on the depth, you might put 1 suture or 2 sutures. Again, it's pretty common. We do a lot of these over here. I release the folds a little bit to give more space, and this is how it looks post-operatively. I know pediatrics. If it's unilateral, we do injection laryngoplasty with ProLarynx voice gel or carboxymethylcellulose voice gel. If the voice function hasn't come back within 2 years, we go ahead do a laryngeal reinnervation in a child, and I'm pretty sure you might be discussing it in your course today, but just a brief overview of how we do laryngeal reinnervation for unilateral vocal fold paralysis. So this child has a left-sided vocal fold paralysis, secondary to PDA ligation as a baby. The first step is we do an injection laryngoplasty using ProLarynx voice gel, and then we start the laryngeal reinnervation procedure. And it's the nerve we hook. The recurrent laryngeal nerve is known as the ansa cervicalis. This is a very simple procedure. I would highly recommend people to do it because it's very, very simple. You make an incision, you raise some flaps. The trick is to identify the ansa, which is done at the anterior border of, you dissect the anterior border of SCM. And then you find your ansa. It's at the intersection of IJV with the omohyoid and the SCM, and that's where the ansa stump you're going to find. And then you mobilize the ansa stump. You find your recurrent laryngeal nerve exactly as you find in a thyroid surgery, and then essentially you mobilize the ansa cervicalis and hook it up to the recurrent laryngeal nerve under the microscope using nino or nylon or any other suture you want to use. So very simple surgery. And it gives tremendous results in pediatric population. It's a great surgery. So this is us doing the neuroraphy under the microscope. It usually takes a single stitch or 2 stitches to do it. You join the epineurium, and and that's pretty much it. This is the end of the surgery. Bilateral vocal fold paralysis is a whole together different talk, so I don't think we're going to dwell on it today. Management of pediatric laryngotracheal stenosis. Presentation would be biphasic stridor with a history of intubation or recurrent croup in a child. This is the Cotton-Meyer grading system, which is pretty popular in classifying laryngotracheal stenosis from grade 1, which classifies it from 0 to 50%, or grade 2 is 50 to 70, 70 to 90 is grade 3, and grade 4 is complete glottosubglottic stenosis. Again, pretty much available online and anywhere you want to grade stenosis as. This is one of our book chapters which goes over how we evaluate our stenosis. It's a full, a lot of evaluation goes when you start managing these stenosis. And just to give a broad overview of how we manage them grade by grade, grade 1 are those thin scars essentially, or thin webs, which you must be seeing pretty often, especially in people who have been intubated for COVID. And the principles remain the same, both in pediatric and the adult airway. We essentially do laser incision of these. You do a Mercedes-Benz sign where you do a vertical incision over here and 2 on the side. And then you put a balloon and dilate it essentially to the age appropriate size for the child or for the adult. I inject Kenalog and then dilate so the Kenalog spreads. Some people do mitomycin C, which is great and which has been shown to have some benefit in adults, not in children. So I don't use it in children for surface topicalization. But this is simple, grade 1, web, laser or cold steel, put a balloon in, inject some Kenalog 40, and you have to do it multiple times, sometimes in children, and that takes care of it. Same in tracheal stenosis. It's a distal lesion. This is an 18-year-old with tracheal stenosis, and you laser and you balloon dilate. And this is our workhorse for grade 2 subglottic stenosis, which is an anterior costal cartilage graft, child with suprastomal collapse, multiple interrupted sutures. And again, this itself is a 1-hour talk about how we do it. If the laryngotracheal stenosis is grade 3 or higher grade and with glottic involvement and the cords are also involved, then you'll end up doing an anterior posterior costal cartilage laryngotracheal reconstruction where we'll do our anterior cricoid split, we do a posterior cricoid split, we put a part of the costal cartilage in the back wall, we put a part in the front wall, and then we stent it or put an endotracheal tube in. And this is a child who has significant grade 3 glottosubglottic stenosis preoperatively, and this is the same child, hopefully, after the laryngotracheal. So you can see the posterior graft, you can see the anterior graft, you can see they are well mucosalized, and the child is decannulated. We put a stent in. I put I put a suprastomal stent most of the time, and again, these are full talks essentially. Um, Cricotracheal resection, again, this becomes a little bit challenging, and now we are talking about higher end airway recons. It's a great surgery for people who have at least 3 millimeter of stenotic free area between the vocal folds and the subglottic stenosis. This is a child with glottosubglottic stenosis and complete grade 4 post intubation. So there's just no airway. It's trach dependent child. We print our tracheas, which shows how bad the stenosis is at this level. And then we end up doing an extended PCTR where we essentially resected the stenotic, put a graft in the back wall of the trachea. And this is again, CTRs and this is the post-op picture, well mucosalized. The kid is now decannulated. Essentially, you resect the segment and you do a anastomosis depending upon how you're trained. So some people do a single running suture. I do interrupted sutures in the back wall and the front wall. So this is the same. This is a 16-year-old, and it's time. So I'm going to briefly discuss about exit procedures or neonatal airway obstruction. So what exactly is an exit procedure? You guys might have heard the name ex utero intrapartum treatment. It's essentially a procedure whereby prenatally diagnosed airway obstruction, for example, a child with a neck mass or retrognathia, is partially delivered, maintained on placental support till you secure the airway. So it essentially gives you some more time to secure the airway, almost 40 minutes, what has been shown when the child is on maternal circulation. Airway wise, there are lots of indications. Commonly, which ENT gets called, is lymphatic malformations of the head and neck or severe micrognathia. um, Criteria for exit: we do a prenatal MRI in a mother or on ultrasound. The sonologist calls you and says, "Hey, we have a big neck mass, and I feel the child might not do well on delivery." This specific child is a significantly microgonathic child. This is the prenatal airway, and you can see how narrow the airway is. So this will be technically challenging to intubate. And these are some photographs from exit procedure, which we did a couple of years ago. This is the child who has been delivered. It's connected to the maternal mom with the umbilical cord still, and we ended up doing a tracheostomy on this child just because he was just not intubatable. Uh, this is another child with a teratoma who underwent an exit. And that's pretty much it. So pediatric airway obstruction is not that difficult to manage. It is challenging, but I feel with appropriate understanding and training, it's doable. You need to have a dedicated airway team and avoid tracheing every strider baby. Again, I'm happy to talk more about it, answer any questions, comments, or anything else you have. Any questions?
You were very fantastic for me. Thank you.
Hello?
Hello, Dr. Sumit. It was a wonderful presentation
And it was
your
enlightened with your
experience. You shared
experience.
videos.
You shared the
So we have 15
videos.
minutes time. Can we share share 10 minutes something
For 15 minutes, 10 minutes.
Dr.
Um,
Sumit?
I can barely hear you. There's so much of echo. I'm sorry I didn't understand what you said.
Hello, sir. I would
Yes.
request you to give a 10-minute stop more. Like, thank you.
Oh, okay. So you have time. Is there anything, any questions you have or anything like um, just to get you more involved? Do you see a lot of kids with Strider?
Yes. We see lot of cases with Strider, 6-7 days old baby,
Uh-huh.
and like you told, right?
And do you usually do a flexible scope in them just to see what's going on?
Actually, it is difficult for us to do a flexible laryngoscopy in every cases, because most of the time the neonates are very sick and with more and more of congenital anomalies, and to give them to do flexible in the GA, it is very difficult for us to assess that patient.
Okay, so again, this you really don't need to give general anesthesia to the baby. You can do it bedside, and in fact, it's much more safer to do it bedside. You won't produce laryngospasm, and that's what I was telling. If the child is awake, and like you and I are awake, and if somebody scopes me, I won't go into laryngospasm. That's the biggest risk we all think of when we try to want to scope a child, that the child might go into laryngospasm and will have to intubate. But as long as he's awake and crying and doing his things, he won't go into laryngospasm because his reflexes are not obtunded. So he's going to be fine. When you sedate the child, essentially, that's when children go into laryngospasm. So that's what I was wanting to convey. Even 15 years ago, there was a huge thing about scoping children in the office, and we do like hundreds of these every week on almost all the kids we get in the office. So do a flexible laryngoscopy in these kids, especially in the neonates, because you don't want to trach every knee. Tracheostomy is a big thing, and you can save these babies. Seriously, you can very easily save these babies. You can have them a very nice and a healthy childhood, and it's not that difficult. So most commonly, what you're going to see in these kids is either some soft tissue redundancy, and that can be very easily corrected with a supraglottoplasty. So do scope them bedside. You don't have to give GA for flexible laryngoscopy. If you want to do a bronchoscopy, yes, you have to take them to the OR. But for a diagnostic flexible laryngoscopy, do scope them bedside.
Sir, one more question. Sir, is there any special thing we have to see in a decision-making thing while taking the patient for pediatric tracheostomy? Whether this patient, in case of long-term intubation, there are many calls from neurosurgery and all. They call for pediatric tracheostomy for long-term intubation. So, what are the things we should see pre-op in the patient, and what are the things we need to see to decide whether this patient will need pediatric tracheostomy, or we can wait for some more longer of period of time, as it has more rate of complications rather than adults?
That is an excellent question, and I'm glad you asked that question. If you read the last line I've written below is think before you trach. A trach is a huge thing for the child and the family, and always keep yourself in the position of the family. A trach child is a big social issue for the family, especially in countries like India. So always think before you want to trach the child. Again, if the child is failing extubation because he has bad lungs, he's a preterm baby and the lungs are not fully developed, the child has bronchopulmonary dysplasia, and the child might need ventilatory support after, then you have no other option but to trach the child. But if the child is failing extubation because he has some subglottic edema, as I mentioned, or subglottic stenosis, or has some other thing going on, has bilateral vocal fold paralysis, has something going on. If it is coming from neurosurgery, I guess there must be some intracranial issues, and that's why the child is failing.
Yes.
Uh, do at least a bronchoscopy to rule out subglottic edema. If there is subglottic edema, as I mentioned, what you can do is use an endotracheal tube, put a cuff or a plug of Tobradex ointment or any ointment which has steroid in it. We use the ophthalmic Tobradex ointment and keep that plug on the endotracheal tube and keep the child intubated for 2 or 3 days with that plug. Give him some steroids in the meantime. And once they extubate, do a lot of steroid nebulizations. You can do epinebulizations in those, epinephrine or adrenaline nebulizations in those children. And again, that will calm the larynx down and you might be able to get the child extubated. If he still fails extubation, then as I showed pictures of the thyroid ala graft, we can do a thyroid ala graft and prevent tracheostomy in the child. So there are ways you can prevent a trach in the child depending upon why is he failing that extubation. But even if you have to do the trach, the video I showed you is actually on YouTube. It's on various other websites. Try to make it safe for the baby as far as the trach goes. And the most important complication of a pediatric tracheostomy is accidental decannulation, where the trach comes out and you are unable to put the trach back in. That's why those stay sutures which I showed are pretty helpful in getting the tracheostomy tube back in. So there's a whole process about doing peds trachs are very different from adult tracheostomies.
Sir, that was very informative knowledge, sir, and it will help us to attend calls in a very different way and a very proper way, sir.
Yeah, or feel free to reach out to me if you have some case you want to talk about anytime. Again, we do a lot of international stuff all around the world. And this is something which I feel is doable. It's just people are just not trained to do it. It's not difficult. People are not trained, and when you're not trained, you haven't seen it. We all have internal fears about doing stuff which we haven't seen or are not trained in. This is not difficult. It's just we have just not seen stuff like that. So this is pretty much, again, happy to help in any way. Reach out if you have questions. You have my email. So again, thanks for the invitation, and hopefully you guys have a wonderful course.
Thank you, Dr. Sohit. Now it will be a recurring invitation and we will like to have you more frequently.
Yeah,
Thank you
absolutely.
for the enriched experience.
Absolutely. Thank you again.
Good morning.
Thank you very much, sir.
Enjoy the course. Yeah.
Thank you very much,
Bye-bye.
sir. Thank you, sir. Thank you, sir.
So, my dear students, dear kids, Now we'll be starting the OPD procedures, how to do endoscopy, how to evaluate the patient and what to look. So Dr. Rakesh Srivastava will be joining soon and will be evaluating the patients now.
Start sharing this.
So we are having the anesthesia team of Dr. Ashwin. Hello everyone. So we'll be having a good interactive session and we'll have their input also on airway. So now we are starting with the presentation of cases.
वहीं रख देते आएगी वहां तक
आवाज आवाज सुनो
हेलो So the first case for the assessment, the first case for the assessment, this cut throat. In the month of February, going to do is to do the assessment for the vocal folds, and if possible, I'll go below the vocal fold to look where was the injury, and he is not getting that voice which he wants. So he's saying he's having problem. Initially, he was having problem in exertional activity like running or climbing stairs, but currently he doesn't have any issue like with the airway. So we're just doing the assessment. I'll just show you how you can do it. What are the tricks of doing a flexible scopy? So in my setup and how I do it, and many things are there in the test book. But few tricks I'll show you how you can do with the because this is a wonderful tool. This is the people say that scope is the first mode of assessment, but I think one should have a flexible scope to do if you're starting an airway or a voice setup. So flexible nasopharyngeal laryngoscope without suction, and this is I'm using the suction. And this is all of this scope is ENF VT3. So what I'm using is ENF BF170. So that processor is different. I am using narrowband imaging in my office. The current processor is 190 with, it has got a 4K quality and it has got a NBI mode. NBI is basically high contrast laryngoscopy, and it is very good for the assessment of early malignant local anesthetic, xylocaine in the nose, almost 1 cc in each nostril. No decongestant I have used. Decongestant is required only if there is a severe deviation or there is a hypertrophic turbinates, patient is having any pain, then you can put a decongestant and wait 10 minutes and do the scopy later on. So the methodology is patient is comfortable and in neutral position, because we have a dental chair, so head is supported on the dental chair. Here there is no support there. So one person can stand on the back, so that patient should not move the head right or left. And then from the nose, we try to negotiate, and it is नहीं आप बस हाँ वैसे हाँ powerful suction. We need a powerful suction.
Hello.
Yeah.
Can we shift to the screen also?
Yeah. नहीं इसको खींचिए आगे ले आइए. ये राइट लेफ्ट मूव कर रहा है. अप एंड डाउन करो. रेडी. इधर आओ बस. ये राइट लेफ्ट मूव कर रहा है. अप डाउन. इसको चेंज कर देना. हाँ. So this is the way to go from the floor and then ask the patient to say nothing to say, breathe from the nose. So the palate will be in normal neutral position, and now we can see the so we have posted the post-nasal space for Muller's maneuver, how to do the Muller's maneuver. This space is very important to know the facial closure or lymphatic closure. How you can you know, about say papa or like that, so that you know that hold the like this position and look for the approximation of uvula over the posterior pharyngeal wall. Say pa ba. Now you see that it is touching the pharyngeal wall. There's a pharyngeal wall. Ah, ah, ah. अब नाक से सांस लीजिएगा.
Hello.
Oh, yeah.
The picture is a bit hazy, sir.
Yeah, actually some thing is there. I'll just suction is it's not powerful. It's a bit of I'll just get the नाक से सांस लीजिएगा. Now you getting the good quality.
Hello.
Yeah, na? So the very sometimes difficult to assess it for the P important. So look below the cord. So now I'm using it 4% to look below the cord. So asking the patient to say E, 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 E. So yeah. आराम से आराम से. So the total amount which we have used in 4% xylocaine is 1 ml at the inlet site. When we were just at this level, we have anesthetized the base of tongue and epiglottis. Now we have anesthetized the vocal folds. Wait for 30 seconds now and see the sensitivity of the whether by touching it patient is having any feel or not. बार-बार थूक मत घोटिए. You have to tell the patient not to swallow too much, and then you look for the. So this is one way of assessment. If you want to see the anterior commissure, sometimes it is very difficult to see it. You see the movement of my scope, my finger. You can see the, just roll it like this. And now you have anterior commissure with, so just roll it like 180 degree. You can see the anterior commissure also. But in this way, patient thing you have, sometimes it is difficult to see it, but in this patient it is very easy to see the anterior commissure. So yeah, there is a web type of thing is there, and there is a, appreciate that.
Yes, sir.
And now associate it below it, and so there is a small subglottic bulge is there. This is looks like a cartilaginous. This is part of it is membranous. Then the sizing is very important. Sizing of the airway is very important. You have to know the how much is the. And sometimes it is like a step ladder pattern of stenosis. Step, other step like that. And it has a sufficient space. So this stenosis, there is a membranous here. You cannot do anything for the anterior collapse because that is a basically cartilaginous, and this part also looks normal. The junction of the lower part of the cricoid and cricothyroid membrane and the ring is normal. So it doesn't require, only the small ledge of this thing is there near the posterior border of the trachea, subglottis, and it is going obliquely up near the vocal folds. If you see inferior border of the vocal fold, it is this mucosa is going like, now you see it is coming up to the inferior edge of the left vocal fold. So I don't think this will cause any, and the airway must be around 8 mm plus. I can say with confidence 8 mm plus. So 8 mm for an adult patient will not have any problem in breathing. Only if it is less than 50% of the total lumen size, the patient will start having symptoms. And if it is around 40 to 30% of actual airway, then patient will have exertional dyspnea also. running or playing tennis or playing badminton, patient will have distress. But here it looks very bad. But once I go below like this, it is very easy to negotiate it. So if the patient doesn't have any symptom, not to, it will depend on the dyspnea score. Dyspnea scale is there, which from which you have to, the subjective assessment you can do it using a dyspnea score. And there are different ways you can do it by asking simple question like whether patient is having a distress on climbing stairs of 10 stairs like that, or activities, various activity, daytime activity, he can do it or not. So his problem was basically he is not able to generate that force, and he's saying that he's having problem in the voice. So we'll advise him for voice therapy plus some activity or exercise, lung exercise to improve the expiratory force pressure. So if the expiratory force pressure is good, the patient will have a very good voice. Because the vibration of vocal folds is good, approximation is good, so he will have a good voice by physiotherapy and voice therapy. So these are the tricks of doing a flexible scopy, and the maximum dose which we recommend and the books recommend is 6 ml of 4% xylocaine. So for office base also, don't use too much of local anesthetic agent because this will cause excessive salivation, and sometimes it is very difficult to do the scopy because of the secretions which are coming out. And for compromised airway, for a patient where you have to take a biopsy, if the airway is 3/4 is occupied, or if it is obstructed, patient have got a mild respiratory distress, then don't use local anesthetic. Just do it examination and then do the biopsy, because sometimes local anesthetic cause severe spasm and patient have a loss of sensation and suddenly patient collapse. So in compromised airway, the use of local anesthetic is hazardous. And the other thing which is in post-radiated patient, not to use a local anesthetic because the sensation is already reduced in post-RT patient. If you examine it, but in immediate post-RT patients, patient might have little bit of gag, but after 6 months of that, patient has a reduced sensation and there is no need for local anesthetic 4% xylocaine to spray over the larynx. The other important thing is assessment for any lesion. So lesion is best assessed with a chip-on-tip camera like this one. You see the quality of the image. The CMOS is at the tip of the scope, and the pixels quality will improve once you go closer to the lesion. So that is what we recommended for NBI examination. For any lesion, even the benign lesion, you have to go as close to the lesion, at least 5 millimeters from the lesion. It is not that you have diagnosed it, this is keratosis or this is dysplasia, this is hyperplasia. But if you go close to the lesion, then you may find something additional finding into that lesion. So go as close to the lesion, that will improve the pixel power and you will get a very good image. And then you can, once you are going for a permanent treatment like transoral laser surgery, you will have a good picture of the lesion. And I've told you about the examination part, and other things which are important for the tricks of examining the piriform sinus and vallicula, like for the PFS, if you have to examine right PFS, then turn the patient head to the left side like this while doing a scopy. If you want to assess the left side of the PFS, then you have to turn the patient to the right side. So these are the few tricks you can do it. And beside, for the base of tongue, asking the patient to say ah, so that you can see the base of tongue. PFS, you have to ask the patient to say E. And for functional endoscopic evaluation of swallowing, the method is same for the fees test.
Sir, we have made an arrangement for all the things. So you would like to do NBI and strobe in this patient or fees in this patient? So you have to select.
I'll just show the NBI in the benign lesion, I think. Polyp.
Okay.
Polyp
And how about the strobe, sir, in the same case, benign lesion?
Yeah, benign lesion also.
Okay. How about fees?
Fees.
We can show in afternoon also, no issues. But we have to show that also, that OPD procedures include. Now, regarding the management, I would like to ask, what will be the future complications we expect in this case, sir?
Because this is organized stenosis, there's no chances of anything. If the patient is having a airway like 50% compromise, so URI or some time of this thing, sudden unrelated airway infection can cause aggravation of pericarditis. But it doesn't seem like the mucosa, everything is healed, but URI can precipitate, but currently I think is 8 mm plus.
Sir, I want to know two things, whether it is a mucosal only or it is a crico thyroid membrane which is prolapsing.
Yeah, prolapse. Prolapse is little bit of lower border of the cricoid is there.
Cricoid means cricoid cartilage necrosis was there, which is replaced by fibrous tissue scar.
Yes, yes.
Okay, so anything which should have been done during repair of this trauma which could have prevented this, sir? During the repair of the trauma?
I don't know what was the situation, but
Sir, it was
the other thing is one thing one has to remember it for the junior also. If the trauma, because most of the clothesline injuries usually happens at the level of cricoid, and cricoid is a complete ring. So whenever that thing is there, so if you are doing a tracheostomy to improve the patient airway,
what all instruments are required. So next case examination which you would like to take, sir?
that polyp.
पॉलिप को शिफ्ट कर लीजिए और उसमें एनबीआई भी दे देना और okay sir, thank you. One more case, two more cases to be discussed.
इनका क्या था रेजिडेंट इनका बेटा क्या था ठीक है So what you are looking at is right piriform. You can see very clearly. Articulate, and just below it is a arytenoid, little bit more. Two issue. One is little bit of prolapse of the epiglottis, but that is not a major issue. The other issue is left A fold is prolapsing. सांस लीजिए लंबी लंबी गहरी गहरी सांस खींचिए left A fold is prolapsing. E बोलिए E. So it is something like a laryngomalacia. The left cuneiform and left A fold. It has prolapsed and it has gone and it's touching the epiglottis, the laryngeal surface of epiglottis. And now I'm trying to negotiate it. E बोलिए E. 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 Actually, he will require examination under GA. He will require assessment under GA. And then we will decide about, because lower airway looks normal because air blow is there, well as there. E bolo E. 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 We'll do the assessment first. We need only to. चलो बैठो बेटा अभी रुको तुम्हारा यही होना यही ले जाओ आइए आप कौन सा केस है कॉलेज वो प्रेशर नहीं आ रहा इसमें प्रेशर नहीं आ रहा है सुनो एक वी कनेक्टर होता है यार जो हार्डवेयर शॉप में मिलता है वी कनेक्टर से दो सेक्शन कनेक्ट हो सकते हैं एक दवा रखना है ना नाक में कुछ नहीं होगा चिंता मत करिए हल्का सा इसको दवा को खींच लीजिए अंदर आप खींचिए बस so ready come we are going to do the NBI we are going to do the NBI अभी नहीं इससे चेंज हो जाएगा ना ओके आराम से बैठ जाइएगा नाक से सांस लीजिए। हाँ हाँ हो जाएगा। I'll just show you. लो 4% डालिए थोड़ा सा। ई बोलिए ई। हाँ लगातार ई। और डालो 4% और डालो। सक्शन बहुत अच्छा नहीं है। You need very good suction for this. हाँ एयर पुश करो। ई सक्शन नहीं है मैडम, बहुत अच्छा है।
सक्शन देखो काम नहीं कर रहा कोई, तो वो बोल रहे हैं तो सुनो तो। तुम क्यों खड़े हुए कर रहे हैं यहाँ पे जब कुछ नहीं करना है तो? नहीं गलत काम है ना, करो पानी से जो सकते हो खड़े यहाँ पर
नहीं आ रहा। रुक जाओ एक मिनट। हाँ बस बस बस। ई बोलिए ई। यार ये पिक्चर अच्छी नहीं आ रही है, क्या हो रहा है? व्हाई दिस? नहीं फॉगिंग नहीं हो रहा है ना। नहीं कैमरा हेड नहीं होता इसमें। हाँ एक मिनट क्लीन करना। ये पहले रख प्लस बंदो सर्वर क्लीन करो। हाँ चलो हो गया। चलो नाक से सांस लीजिए सर। हाँ नाक से। हाँ यस। बस हाँ हेलो। हाँ
Hello.
yeah now you can see there is a lesion on the right focal fold.
Yes, sir.
It's look like a the video which I saw, it looks like a polyp, but here it doesn't look like a polyp. Suction not working. हाँ jar tight कर दो yes. हाँ now you change it to NBI. Now change it to NBI. So what NBI does is it removes the red light, and we are using the blue blue and the green light. So this looks like the initial video which I got was a polyp, pedunculated polyp, but here the picture is totally different. So section नहीं काम कर रहा यार. You need a very strong section. But this is still a benign lesion. I think it has detached or whatever has happened. So, and you can see there is a feeding capillary is also there from posterior end and the anterior part of the lesion. So mucosal color, the mucosal reflection will be brown, and the submucosal reflection will be cyan color, little bit of greenish tinge. So you can differentiate between a capillary which is coming out from the mucosal part and which is coming out from the submucosal part. And whenever there is a malignancy, when it starts with new capillary formation, what we call as intrapapillary capillary loops, IPCL. So one major feeding is also coming from here, and there is a small feeding capillary which is coming from posterior part. And by different pattern which is seen in the capillary, we assess the lesion. Brightness kam kar do. So you have to take the image at this distance. Then only you can appreciate. And for anything like that, you need 4% Xalocaine, because patient will not allow you to see as close to this without a local anesthetic. So opposite cord is edematous because of the rubbing of this, the lesion there, right side. Management is microflap technique using cold instrument. We can use laser also. I prefer laser, but here there is no laser, so it can be done easily with the cold instrument also. Microflap using hydrodissection technique. Hydrodissection is you inject adrenaline at the base of the lesion at the level of superficial lamina propria, and then you can elevate the flap, subepithelial flap, and do the cordotomy by cold instrument, not by the laser. So this can be easily done with the cold instrument. अब बैठ गए. पिबरफोनिया उधर है ना शायद. पिबरफोनिया को ऑफ कर दे.
Kind attention registered delegates. आप लोग अपना food coupon collect कर लो. You have registered, collect your food coupon, and you can go to the ENT department administrative block near HOD room. There are food is available, and you have to present the coupon. So go with the coupon. And we are taking next case will be examination under GA, direct laryngoscopy of arytenoid dislocation. So after as soon as sir completes this, you people can have a fast rush breakfast. So first collect the coupon, and I'll announce when the breakfast is open in 15 minutes. हेलो डॉक्टर सुरेंद्र, आप आ गए हैं तो आई वेलकम यू. यू हैव कम हियर लाइक एन एनएनसी ऑब्जर्वर एंड आप अच्छे से ऑब्जर्व करिए दैट वी आर डूइंग अ वेरी एक्सीलेंट जॉब. गिव पॉजिटिव मार्क्स टू अस. So I welcome you all delegates and come join us for breakfast.
हमारा डीडो दे दो. Give me a mask also. हाँ उसको लिटा दीजिएगा. हाँ तुरंत मैं लोकल लगाऊंगा तुरंत खत्म कर दे. नहीं नहीं वो लगा देंगे लोकल लगा देंगे वो तो 15 मिनट्स अदरवाइज टू वेट फॉर लोकल. लेटा दो इनॉग्रेशन के लिए हम लोग चले जाएंगे बीच में. नहीं जाएंगे.
सर ये हमारा लड़का रात दिन काम करता है, सोता कब है मुझे नहीं पता.
अच्छा
सारे काम इन लोगों को पता है.
टर्म कार्ड है.
ये अपने नहीं मतलब हम लोग के हाथ पैर सब इन लोग हैं.
Watch please.
वो कहीं है पीजी.
Any external camera is there? Hello.
एंडोस्कोपिक कैमरा काम कर रहा है कैमरामैन.
Hello.
Yeah.
Dr. Pathak here.
Yeah.
Good morning, sir.
Good morning. So what I'm going to do is this is a case of neck trauma.
Ji.
And the patient is on tracheostomy.
Yes.
The age is a young adult patient, and we have tried to examine it under local, not able to negotiate it because of the prolapse of left AE fold.
Yes, sir.
And the left AE fold was touching the laryngeal surface of the epiglottis. And what I'm going to do is I'll just show you the position of the patient, how you have to assess the airway.
Yes, sir.
And maybe we will come to the conclusion that how to manage this case, because this case looks like it can be managed endoscopically if subglottis and the trachea is normal.
Yes, sir.
So the position of the patient for any MLSscopy is very important, because that, and many of the senior ENT surgeons, they don't know about the how to put the patient and how to examine it, the best position for the patient.
For the airway.
So if you see from the side, I think you don't have the external camera. I'll just show you how the patient is placed.
Yeah, we can see, sir. We can see.
You can see from the
Yeah,
here.
yeah, we can see.
So if you see the head of the patient, and if you see the horizontal plane of the
Table.
operating table.
Yes, sir.
So this position, the head end of the patient and the head, the angulation, the distance, the horizontal position and the head of the patient should be 15 centimeter at least.
15 centimeter.
That is Boyce-Jackson's position.
Yes, sir.
So Boyce-Jackson's position is flexion at neck and extension at atlanto-occipital joint, like this.
That's right.
So many of our anesthetic friends also, they do it like that. They try to do in flat position. But that is not the ideal position. And what I am using is I am doing this, and I am putting a pillow also here. I am talking about the adult patient, not about the adolescent or the pediatric patient. That position is different for those
Pediatrics.
age group.
Yes, sir.
So once you go it, and then you should have a tooth guard. If you don't have a tooth guard, then you can use a simple gauge piece, wet gauge piece, and protect the upper tooth. So the flexion at neck,
yes, sir.
and extension at atlanto-occipital joint. So that all the three axes comes in one line. So this patient is not paralyzed. Give me 10% spray. So what we can do is we can do two ways. One is doing a local anesthesia spray. Normally what I do is I give a superior laryngeal block here and here,
Yes,
for
sir.
compromised airway cases, which I am doing under sedation, not under relaxant. So we never try to give a relaxant. The preferred anesthetic agents which we use for compromised airway for operating purposes is using dexmedetomidine infusion. Start 10 minutes before the procedure, and then we start high flow oxygen, HFNC,
Yes,
heated, humidified, high flow, and raise the patient head to 30 degree. If patient is sitting like this, and we start dexmedetomidine, and after 10-15 minutes we bring the patient down. The flow of the oxygen in high flow depends on the weight of the patient. It is 2 ml per kg per minute.
Yes, sir.
So if it is adult patient, we give 60 liter, sorry, not ml, it is 2 liter per kg per minute. So it will be like 60 to 70 liter of oxygen. We fill alveoli with oxygen, all the dead space is occupied. Give superior laryngeal block. If required, transtracheal block also. Transtracheal, we just give 4% xylocaine. Just use it. And then we proceed it. After 10 or 15 minutes, we bring the patient down in our position like this position. And then we again use 10% spray.
Yes, sir.
The other way we use a tracheal, this thing, we use this suction. This is a MLS suction. In this suction, we attach a tri-way. So tri-way is attached at this end, and one of the tri-way end goes with the 4% xylocaine,
Yes, sir.
one with the oxygen, and one with the suction.
Suction camera.
So we adjust the tri-way accordingly. So we don't try to use suction as a suction because we have filled the airway, all the dead space with oxygen.
With the oxygen.
So we don't want to compromise on it. We don't want to suck all the oxygen which is there in the dead space.
Yes.
So then we use this to give 4% in the trachea. So once we lift this, the airway, we lift the airway, then we use this tri-way with suction to anesthetize the local part, the tracheal airway. Also, this is our indigenous technique, which we are using it in our operating theater.
The position is
So,
very important in examination.
Very important
of the
in
airway.
examination.
Yeah.
Because this patient has little bit of retroflex epiglottis.
Yes, sir.
And it is very important to lift the epiglottis well. Local again. Why we are not giving relaxant? Because we have to look for the vocal cord movement. Now you fix it. So you see that if the depth of anesthesia is good, then there is no problem. So
we don't have
the other way around is you don't have to fix it and use a telescope on one hand and laryngoscope on other hand, because you have to adjust readjust the laryngoscope.
That's right.
This is very important because you don't fix it immediately. Like this patient.
We don't have a inner image here right now.
You are getting the
External image.
endoscopic image.
We are not getting it.
So this is cricopharynx behind. This is part of the
Now we can see
suspension.
now we can see.
Hatao suspension. So now I'm adjusting it. I have removed the suspension.
Yes, sir.
I'm trying to again reassess it. Where is the airway? So you see the epiglottis is little bit more retroflex. So I will again try to lift it. So now I can see this.
Yeah, we can see this.
So I'm not fixing it still now.
Yes, sir.
So what I'm going to do is I'll just see that how the things are. I'll fix karo. So important thing in airway assessment is position of the epiglottis, position of the epiglottis, position of the base of tongue, valvular obliteration is there or not. Then we have to look for suction, please. So if you see the right AE fold here,
yes, sir.
And if you see the left,
it is overlapping here.
Yeah. So it is giving a picture of as if there is a LT cleft is there. Patient has not an issue with the swallowing, but once you are dealing with this type of airway, you have to be very cautious about the swallowing. You should not do too much of dissection on this part.
Yes, sir.
And once you are doing the examination, you should have assessment of how the patient sensitivity is there. I will come on the fees part of it because this patient has to undergo fees test also before you take the patient for airway, because this require endoscopic treatment, but you should not do too much harm to create more problem with the swallowing. Give me a vocal cord detector. Lindong. So this is looks like a straightforward prolapse of the AE fold on the left side, and maybe retinoid will not require any treatment further, and this is causing the issue with the. So how you have to put the for posterior glottic assessment, you have to use a Lindom detector in a reverse position and put a Lindom detector in a opposite direction like this.
Yes, sir.
So just try to retract it and look below the. This is not able to negotiate it. Lamba de do. So I am shifting to the longer scope, yes, bronchoscope, so that I'll get a more working distance, because this camera is blocking my vocal. Oh, ये निकल गया.
Hello, sir.
I'm using a Lindom, this Dido laryngoscope, and if you see there now, the picture is more clear. Patient has got little bit of membranous posterior glottic and little subglottic stenosis, which looks like membranous only. Can you appreciate that?
Yes, sir. Yes, sir.
It looks more like a. So this is a good case for laser.
Okay, sir.
So.
So what is the diameter of your telescope, sir?
Yeah, this is 2.7.
2.7.
2.7, yes.
30 centimeter.
Yeah, this is a bronchoscope actually.
Sir.
Used for foreign body removal.
Yes, yes, sir.
But normally you can use a tracheoscope, which is 4 mm. So
Okay,
4
sir.
mm for adult patient, and you can share it with your urology friend.
Yes, sir.
The cystoscope, you can use a cystoscope. So this tracheostomy is far away from your
lesion
stenosis site. So the important part section hai na. You have to palpate it also, because stenosis, the palpation is very important, so that you will know that it's a cartilaginous or bony part of it. So you request your assistant to press it from the side. So it is partly bony, partly it is soft. This. डिटेक्टर मूव कर गया. Hold it. Lindom vocal fold spreader. So there are Lindom vocal fold detector are two types. Types. One I have made a straight one, which doesn't have this bayonet shape.
Yes, sir.
This has a bayonet shape, but one vocal fold detector which is a straight without a bayonet, which I use it here. So straight one you can put it like this without using in a reverse direction. So this is up to here. So once you are doing the excision, you can do the excision of this part of the. So this is looks like a arytenoid, part of arytenoid which has been pushed up, which has gone up like this. So once you remove this and release this part of the AE fold,
Yes, sir.
this part of the AE fold which is short, like laryngomalacia. What is type 1 laryngomalacia? Type 1 laryngomalacia is short AE fold and it collapses with each inspiration. So that is known as type 1 laryngomalacia.
Yes, sir.
So this is something like an adult laryngomalacia. You just have to cut it, or you just use a cobblator and just excise it. And then you have to do the excision of this part of the area. And the third part is you have to give a cut here, and then balloon it. Once you balloon it, you know the size of the airway, and then put a endoluminal stent here. So endoluminal stent will be a cut piece of T-tube, and then fix it over the neck. So, after balloon, after the sizing has been done, you can put a T-tube after cutting this thing, and so this is a complete treatment for this patient. So, 3 procedure. One is cutting this A fold so that it will go a little bit back, cutting this part of the arytenoid, and then releasing this stenosis, and endoluminal stent so that this part doesn't re-stenose. So that is part of the treatment for this patient. So it will take 1.5 to 2 hours. No, you tell me. Patient is under GA, no problem. अभी ले सकते हैं. We can shift it to flexometallic because water will go down. Water will go down. It will take another 1.5 hours minimum. Putting a tube and there, and what tube size is there? T tube.
T tube 12 number आपने बोला था.
हाँ 12 तो शायद चली जाएगी. और so that is the treatment for this patient.
अभी टच करना है कि सेकंड स्टेज में करना है आपको?
You decided. The patient is under GA. I have no problem.
सर्जरी की एंडोस्कोपिक सर्जरी इंस्ट्रूमेंट ला एंडोस्कोपी
नहीं है. Everything is there.
एवरीथिंग इज देयर.
हाँ नहीं. We need a cobblator. We are not going to do with the cold instrument.
कॉब्लेटर.
हाँ cobblator with
लगा वो जो नया बॉन्ड आया वो देखो. देन शुड वी गिव
flexometallic. हाँ shift it to
रिलैक्सेंट.
हाँ relaxant also.
व्हाट फ्लेक्सिबिलिटी?
Flexometallic or some, because blood will go down, na? Blood.
Inflated.
Achha, this is not. This is achha cleft. Okay. This is cuff tube, na? No problem.
Test is also okay, no problem. Relaxant अभी सब करेंगे. Then we will give relaxant.
हाँ अभी दे दीजिए, no problem.
Okay.
लो एक शीट दे दो. एक शीट और दे दो. शीट. एक शीट.
It will take 1 hour.
1.5 hour. Fix करने में.
Hello.
Yeah.
Hello, sir. Nitin here.
Yes.
Sir,
Dr.
I
Nitin?
just want to know about the laryngoscope which you have placed in the larynx.
This is a Dido laryngoscope.
So the tip of the scope is in vallecula, no, sir?
Yeah. It is in vallecular, not in the.
Not in the not
Yeah.
at the anterior commissure.
Yeah, because our work area is in the posterior larynx.
Okay.
We are working on the posterior larynx, so we don't need.
That's why the glottic retractor you could place nicely, no? Otherwise
Yeah.
it was getting very difficult.
Yeah.
You always put it like this for
No,
the posterior.
no, not in all cases. It depends on the, because like sometimes the laryngeal wand doesn't go in the below the mid trachea. So you have to insert your laryngoscope down up to the vocal fold, or maybe little bit below. So the length of the laryngeal wand is, I think, is 13 point something or 14 centimeter. So sometimes it doesn't go because of the extra length of the laryngoscope, which is outside the Mouth.
Mouth, yes, sir.
So this is around 8 centimeter. So 8 centimeter you have wasted the length of
Length of that, yes, sir.
the band. So it doesn't go up to that level. So you have to put it at the level of cord, or sometime if it is a like Dido one, it can go a little bit down also.
Okay, sir.
So CO2 laser without the fiber, you cannot work in the trachea. You have to have a fiber laser for it.
Okay, sir. Thank you.
एक शीट दे दो. एक वो ले लीजिएगा यूनिपोलर कॉटरी. यूनिपोलर कॉटरी. यूनिपोलर कॉटरी. यूनिपोलर. फुट पैडर. ले ले.
Hello.
Yes, yes.
Sir, which are the different type of stents you use?
Pardon?
Apart from T-tube, which are the different stents you use?
Different size of?
Stents.
Stents. Okay, normally what we are using is in India we are using cut end of the T-tube. The T-tube we design it depending on the
T-tube which comes in a 12 or 14 number, that is the same one. So.
That depends on the size of the trachea. Like this airway, we are going to use either the 12 number T-tube.
And how do you fix it in the neck?
I will fix it with a Lintenberger needle carrier. I'll show you how I do it. So with one surgery, with one procedure, we can show you multiple procedure in this case. One is the use of cobbleter. Other is first is the assessment. Other is use of cobbleter and fixing the stent. थोड़ा सा इसकी हाइट नीचे हो जाएगी टेबल की हाइट नीचे होगी टेबल की हाइट नीचे हो जाएगी हाँ इसकी हाइट नीचे हो जाए टेबल की हाइट नीचे हाइट फिक्स है या स्टूल थोड़ा ऊपर कर दो हाँ ऊपर कर दो थोड़ा सा आराम से कम है नहीं ऊपर हो जाएगा सर
हेलो
ऊपर मत करो यार नीचे करना है यस
सर मैं रविंद्र बंसल ग्वालियर से हेलो श्रीवास्तव सर सर ये जो ट्यूब आप डालते हैं ये ट्यूब उसको कब तक रखना होता है हाउ यू डिसाइड कि हाउ लॉन्ग यू हैव टू टेक द पुट दिस स्टैंड या
स्टैंड मिनिमम फॉर 3 to 4 वीक्स नहीं है ज़्यादा ये तो बहुत नीचे है so we'll be putting the stand but before putting the stand we'll be using mitomycin C and Canacort also so we'll be needing mitomycin C and Canacort
and that remove under general anesthesia or we can remove in
नहीं आ पा रहा अभी भी हाँ तो ये होना चाहिए देखते हैं इधर से अब मे बी आई विल डू इट स्टैंडिंग पोजीशन कहाँ गया सर मैं चल लो स्टार्ट करो वी आर गोइंग टू स्टार्ट बिकॉज वी डोंट वांट टू वेस्ट टाइम start as early as possible there are many cases
ऐसे
देखना लाइट पे मत मार देना Light on. Light on. One gauge piece with saline. Pani.
Sir, is it required further dilatation or how you do the follow-up?
It depends on how the tissue responds.
And so what are the
Our basic aim is to decannulate the patient. Airway, there is no straightforward answer to any thing. Just इसको magnify करोगे image को, increase the size of the image. Increase the size of the image. ये बड़ा कर दो, साइज बड़ा कर दो इमेज का. कैसे करोगे? ये बटन है ना, होल्ड करके नहीं हो रहा है? हाँ हो रहा है. होल्ड करके रखना है, मोटर राइट. ठीक है. So what I am doing, I am going to show you another way of examining it. So I am putting the scope from the side of the laryngoscope. Can you see that? Can you see that?
Yes, sir.
So scope is not through the laryngoscope, it is through the, so give me 30 degree. 30 degree nasal endoscope.
Sir, how useful is that Havas laryngoscope that is meant for the endoscopic?
I am not
procedure?
very used to it. I think I have two Havas laryngoscope and they are both are lying. They are not. I am not using it. I am more comfortable with microscope. I am more comfortable with the. So what I am using is a 30 degree nasal endoscope.
Okay.
I am not going through the. I am not going through the. Give me carburetor. So I am not using it through the laryngoscope. I am putting it through the around the laryngoscope.
Okay.
So I am now getting a good picture with 30 degree telescope. Give me band and keep unipolar ready if any bleed is there. So if you are touching on one side of the larynx, there are no chances of re-stenosis. If you are touching both the side of the larynx, there are chances of stenosis.
So you are going to ablate it?
Yeah.
And what are the settings, sir?
5 होगा कितना है? नहीं पानी आ रहा है. So this part of the A fold is relatively avascular area.
Okay.
But still you have to keep a unipolar ready. नहीं मेरे पास है, लेजर वाली है, नहीं लाया. नहीं लाया.
Is there any lateral limit for that, for dissection?
Give me a patty. अरे यार जल्दी दो. अरे वो वाली पैटी दो, न्यूरोसर्जिकल. So we are using two pure aniline patty बैंड दो बैंड. ये विदाउट थ्रेड दो यार. घसीट रहा है इसको. प्रॉपर्टी. सरवन कॉटरी चाहिए होगी यार. कॉटरी पापा है यूनिक वो है. तो लाई नहीं लेजर वाली. हाँ 600. टच करो. टच करो. This surgery would have been easily done with the CO2 laser. Hardly 5 minutes forceps. But no problem. Madam is saying she is going to. We are going to have a laser workshop next time. So I am working through the. Please don't move the patient. You know. So this part has to go. No, later. अरे यार वायर वायर मत खींचो यार. एक मिनट. क्या कर रहे हो? You have to take care of the other side of the. So you can see the bare cartilage is there. Maybe I'll remove that part of the cartilage. Oh, yes. So now I can remove it. Give me scissor. Caesar. 7 micro Caesar.
Removal of the cartilage required dissection.
Yeah, cartilage is bare now.
Yeah.
So we'll cut the cartilage. मैडम की ले लो सीजर, मैडम की सीजर अच्छी लग रही है। हाँ लेफ्ट सीजर। मेरा फोकस होगा, फोकस थोड़ा गड़बड़ हो गया। कौन सा बेटा? दिस वन। प्रेस कर दो, प्रेस कर दो। वेरी गुड।
So quality of the audio visual is very good. Please pass on the message to the Dr. Kavita.
Okay. The master of a cold instrument in India, MLS Scopies, he is no more with us, Professor Arun Goel. So I have learned a lot of things from him, Professor Arun Goel. He died last year. He do most of the work with the cold instrument, and he is also an expert in laser also.
Excellent.
Pardon? Yeah. Better than
Can this procedure can be done with the three-hand technique, sir?
Pardon?
Three-hand technique can be used for this procedure?
I can't hear it actually properly.
Three-hand technique can be used for this procedure?
Yeah, actually I use microscope only.
Okay.
But here I am microscope, the adapter is not there.
Okay.
So I can operate, but you can't see now. This is the problem. I am used to microscope. No problem, we'll do it. मैं वही यूज कर रहा हूँ। हाँ, क्योंकि वैसे लाती है इधर, यहाँ पे वैसे लाएगी ना। सीजर दो।
So our aim is to ablate the mucosa and dissect out the cartilage.
Yes, this part is little bit vascular actually. The superior branch of the superior laryngeal arteries branch, it comes from the I'm able to remove the cartilage now. Maybe give me stout forceps, our stout forceps, big one. So I'm using the bigger forceps, bigger cuff forceps, which I use it for cancer surgery.
Wonderful.
So now you can see that you're not seeing the inlet of the larynx.
Yeah.
Suction.
We can see it clearly.
Suction.
And as such, there is no
because
bleeding.
I am using it from behind, so you are not getting the actual view, because this is in the scope is in the piriform, not in the. I'm not seeing it through the laryngoscope. Once I'll shift it, I'll show you how it looks like. So this is the actual thing you are.
Yes, sir.
But this is a 30-degree scope. So little bit of posterior part, I will re-examine it. I should not do too much of damage, and it should not lead into posterior stenosis also. So be careful. You can do a second stage, but not to do harm to the 0 degree. So not to do too much of harm, don't use it like, even with the laser also, you have to be very careful.
Sir, which laser you use?
I use CO2 luminous.
And
थोड़ा सा बड़ा करेंगे.
What about your experience about this fiber laser, KTP laser, for this purpose?
KTP airway below the cord, it is, you can use it because suction देना. अब वाला दे दो उसको, लंबा वाला.
Sir, luminous तो बहुत महंगा आया होगा.
Now the cost has increased also again. We are 85.
सबसे महंगी कार से भी महंगा पड़ता है सर वो.
क्या जी?
सबसे महंगी कार जो आप खरीदना चाहते हो ना, उससे भी महंगा पड़ता है.
No, no, no. I don't know. Car. You are talking of Tesla. So I think this much is okay, because this will not cause posterior glottic stenosis.
Sure, sir.
And can you increase the size of the? I don't know, madam. Bas. Now I am going to go below the cord. Below the cord also looks okay, I think, with this. So what I am going to do is I'll just size it. How much is the size of the subglottis? So for that you need a uncuffed tube. 6 number की uncuffed देना. Number की uncuffed.
Sir, how you decide when to do tracheal resection and anastomosis, and when you should go for the laser or?
See, 85% of airway stenosis can be managed endoscopically. 15% like grade 3 and 4 will require it. Even grade 3, if it is fresh, then it can be managed. So important examination part is you have to look for the posterior part of the subglottis. Now you look at the posterior subglottis. I am gliding my scope like this and see the trachealis muscle. So little bit of stenosis is there. You see this? This one. So little bit of posterior subglottis is there. And if you see from the side, that is also little bit. So airway which looks very narrow from here, but once you go close to it, then you have to assess the edge of the trachea. with the stenosis.
Okay.
So I think this patient might not require any stenting. And what I'm going to do is just to assess the sizing of the airway by putting the various size of telescope.
Sir, stand डाल ही देना sir.
So, pardon?
Sir, please put the stand.
Put the stand.
Yes, sir.
Doing. No, I just see the endotracheal tube to see the size of the airway.
For the sake of
So
patient and
endotracheal
us.
tube, like if you put it 6 number uncuffed.
Yes, sir.
6 number uncuffed है आपके पास दीजिएगा. So 6 number नहीं I am doing it for airway sizing. So sizing, if it is 6 mm of uncuffed, it will have a OD of 7.8. कितना मैडम देखिएगा? अच्छा नहीं 7.8 है ना OD. Outer diameter. 8.2. So if it is 8.2 for this patient, so I'm not going to do anything. So I'm trying to put this tube and see whether see this is going. So patient airway is 8.2. Okay. So I don't think he will require anything for subglottis. Unnecessary, I will damage more.
Okay, sir.
And it will cause more harm. Any foreign body in the airway, whether it is a stent or anything, it will cause more harm than good. And especially if the subglottis has healed. The only thing which may cause failed decannulation in this patient might be paralyzed cord. So
Okay.
paralyzed cord, we don't know about the movement because that time everything was collapsing. But since one arytenoid was moving, so we may be able to decannulate this patient. So what our next aim will be after 10 days, mitomycin C ले लेना. So after 10 days, Canacort. So after 10 days, we will reassess the airway and then start downsizing it.
Okay.
So maybe today the patient is on 6 number, na? 6 number cuff tube. So we immediately shift it to uncuffed tube. Uncuffed tube so that patient can breathe from above. And once the patient starts breathing from above, the healing will be faster. And patient will get used to the nasal breathing because he is dependent on it. And he will start phonating. Once he starts phonating, the cord will abduct. The cord will abduct, there are less chances of adhesion formation. So he should talk much. He should, whatever, if he is doing puja, anything, he should speak. He should speak as much as possible by putting a finger here. And so that the cord keeps moving. And there are less chances of adhesion formation there. So downsizing immediately. And then after 10 days, if the airway looks good, then we can shift it to 5 number and start corking it. Daytime 3 days, then daytime, then 3 days, day and night, both. If the patient tolerate well with 5 number tracheostomy, then we can take out the tube. So the aim of the goal of the decannulation is patient should have a normal nasal breathing and healing should happen fast.
The same time, do we need to go for the flexible endoscopy, flexible scopy? The
Flexible
scopy along with.
Or you can do rigid also, no problem, but should be able to see it. I think now you can see the airway better. So now I'm going to do is inject Canacort there to prevent any re-stenosis. So the next patient is ready. Yeah. Yes. You downsize it, है ना? You downsize it, no problem. Inject कर देना. कर दोगे? उधर patient है ready? Next patient is ready.
So, sir, if we are able to pass the 8 mm outer diameter endotracheal tube.
Hey, that depends on the patient age, everything, specification. Like he is not even adult now. If you see his physique, everything, his normal adult tracheal size is 18 millimeter, the circumference.
Yes, okay, sir.
So Indian population, the size is less. So for this patient, it must be around 14 to 15 millimeter.
Okay.
Maximum. I think we can even with the scope you can assess it. That if you see this.
So we are not able to see the
endoscopic
picture.
Endoscopic picture. Endoscopic picture. So in this patient also the airway doesn't look quite a big airway. See this, now you can assess with the tube size. See this tube size, this is tracheostomy is
yes, sir.
6 mm, na?
7.5.
So 7.5 tracheostomy, 7.5 hai? So 7.5 with OD of 10.4. So 10.4, you see the airway, it is snugly fitting.
Yes,
this
sir.
tracheostomy tube is snugly fitting into the maybe 1 or 2 mm you can say extra. So maximum you can say 12 to 13 mm is the tracheal diameter. And if here you can get 8 or around that, maybe more than that, because 8 I am saying it with an endotracheal tube. So even 9 mm, patient will not have any compromised airway. 50% only, if 50% it is compromised, then patient will have symptoms. Otherwise, patient will have no symptom. So, I think patient has got, you can say, compromised subglottic airway is around 10% of actual. So 10% will not cause problem.
True,
And
sir.
we will do more harm by doing something on the cutting the cartilage, touching the cartilage, cause periconditis. Then, so this has happened because I have seen patient operated like that. And you have to respect the mucosa. Once it has healed, then respect it. Only if it is a grade 3 or grade 4 stenosis, then only you should touch it. Otherwise, don't do anything. You will do more harm putting a stent there, unnecessary, creating more problem.
Agree, sir.
So what I am going to do is just inject Kenacort at the base. We can use a mitomycin C also to prevent refibrosis. सरवन दूसरा स्कोप लगा दो 30 दे दो 30 दे दो 30. So the injection needle which we are using is the same you get it from Santosh Surgical or Kalelkar Surgicals, the injection needle. So this is the injection needle, you are seeing it. So we are using a Kenacort and I am putting the scope from the side of the scope. रुक जाओ. So these are the maneuvers, you have to learn it with time. See.
Can we remove this hump-like cartilage which is left out?
This is.
Whether, yeah, that's what
we can do it.
Yeah.
Little bit ablate it, not the cut it, but ablate it. Law. वो दे दो. Cobbleter. Sorry, coagulated, not ablated, coagulated. Because of inherent tendency of this, one is to since we have not touched the other side,
Yes, sir.
so there are less chances that it will form a and patient will start phonating it.
Yes.
This one, no. This will form interretinal adhesion actually. So this is the other end of the arytenoid actually, the right side of arytenoid. You see the moment is there on the right side. The arytenoid is moving. So it is the gliding action is there. You can see that. Patty the knife. I will block the neck. साला ब्लीड कर रहा है. ये कहाँ से ब्लीड करने लगा? ब्लीड हो रहा है. पैटी छोड़नी पड़ेगी. पैटी छोड़नी होगी. पैटी दो. पैटी छोड़ो. इसको सूचर भी कर सकते थे. समझ रहा?
Yeah, it can be sutured.
I'm thinking of it.
That's right.
यहाँ से पास करके इसको सूचर कर दो.
It can be removed.
है ना? But main vessel is coming from there.
Something
see
like
that?
glue can be put there, sir? No?
Pardon?
Yeah, glue can be put just to stuck up that.
Then let him. Actually, I think he will. Once he will start speaking, na. I think today only we will reduce the size of the tube.
Yes, sir.
इसको मैडम 6 नंबर अनकफ कर दीजिएगा. इसको 6 नंबर की अनकफ. हाँ, reduce it to 6 number. Today, हाँ, today only. कौन? अच्छा. हाँ.
Gradually, you have to reduce the size of the tracheostomy tube.
किनको? अच्छा अच्छा, आपकी फ्रेंड है. हाँ, नेडोक्सिन लगाते हैं, मिप्रोसिन लगाते हैं, गाम नेगेटिव डोंट करना।
Thank you very much, sir, for nice demonstration.
अरे सरवन, तो हमारा लैपटॉप कहाँ था? वहीं रख दिया था ना, चेंजिंग रूम में है ना लैपटॉप। मैडम चेंजिंग रूम में लैपटॉप रखा हुआ मेरा, चेंजिंग रूम में लैपटॉप रखा हुआ, तो लो जेली दे देना, जेली। नहीं है, बस बेटा। हल्का सा स्निफ करना अंदर। फाइबर ऑप्टिक कनेक्ट करो प्लीज। बेटा ये बाद में समेटना, सुन लड़के एंडोस्कोपी करते हैं ना, इनोवेशन जाएगी। हाँ, पे एंडोस्कोप दे दो सर को, कनेक्ट करते हैं कैमरा लगा के, वीआईपी इमेज दे दो, वीडियो उधर लगेगा सर। मैं लगा दूं सर, दिस वाज अ वेरी गुड केस। हाँ, मैनेजमेंट वाज स्ट्रेट फॉरवर्ड, कैमरा लगा हुआ है, कनेक्शन आ जाएगा। बेटा आप उठना, आप एक मिनट थोड़ा पीछे कर ले शालिनी। लगा दिए, लगा दिए। इसका कैप कहाँ गया बेटा? वो सर कैप कहाँ गया? हिला रही है, लड़कियां खड़ी हो जाएंगी तो ऐसे यही कनेक्ट होगा इसमें। हाँ बेटा, ये इसमें लगेगा बेटा। श्रवण नहीं, श्रवण कुमार महाभारत से। ई बोलो, ई कुछ नहीं है मैडम, नथिंग, नॉर्मल है। लंबी सांस लो। नहीं, पीछे पीछे। हाँ, नथिंग इज देयर। ई बोलो, ई लंबी सांस। Right edge little bit irregular. Right edge little bit irregular, mid part. Can you see that small micro nodules type of? Right side में E लंबी सांस। नहीं हो रहा। E क्या वोकल ओवर यूज करती हो क्या वॉइस? ओवर यूज ऑफ वॉइस? अच्छा,
नहीं यहाँ क्लीन कर दो, यहाँ सिंक है, वो दे दो। आइए यहाँ बैठ जाइए, इनके लिए कोई फ्लेक्सिबल डाल दे।
हाँ वो कर लिया, जली दे दो, जली।
जल्दी दे, मैं मैडम को बुला रही है, गीता मैडम को।
स्निफ करिएगा, अंदर खींच लीजिए। नाक से सांस लीजिएगा। ओहो, ई बोलिएगा, ई से ई। लंबी सांस। एनबीआई करो। ब्राइटनेस बढ़ाओ। सांस लो करिए, चेंज होगा। ई बोलिएगा। वो देना फिर से साबुन। नहीं, ये लोकल में लगा के जाऊंगा मैडम। हाँ हम आ जाएंगे। स्मोकिंग तो नहीं है? अच्छा, और आपको एक्चुअली क्या है ना, वो एसिड रिफ्लक्स हो रहा है और
प्रॉब्लम तो नहीं है, पब्लिश होने में चार्जेस यहाँ ले लीजिए फोटो, हम लोग किधर से कमी नहीं आ जाती। दीपांकर तुम भी आ जाए, तुझे बग वहाँ से ले लीजिए, ये सब आ जाएगा। स्टैंड दे करते हुए एंडोस्कोप ले लो।
ठीक है, हो गया।
एक और थैंक यू। क्या है सर इनका मैनेजमेंट?
इनका सीडो सल्कस है, कॉर्ड के नीचे लेफ्ट कॉर्ड पे एडिमा है, और ऊपर सुपीरियर सरफेस पे भी है,
तो
बट नहीं, he has to be kept on PPI for 3 months and alginate आता है, Gaviscon syrup half an hour after meal 10 ml Gaviscon। मैं इसको बोल देता हूँ, लिख के देंगे।
सर क्या क्या बोलना है? गेविस्कॉन और टेस्ट वर्ड्स थोड़े से कई बार डिस्टर्ब हो जाते हैं। और क्या देना है? ये लोकल सर आप लगाएंगे, लोगों को दिखाते हुए मैं डील आप लोकल लगा के आएंगे। बढ़िया है, बहुत बढ़िया। अब तो एक्सेप्टेशन आपने
नहीं नहीं शंकराचार्य
आप सीखने का सोचते तो बाकी सब भी जुड़ते जाते हैं। बैठ के सोच लीजिए आप यहाँ अभी एक छोटी बच्ची भी आई है, 5 साल की है, सबग्लॉटिक स्टेनोसिस है, उसका असेसमेंट बताएंगे पोस्ट कार्डियक। तो साइज छोटा जा रहा है एंड और क्या है कॉलर 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 लगाएंगे।
हेलो कविता, ये माइक
आप ही बोलो सर। हेलो सर, आप प्लीज डिमॉन्स्ट्रेट करिए कि आप क्या लैंडमार्क यूज कर रहे हैं, कैसा लोकल लगा रहे हैं और प्यूबोफोनिया प्लीज सर। और बाहर कोई सुन रहा है तो अंदर जाके बोल दो कि सर आप माइक पे बताइए। ओटी प्लीज।
Hello. Hello.
Hello. Yes, sir.
बेटा बाद में हाथ मत उठाना है ना.
So
So this is not the ideal position for the surgery, but I am making the patient more comfortable. So I am doing in neutral position. Otherwise, most of the thyroplasty are done in extension position with the shoulder beneath the pillow below the shoulder. So what are the landmarks? Landmarks are very common. This is the procedure for this patient. He has got Pubophonia.
Yes, sir.
That is female voice, and he has to undergo type 3 thyroplasty. So type 3 thyroplasty, the important landmarks for local infiltration for any thyroplasty is all the three cartilage, you have to know it, and the local site of infiltration is middle part of the thyroid cartilage. So what I am feeling is, can we have a pen? Yeah, pen is here. Same marker will use later. So the important landmark is, this is a notch. Pen है कोई दूसरा? So here is the notch, and this is the, अभी नहीं चाहिए मैडम, बाद में चाहिए होगा, आप इसको मत दीजिए, निकालिए नहीं. You will need another marker now. This is unstyled, na? So this is the superior border of the thyroid cartilage.
Yes, sir.
And if you extend a little bit, now this cricoid has become prominent.
Yes, sir.
So this is the level of the cricoid. Can you see this?
Yes, sir. We can appreciate.
Yeah. So this is the notch, and if you feel it here, there is a little bit depression is there, and this looks like the lower border of the thyroid cartilage. And if you palpate it just above the notch, you can feel there is a hard bone also there.
Yes, sir.
So hard also will have greater cornu and a
Lesser cartilage.
lesser cornu like this. So this is hyoid, this is thyroid, superior border of the thyroid cartilage, and you have to remember the midline here and here. Midline is very important for any surgery you are doing, like tracheostomy and like that. So the site of infiltration is mid part of it, because we are not doing the type 1 thyroplasty, so we are not going too much laterally.
Yes, sir.
So our dissection will remain in the midline. So I have infiltrated 1 ml. Now I am going little bit on the notch side, because we have to go up to the thyroid notch area also.
Standard solution of 2% xylocaine with adrenaline, sir?
Yes, sir.
Yeah.
And there is no sedation, nothing is to be given. Patient
Yes,
should be talking.
Yeah.
I'll show you type 1 also, just to demonstrate you on this patient, the landmark for type 1 thyroplasty.
Yes, sir.
But we'll be doing only type 3 only in this patient, and it's so this is the lower bottom side, which is a sensitive part of the, and also a vascular part, because here the part painting from here to here. Apply some tape here. Microphone यहाँ लगाना नीट कर आप बैठे रहो, यहाँ टेप लगा देना, यहाँ तक पेंटिंग, यहाँ तक पेंटिंग. Pardon? हाँ, but face खुला रहने देना. He has to breathe, ना? Don't cover the eyes. मेरा assistant आ जाएगा तो समझा देंगे. We'll do it. He'll be talking, है ना?
How much infiltration do you do, sir?
Around 5 to 10 ml.
5 to 10 ml.
I think this much is more than enough.
Yeah, that's.
Or we'll keep one 1 ml syringe with local ready. So if we need it, then we can inject it at the time of surgery. इसको फेंक देना. Use a new marker, है ना? So I'm coming there only. Just.
Back to the home college. अभी आपको welcome भी करेंगे. So it's nice that we are having Dr. Baupachi. And we are having eminent otolaryngologist from Sagar, Dr. Nanoria sir, जो AOI के past president हैं. And बहुत सारे PGs आए हुए हैं. Sir, are you coming to the auditorium? Srivastava sir? We welcome you, sir. Diksha, please take over.
A very good morning to all of you. I am very pleased to welcome all of you to Laryngology Workshop 2022, organized by Department of ENT, Netaji Subhash Chandra Bose Medical College, Jabalpur, AOI Untitled Chapter, and AOI Jabalpur. I am very excited to see all these surgeries, and I would also like to welcome the our chief guest, Dean Ma'am, Dr. Geeta Goyal Ma'am. I would like to request Dr. Kavita Sachdeva ma'am to kindly welcome Dean ma'am.
Dean is the inspiring part. Dean
Thank you so much, ma'am, and thank you so much for supporting this event. And now I would like to welcome Dr. Ashish Sethi sir, head of the Department of Anesthesiology. Sir has supported this event, and in general he is a very supportive personality. Thank you so much, sir, for being here. And now I request Dr. Anirudh Shukla sir to kindly welcome Dr. Sethi sir. Thank you so much, sir. I would also like to welcome the NMC observer is here with us. I would like to request Dr. Mahmooda Sultana Nizam to kindly welcome sir. Thank you so much, sir, for being here. Now I would like to address I would like to welcome Dr. Natwar sir, head of the Department of Anatomy, where we welcome you, sir. Thank you so much for gracing this occasion with your presence.
You are always a strength.
I would also like to welcome all the faculty members and all the dignitaries who have. I would also like to welcome Dr. Nandhoria sir. Sir, thank you so much for coming.
From Sagar, he is coming, eminent surgeon, past Thyroid resident. I would like to welcome Dr. Vidyarthi and please.
Thank you so much, everybody. I would like to welcome all the faculty members and the senior residents and my junior residents and colleagues who have taken the time and attended this conference. We have some very senior faculty members also which have come across from different cities. I welcome all of you. Now, let us all begin with the blessings of Goddess Saraswati. And let's begin this ceremony with the lamp lighting. I would like to request all the dignitaries, Dean ma'am and City sir to kindly come and do the lamp lighting ceremony.
आइए डॉक्टर ननोरिया सर आइए डॉक्टर नटवर
On behalf of AOI MP chapter, AOI Jabalpur and ENT department, I welcome you all to Laryngology 2020-2022. Honorable Dean Ma'am, respected Secretary Sir, our Chief Operating Faculty, Dr. Atresia sir from Lucknow, Dr. Ashish Secretary Sir, Dr. Natwar Agrawal sir, Dr. Vidyarthi sir, and I welcome you all. So, institutional commitment, departmental dedication and delegate participation make it possible for any scientific event to be happen. And when I was a postgraduate, I always felt the need that there has to be a better way to learn and facilitate learning, because we all in the old times struggled to see the surgery. Microscopic laryngoscopy was very difficult to see, and the technology was of that time. So I always wanted to learn. I wish some clarity on the final details of this intricate surgeries of vocal cord and airway. When we see a small child with stridor, you think, what should we do? Why are we helpless? MS करने के बाद भी हम helpless क्यों feel करते हैं? So that desire, this pent-up desire to learn this intricate, delicate surgery and to learn this function and all the stuff from and changing this shift from microscope to endoscope has probably made me keep this topic of laryngology. And we all are here to learn. I am also learning, we are learning, sir is teaching and sir is learning. So I am very thankful that Dr. Rakesh Srivastava sir, when I called him, he agreed on one phone call. So I am very thankful, sir, to come to Jabalpur and you are teaching all the faculty members with interest. You are telling us the finer tricks and tips to learn. Now this transmission was possible, and the more important thing that not only we 50 are learning the surgery, the YouTube link is shared in the national forum and many PGs will be learning, and I think it is first few steps, and now I can see most PGs to take up this laryngology and airway as a difficult topic, and it will become a simple topic for us. Now we have a very dynamic being, Dr. Geeta ma'am, and she is just helping. Acha, ye kar lo, wo kar lo. So we are also running with her, and she is giving us enormous opportunity to work. Our superintendent is also helping us a lot with human resources. Dr. Sethi हमेशा खड़े रहते हैं, चाहे mucormycosis हो, चाहे छोटी सी foreign body हो, he is always lending his support. This hall is his, but he is always giving it to us. So I am very thankful to Sethi sir and his team. Now this event was made possible with AOI Jabalpur President Dr. Sameer. Dr. Pathak is a senior member. Dr. Sumit Kumar is our secretary. Again, he is working hard to make it possible. Dr. Nitin was constantly providing me the basic important things, the patient which are deserving, because I will tell you, your patient, 15 patient आए थे हमारे पास, and when we told आपकी surgery करना है, they all are having some psychologically imbalanced type of attitude. कभी हाँ, कभी ना, कभी हाँ, कभी ना. उस चक्कर में हम लोग की नींद उड़ जाती थी कि हमने जो पेशेंट सेलेक्ट किए उनका क्या होगा. Anyway, today we have lined up 6 new beautiful cases, and only thyroplasty type 1, but we are planned with elastic block is not possible. Otherwise, we are doing all. Sulcus vocalis video will show, but fat injection case has also denied yesterday only. So I think with this workshop, we will all enhance the management of airway and voice. And thank you all for coming and making this event possible. Thank you, delegates. Thank you, my PGs who are willingly, actively working. Thank you all. Thank you, dear ma'am and councillor.
Thank you so much, ma'am. It was indeed a pleasurable moment for all of us. Now, I would like to request Dean Ma'am, Dr. Geeta Queen Ma'am, to kindly say a few words of support and encouragement.
A very good morning. Good morning, sir, and thank you for coming all the way from Lucknow. Thank you, NMC Observer, and I'm sure you'll like the workshop. Like Kavita has said that I am running and I'm making all of them run. Very truly said, as everyone who resides in the city knows that I am a sprinter. So it's been a sprint of almost 5 months now through the Dean's office, doing work probably that would have been done in 2 years in 5 months. And that was possible only because I had some awesome after getting my dean's order as him, because I think he had been telling me this for the last 10 years that you have to be the dean. So, I sat on the dean's chair with a simple dream that even if I rise 5 millimeters over the ground is going to slip beneath me. So I'd have to stay grounded. And like I was just telling him, every morning I tell myself, भगवान ने एक दिन और दी है सबके सेवा के लिए, तो सबकी सेवा करनी है. और शायद आज मैं 2 जन के लाइव्स को डिफरेंट वेज में टच कर पाऊँ, और ऐसा भी मुमकिन है कि आज मेरा आखिरी दिन हो इस तरह से सेवा करने की. तो अगर मैं 2 लाइव्स को टच कर पाऊँ तो मैं कोशिश करूँगी तीसरे लाइफ को टच करने की. शायद मुझे कल वो मौका ना मिले कि मैं इस तीसरे लाइफ को टच करूँ. So this is keeping me going, and I am really overwhelmed at the way I have been accepted. I think it has to be a rare phenomena that in 5 months' time, people senior to me, people junior to me, I think 80% of the campus just comes and hugs me. It's lovely to have a dean like you. So all that blessings comes from you all. Thank you for all your blessings. Thank you, sir, for always believing me. And thank you, everyone. And thank you, Kavita. And thank you, all my colleagues and wonderful postgraduates for whom I really wish to make the change as much as I can in whatever period God has destined me to serve you. Thank you, and thank you so much.
Thank you so much, ma'am, for the kind words. Now, I would like to request the head of the Department of Anesthesiology, Dr. Ashish Sethi sir, to say a few words, please.
Yeah, so I'll just make it, short and sweet. I would like to thank the, learned faculty, Sir Dr. Srivastav, who's among us from Lucknow. And I would like to congratulate the Department of ENT of NSCB Medical College under the dynamic leadership of Dr. Kavita Sachdeva, who has been doing phenomenal work. She did, as we all know, she did fantastic work during COVID-19, handling the surgical management of mucormycosis, in which we supported her, and she was, and thankfully so, in other aspects of, she's been working towards improving the learning curve of the ENT practitioners of the city of Jabalpur. And I congratulate her, and I congratulate the Department of ENT, for doing so. And I wish all of you present here a very happy learning experience, all the postgraduates, the faculty, ENT practitioners of the city of Jabalpur. I wish you all a very happy learning. Thank you so much for having me.
Thank you so much, sir. Now, I would like to request the man of the hour, our chief faculty member, Dr. Rakesh Srivastav sir, to kindly say a few words.
Respected Dean Madam and CMS sir, Professor Sethi, and head of the department, Professor Kavita Sachdeva, and all the senior faculty here, and all the students. Warm regards from me. I am really happy and feel great pleasure to be here in Jabalpur Medical College. And I'm always be ready to teach whatever little I know about the airway. And airway is my passion for last 20 years. And even in coming week is very important for me because Tuesday I'm going to present my airway project to the government of UP. So I hope I'll able to serve the poor and the patient who really needs this type of care, specialized care. And my lesson, the teaching to all my juniors is take this specialty, laryngology. It's upcoming specialty. When I have chosen it, I shifted directly from otology and endoscopic sinus surgery. 15 years back, my contemporary at that time was Dr. Sachin Gandhi, who motivated me and bring me to this specialty. Now I shifted from laryngology to airway. Now after the age of 55, now I'm shifting to pediatric airway. So what my father used to tell, because I am from MP only, because my father was graduate from Gwalior Medical College 1954. And my whole family is in MP, from Indore, Ujjain, Bhopal, and few from Gwalior. So 40 साल तक सब कुछ करना, 40 से 50 साल के बीच में एक चीज करना, फिर 50 साल के बाद ऐसा करना कि जो दूसरा ना करे. So with these words, I motivate all my juniors to join this specialty, and whatever help you need it from my side, I'll always be there. Thank you.
Thank you so much, sir. We wish to even accomplish and learn what you are teaching us, even half of it, if we are able to incorporate it in us, then it would be a blessing. I would like to request Dr. Geeta Goin ma'am, our dean, to kindly give trophy to Dr. Rakesh Srivastava sir. Thank you so much, ma'am, and thank you, sir, for giving us this opportunity. Now, I would like to request Dr. Kavita Sachdeva ma'am to kindly present the memento to Dr. Geeta Goin ma'am, our dean. Thank you, ma'am. Now, I'd like to request Dr. Anirudh Shukla sir to kindly present the memento to Dr. Ashish Sethi sir, the head of the Department of Anesthesiology. Now, I would also like to request Dr. Kavita Sachdeva ma'am to please present the memento to the NMC observer. Okay, sir, Nanoria sir, please kindly give the memento to the NMC observer.
Please fill in the NMC feedback forms in the evening because you will get the points after filling the certificate and feedback form. But I cannot issue certificate of 4 points. Okay, thank you. And
Thank you so much, sir. Now, I would like to request the team of AOI Jabalpur to please come here and accept. everybody. Thank you so much, sir. Now, without
अभी Pubophonia चल रहा है. I like to welcome Ritu Punurmati. Dr. Mamta, please come forward. पहला केस इन्होंने यूज कराया. मेरी सारी सहेली. We are batchmates also. डॉक्टर बाहर से कितने लोग आए हैं? अरे ये लोग चले गए विद्यार्थी सर. क्या मतलब है तुम्हारा लाइट आने का? सब बैठ के चले जाएंगे फिर डॉक्टर से ले रहे हो. क्यों चले गए? आपने देखा विद्यार्थी सर?
नहीं एक्सटेंशन शोल्डर के नीचे क्यों नहीं अपडेट तुम्हें इधर आना चाहिए इंस्ट्रूमेंट मेरे को चाहिए होगा एक डिटेक्टर रेस्पिरेटरी डिटेक्टर लिया नहीं लिया मार्कर दो मार्कर हेडलाइट दो मैंने आपको कहा था ना एक मार्क
हेलो
यार ऐसा करो या तो माइक्रोस्कोप की लाइट लगाओ माइक्रोस्कोप की लाइट लगाओ बस लाइट लगाओ क्या तुम्हारा इसमें लाइट आ रही है हाँ बढ़ा दे यार मैं फिर हेडलाइट लगा दूंगा हाँ थोड़ा सा इधर फोकस करो जरूरत नहीं है मेरा हेडलाइट की है ना हटा दो ये लाइट कैप ठीक कर दो
क्या बोलते हैं एक बार सिस्टम बंद करके ये ट्रॉली आप ऐसा करिए इधर ले आइए
हाँ इधर लाओ ना इसका उल्टा लगाए हो ट्रॉली इधर लाओ हम घूमेंगे थोड़ा ना बार बार वो क्या मार्कर कहीं ड्राई करो क्या नाम है बेटा आपका संतोष यादव बाइपोलर यूनिपोलर सब काम कर रही है नहीं यार वर्कपीस से खेल दो यूनिपोलर नहीं आई थिंक थोड़ा चाहिए मिल जाएगा बहुत अच्छा है बाइपोलर का कहाँ है फिर पहले इधर दीजिए उधर नहीं हमारे पास दीजिए यू आर रेजिडेंट ना आप इधर हो नहीं आप इधर हो बताओ No, artificial. Skin hook. पीछे रखो ना छोड़ बेटा इधर आ जाओ भैया को दो भैया को दो हाँ मेरे को दो
Hello.
Yeah, I am dissecting a
Sir, the
subplatysmal plane.
picture is not clear, sir.
Can you getting the picture?
No, no, sir. There's some.
You are not getting the picture? अरे भाई काल स्टॉप
Sir, camera is not focused properly.
हेलो सर, वीटोम फोकस नहीं हो रहा है और किसी का हाथ आ रहा है वहां बीच में, जो रिट्रैक्ट पकड़ा है ना, रिट्रैक्टर. नाउ इट्स क्लियर.
क्लियर बेटर
Yes,
Not
sir.
better?
Better. Yes, sir. Better.
हेलो सर, स्टेप्स बता दीजिए एक बार क्या किया सर
I
आपने.
am just elevating the subplatysmal flap.
Okay, so the plane is
Identify-
subplatysmal, right?
So I have identified the anterior jugular on both the sides.
What is the width of the incision size? कितना है सर? Roughly 2 centimeter, 3 centimeter.
3.5 or 4.
Okay, okay. And it is a mid thyroid incision we have given. है ना?
Mid thyroid
Right.
cartilage.
Right. So the landmark are same. Okay. So later on we can discuss the pubophonia surgery decision taking criteria.
Yeah.
Right. So we had 3 patients of pubophonia and all were right candidates, 17, 18 years old.
On tooth. ये होल्ड करो बेटा ये होल्ड करो देखो रिफ्लेक्टर तुम्हारा गिर जाएगा रिफ्लेक्टर तुम्हारा गिरेगा सर कौन सा ये रिफ्लेक्टर पेन तो नहीं हो रहा है पेन होगा तो बताइए रुक जाओ So I am dividing between the jugulars. So now almost I have divided between the jugular. I'm going to put the asteroid detector there. Yeah. Take care. Rain में ना बदलो। So we are using minimal exposure, giving some local. Some local. Have an infiltrate in the muscle plane. अभी शांत हो जाएगा बेटा जल्द। Some more. और देखिए।
So what precautions we should take when we are raising the flap? Like they should not be raised too laterally or something like that?
No, it is midline only. It is very simple
Midline,
thyroplasty.
right. Okay, so
One
it
of
should
the
not be...
simplest thyroplasty.
Okay, so your plane is right now the sternum strap muscles only. You have not...
Yeah.
Yes.
That is also we are not going to cut it. We are not doing anything laterally.
We are just giving incision and going to the depth.
Yeah.
Right. पीजीज आप लोग को कुछ पूछना हो तो प्लीज पूछो क्योंकि आप लोग पूछेंगे तो इंटरेक्टिव सेक्शन ज्यादा होगा।
No, I do it like that. अच्छा। ये लो। हेलो। घबराओ नहीं बेटा, कुछ नहीं हो रहा। तो skin up. So now I am feeling the notch. अरे चुपू क्या कर रहा है? Why? No. ये हिलाओ नहीं बेटा। ना बाइपोलर को जल्दी नहीं कर देते। बहुत बड़ी है ये बाइपोलर, छोटी नहीं है। हिलाओ नहीं बेटा। ये देखो।
Sir, how is the cooperation of the patient? You have given any pre-medication?
Yeah, I have given a little bit more local.
Local. Okay. And no pre-medication, atropine or something like that? No. Okay. So this is the cricothyroid level, which is having some troubleshooting.
Yeah, there's a vessel is there.
Okay.
Hello? हमारे हाथ में है, मेरे हाथ में है। काफी नहीं है। करो। करो। एलिवेटर। किनो? ये छोड़ दो। Detector. So this is a notch. You can see it. Give me one detector. Hold it this way. This way. So now this is very important part. Now we start from superior to inferior. हिलाइए नहीं बार बार है ना?
Sir, what plane are you doing? So above the perichondrium, mucoperichondrium.
We are not elevating the mycoperichondrium. देखो दोनों इक्वल प्रेशर लगा हुआ है ना, एक जना ज्यादा लगा रहा है, एक जना कम लगा रहा है। अब नीचे दिखाओ, नीचे से शिफ्ट करते जाओ, नीचे शिफ्ट करो। हाँ, like that. So we are going 5 mm from the, अरे यार ये क्या है, ये बना क्या हुआ है?
So this surgery sir is doing under LA. So Soumya, see to it that fiber optic is shifted to OT2.
No need for fiber optic in type 3.
Okay.
Only in type 1 we require.
Right, sir.
Only if you have damaged the inner perichondrium, then it is you require it. Otherwise, so this is the inferior border of the thyroid cartilage. ठीक से रिट्रैक्ट करो ना, कायदे से ठीक से रिट्रैक्ट करो, बड़े वाले से। हाँ, ये बड़ा वाला ठीक है, छोटा छोटा लेके बैठो, ये दिखाओ, रिट्रैक्ट करो इधर। हाँ, so this is the inferior border and this is the inferior border. माफ करो, watch this. This is one of the simplest thyroplasty. So now we are measuring it. How we'll measure it? I'll just show you. कुछ मत करो, कोई रीडिंग नहीं है, leave it. माफ करो। So this is the midpoint, and here is the midpoint. Give me one caliper is there. तुम लाई नहीं हो क्या अपना? एडजस्टमेंट कौन डाला? अरे तो करने तेरे को तो पड़ेगा ना, नापो कैसे? देखो उसमें वो ठीक है, ऑटोक्लेव नहीं होगा ना, देखो उसको मत यूज करो। गिव मी ए पेन scale. So this is the notch of the thyroid cartilage. Hello?
Yes, sir.
Here you can see it. Yeah. And this is the detector देख रहे हो हम focus कर रहे हैं. And this is the inferior border of the thyroid cartilage. So our in type 3 thyroplasty, our incision will be lateral to the 3 mm from the midline. So बस इधर छोटा छोटा बनाओ ना, पैटी दो बेटा यहाँ रखो. बस ठीक है.
Welcome, sir.
So
Madam is also there.
So now the lateral cut is 3 mm from the midline. Some people keep it as a 5 mm, but 3 mm is more than enough.
I request Kavita ma'am to honor Arvind Sharma sir. Thank you for coming, sir.
इसको सीजर देना, सीजर दो, ये बड़ी वाली सीजर दे दो. So 3 mm from the midline. एक और देना सीजर. तो देना है ना स्केल, इतना काट दिया हमने. इसलिए कहते हैं कैलिपर इज मोर यूजफुल. तो 3 mm और मत करो. Actually, the problem is this thing has to be done with the caliper, but we don't have a caliper here. I am doing it, measuring it with the scale itself. Around 3 mm. Yes. Give me a blade. Doctor. Give me an elevator. Elevator. So 3 mm on either side of the midline. पकड़ के रखो ना, बार बार लूज क्यों कर रही है? Don't make it loose, है ना? लो, great. Resection करूँगा. So the incision should go through and through cartilage, but one should take care that we should not damage the inner perichondrium. So this side the incision is given. Now we are shifting to the other side. और जोर से नहीं. आप उधर टीवी पे देख रही हो.
आप जीना छोड़ दीजिए, हम कर जाएंगे.
Good afternoon, sir.
Yes.
Sir, I'm a resident from MGM Medical College. Sir, my question is how deep this incision should be to prevent injury to the inner perichondrium, sir?
That you have to learn it gradually once you know it. I'll just show you how you can use a micro ear instrument, your flag knife and ear instrument. Flag knife and those things.
Okay, sir.
This is too big. ये बड़ा है. Ear instrument. I told you that time. So you can do is you just see the lateral part I am elevating. Now you see this already been elevated like. Can you appreciate that?
Yes, sir.
Part of it has not been cut. ये marker हटाओ ना यहाँ से क्या है? Plaster, servo section. यार देखो ना क्या प्रॉब्लम है. ओके क्या कर रही है तुम? तो दो. अच्छा ये है. नहीं तो दिया. बहुत बड़ी है यार. इससे छोटी नहीं है तो. ये तो पता नहीं है प्रॉब्लम. Yeah. भैया बेटा दिखाओ ना. आप उधर देख रही हो टीवी पे. आप इधर देखो. इधर देखो. इधर देखो. What I need. Now give me elevator. 7 wala 90-degree elevator. So now I have elevated the lateral part of it. Now this middle segment can now go in, and now I have to check the patient without the pressing it. नाम बताइए अपना. Without doing anything, now we can. Hello. Hello. Hello.
Sir. Sir.
Yeah.
Hello.
Yeah. Who's there?
Yeah, Dr. Nitin was there, sir. I'm giving him. He's having a lot of experience.
Dabani. So I have elevated on either side 3 mm. I have given a cut on the midline, right and left side,
Yes, sir.
without interfering with the inner perichondrium.
Yes, sir.
So what happened is the middle part has already synced into it, and now without doing anything, the patient has got improvement in the voice. Now you listen to the patient voice. I hope they have played the audio of the patient before the surgery.
Yes, sir.
You must have listened to the audio of the patient. Now you listen to the patient voice. अपना जोर से नाम बताइए.
संतोष यादव.
Can you listen that?
Yes, sir.
1 2 3 4 10 तक गिनती है जोर से.
1 2 3 4 5 6 7 8 9 10.
Now you can listen.
सर पेशेंट से पूछो तो उसको चेंज मिल रहा है कि नहीं.
आपको संतोष जी कुछ अंतर लिख रहा नहीं लिख रहा है?
दिख रहा है सर.
कैसी लग रही है आवाज? अमिताभ बच्चन वाली?
मोटी है पहले से.
हाँ आदमी जैसी लग रही है ना.
ऐसा.
अच्छा
सर बधाई हो. अच्छा लग रहा है. ऑल आर अपलॉडिंग
So,
इट. गुड सर्जरी.
yeah.
वी आर हैप्पी.
So he doesn't require any midline suturing. There are different techniques for it. Initially, when I did my, I think, second type 3 thyroplasty, that time I was using silicone block also to do the adequate compression over the mid part of the thyroid cartilage. So my technique was that time
So you will not suture.
Putting a silicone here, then taking a proline from here,
Right, that was the old technique.
passing it through the silicone block, then taking another suture like this from here,
Right.
and then tightening it like a instrument, musical instrument. You are doing it.
Okay.
And then when the patient says, I am satisfied with the voice, then we do the tightening of the suture. So that time. But I think with this technique, he doesn't require any suturing as such.
Only you have done collapse of the medial part, and that has led to improvement.
That has gone early synced into it. And if you press more, then he will have a more heavy voice, which is not suitable for
young boy.
His age of the. So he will have a voice of something like 45, 50-year-old person.
Sir, can I ask you one thing?
Yeah.
Anything like if he presses the anterior after healing, will something happen, or will the voice change if he compresses?
Even the healing happens because ossification starts from laterally, posterior-inferiorly from the thyroid cartilage, and it goes anteriorly. So this will remain as a cartilage till I think at the age of 45, 50 years.
So we are done with it.
Because you are done with it, and that even if the healing happens, it will be above that area. And that middle part has already synced into it, that healing will not take place like that. It will overlap like.
Thank you, sir.
So without suturing it, we can leave it like that, and then we suture the step muscles and like that, and we finish out this case.
Any drain to be kept there?
No. Because we have not damaged any vessel. We just check it. Whether he was
रिचा नेक्स्ट केस लगवा दो बेटा. कौन सा लगा रहे हो? वोकल पॉलिप? सर से पूछ लो.
And regarding mutational falsetto, the transgender surgery, you can post second case. You know?
This is a Karl Stoll's V-tome which we have got for this surgery, and I think this is helping us to demonstrate.
Few images. Yes, sir. So,
Sir, आप transgender surgery
I was talking about the transgender. There is an article by me on Indian Journal of Plastic Surgery. It's a review article on transgender. So what transgender we do is, we do type 4 thyroplasty. So male voice in a female patient to convert it into female voice. So for that we need is the tensioning of the vocal folds. So for tensioning of the vocal fold, the main muscle which is involved is cricothyroid muscle. So this is a type 4 thyroplasty. There are other procedures, endoscopic procedure, which can be done in patient with transgender. So what in type 4 what we do is, just a minute. So what we do is, you have seen it here. So our incision will be little bit on the lower part.
V-tome को focus करो cameraman.
हाँ थोड़ा नीचे कर दो. हल्का सा नीचे करो.
So sir is telling from female voice to male voice कैसे बनेगी?
No, male voice.
Male voice to female voice.
हाँ. नीचे. ये. So incision will be at the cricothyroid area. That is between the thyroid and the cricoid cartilage. Same incision. Then we separate it like midline without damaging the anterior jugular. And what we do in type 4 thyroplasty, there are 3 things which are very important. 3 things which are very important is, we should not go too laterally, because if you go too laterally on the cricoid, then you will damage the cricothyroid muscle, which is the most important tensor of the vocal fold. Second thing is freeing the membranous part of the cricothyroid area. That you have to free it, because you cannot, the type 4 thyroplasty is basically cricothyroid approximation. So once you approximate the cricothyroid cartilage, what happens is thyroid cartilage tilts back. It tilts back and it tilts the posterior part of the larynx, and that is how it stretches the cricothyroid muscle. So once you approximate cricothyroid area, so that we only be approximated once you free the cricothyroid. In between the cricothyroid, the membranous area is there. So ligament is there. So that ligament you have to free it, and then you have to take a thick suture, either proline or what we used to take, मोटा वाला जो suture लेते थे, और ethibond suture. So ethibond 20, you take it from the lower border of the cricoid cartilage, and then take it out from outside in. From outside in, you take it out between the cricothyroid membrane, and then bring it over the lower border of the thyroid cartilage. So from the lower border of thyroid cartilage, there are chances that it may cut through. So to prevent the cut through, we take a small silicone block to prevent the cut through to the thyroid cartilage, and then we bring it from outside of the thyroid cartilage, then out from the cricothyroid membrane, and then we tighten the suture. It will be like going from outside lower border of cricoid cartilage, then coming out between the cricothyroid membrane, and then from outside going down to the cartilage, thyroid cartilage, and then coming out between the cricothyroid membrane, and then tightening the suture. So then only it will get approximated. So the thyroid cartilage will tilt back, and this will stretch the vocal fold. When vocal fold is stretched, the lengthening happens. The pitch will go automatically to higher level, which is a female voice. So that is our aim of surgery, and that is known as type 4 thyroplasty. So disadvantage of type 4 thyroplasty, the type 4 thyroplasty, there are 50% chances of failure. The reason for failure of type 4 thyroplasty is because on long-term follow-up, like 18 months or more, sometimes this suture give away. It becomes loose. So cricoid goes down and voice become again a male voice in a female patient. The other reason of failure is the cornu of the inferior cornu of the thyroid cartilage, it attaches over the lateral facet of the cricoid. So that joint is mostly a synovial joint, but this is a very unstable joint. So sometimes because of the instability of that joint, there are chances of failure is there. So there are various studies on CT scan which demonstrated that which case is going to fail, which is going to succeed. Now coming to the other procedure, which is I am started doing it. I think Dr. Nupur is also doing the same procedure nowadays. That is known as endoscopic Wandelaar glottoplasty. What is Wandelaar glottoplasty is? The Wandelaar glottoplasty is we freshen the anterior 1/3 of the vocal folds on both the sides. So once you freshen the vocal fold, and then you suture both the vocal folds in the anterior 1/3. Either you can do it with the laser or you can do it without the laser. So vicryl suture, we use it, 2 vicryl suture to approximate the anterior 1/3 of the vocal fold. So that also improves the pitch of the raise the pitch of the patient, and it become a female voice. But the problem with type 3 Wandelaar glottoplasty, that is type 4 procedure for the Pubophonia is not the Pubophonia. For transgender is patient, because you have reduced the size of the glottis, patient will have a reduced vocal throw. If the patient is a singer, then patient will have a problem in singing, because the area of the glottic area you have reduced it by creating a web by suturing the anterior 1/3 of the vocal fold. So endoscopic procedure has got that disadvantage, and if the patient is a singer, then that procedure is not going to. The patient will always complain of reduced vocal volume or reduced throw in the voice, but patient will have a long-term good results using this endoscopic procedure as compared to the type 4 thyroplasty, which is cricothyroid approximation for transgender. और सोचा कर दोगे हैं, इसको मसल को अप्रोक्सीमेट कर देना, ठीक है, ये लगा रहे तो यार लाइट ये हाँ हाँ ठीक है, पहले मसल उसके बाद ब्रेन की जरूरत है नहीं.
डियर फ्रेंड्स, इसका यूट्यूब लाइव रिले हो रहा है. आप लोग सब उसको एक बार ऑन करके लाइक कर लो, थंब कर दो, तो एटलीस्ट आई विल गेट 100 लाइकिंग्स, प्लीज, ऑल ऑफ यू.
हाँ तो ठीक है, हाँ प्लेन। ब्रेडी कार्डिया तो वैसे नहीं है, निकाल लो। नहीं अभी वैसे भी इसको को करना है, फॉक करना है, फॉक करना है ना, फॉक 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 है ज़्यादा ना। पानी लाओ गरम, पहले बताओ, टिप साफ करो। लाओ वो तो सेवलॉन दे दो या तो, देखिए ये लग रहा है अंदर गंदा है।
Hello.
Hello.
Hello, sir. We do not have that endoscopic picture.
Yeah, I'm just adjusting it. I'm not used to this thing na tele. Focus karo.
Microscope with micromanipulator.
No, actually I am used to my the दूसरा नहीं है कैमरा कोई। फोकस कैसे होगा? Where is Olympus? यार फोकस कर दो यार, और मैग्निफिकेशन कम कर दो। अरे ऐसे ही छू लो बस, कोई प्रॉब्लम नहीं है। कोई सिंपल कैमरा लगा दो। हिला रहे हो तुम बाबू। जरा और थोड़ा सा वो करना है, छोटा करना है तो हाँ ये कम करो, हाँ और कम करो बस। सेवलॉन दो या गर्म पानी दो। ये कुछ गंदा है अंदर, ये उल्टी पिक्चर आ रही है क्या? नहीं उल्टा आ रहा था पिक्चर। ये इसका जो शीट है ना, ये गंदा है लग रहा है। ब्राइटनेस बढ़ाओ जरा और फोकस करो। लोकल दो। हाँ लो लोकल देना।
ये इस तरह से होल्ड करिए इसको, आप केवल इसको पकड़िए, यहाँ से पकड़िए और इस तरह से।
पैटी देना। This looks like more like a epithelial cyst. Epithelial. So. लो पैटी।
अच्छा
दूसरी फॉर्सेप दो, ठीक नहीं है। सेकंड लाइफ सेकेंड लाइफ अपटर्न सीजर इसके बाद चाहिए होगा, यहाँ रख दो और तुम्हें दबाना है। हाँ बस, अब फोर्सेप का है ये। ये कुछ नहीं। Oh, this is cyst.
Hello.
Yeah.
Sir.
Actually, I am giving incision with the sickle
sickle.
knife.
Yes, sir.
This looks like a cyst only.
So is the incision always you take here only?
Yeah, I have tried to give it on the superficial lamina propria, the superficial layer of the, and but I think the
vocal cord. Yeah.
Yeah. ये क्या दे रहा है?
And now you are planning to take a flap.
Yeah, I am trying to do it. Bushire left. This is right. This is left.
There is a small contact granuloma, I think, on the other side also. Other vocal cord.
But the initial video which I saw, I think that was not this patient. Some other patient must be shown on the video. And suction. So whenever you are doing a MLS, try to suck over the patty rather than directly over the vocal fold.
Sir, is anybody...
Try not to damage the...
mucosa.
So I am using left push-higher forceps, also known as heart-shaped forceps, also known as samosa forceps, whatever you can call it.
Sir, is anybody holding the scope or it has...
No, it is. I am using the Havas scope by Carl Stos. So this looks like a subepithelial cyst only. ये स्टेट दे दो शायद. I will do it with this only. Like knife. लाई नहीं हो लाओ तो हाँ तुमने कोल्ड इंस्ट्रूमेंट लगाया नहीं है क्या मैं उससे कह रहा हूँ इधर कोल्ड इंस्ट्रूमेंट इज वेरी डिफिकल्ट
Yes, sir.
Very beautiful, sir. मजा आ गया.
बिना प्रैक्टिस देना
Suction.
सक्शन दो
It's a pure adrenaline, no?
हेलो
Hello, it's a pure adrenaline.
या प्योर एड्रेनलिन So some redundant mucosa is there, so I will just check it.
Yes, sir.
For sir. Pushaya.
But will it cover that?
Yeah, I'll just check it. Because there are two ways you have to check it. One is
Yes.
you press it on the vocalis muscle, like this.
Yes, sir.
Pressing over the vocalis muscle.
We can see the muscle also.
Yeah, but there is a mucosa which is hanging, posterior part. You can see this.
Yes, sir.
So just I will trim it, so that is, healing happens smoothly like one scissor.
ये तो हीलर
तुम राइट क्यों नहीं दे रहे हो?
Sir, if we leave this mucosa like this, it will cover the raw area also.
Yeah. I'm decided it. And this will cover our cyst also.
Yes, sir, definitely.
The dead space.
Dead space. Anything to do with the right vocal cord, that small.
I'll just see.
Not
This-
right, left.
This one.
Yes, sir. It doesn't require anything.
It is on the inferior
Vocal
lip of the vocal cord.
Yes, sir.
Nothing you should not do. Okay.
Okay, sir. Thank you so much.
हाँ बस सुन लेते हैं।
फ्लेक्सिबल ना ऐसे टेंशन होगा ना सर ने भी बोली कि 3 महीने तक रहेगा सर कब तक लगवाते रहोगे ये बहुत देना ये तो सेट
ले दो हाँ मैं दरवाजा लगा
नहीं ये कहाँ लगाते हैं मुझे ये तो ये ऑन हेलो जल्दी मैडम
सुलेखा सिस्टर जी आज ड्यूटेन का वो सैंपल कंटेनर आए तो है एक भी नहीं मिल रहा मेरे को क्या सैंपल हाँ सैंपल कंटेनर पॉली पॉली इसमें वो लगाना तो उसको उनको बुला लो कैसे बुला लो साइड रूम से ग्लव्स दे दो ऑन कर लो स्क्रीन फास्ट और साफ सुथरा रखना उनका शेड्यूल गवर्नमेंट एरिया में तो गंदगी करेगी ये बंगाली है रॉयल रॉयल वेरी ब्यूटीफुल
Hello, hello. Ma'am, what is the next case the delegates want to know? Hello, anybody there in the OT?
So we will be having 3 evaluations now. One is a small child post cardiac surgery. She is maintaining saturation at PU. You have to sit on. कपड़ा तो बिछाओ ये बिछाओ बिछा दो सिस्टर ये भी गंदा है दूसरा ला so that small child sir will be doing nasopharyngoscopy उसका 80% saturation रहता है we are suspecting subglottic stenosis she underwent cardiac surgery तो उसका evaluation discuss करना है अपन को nasopharyngoscope करेंगे local में उसके बाद we have a post mucormycosis suspected vocal cord paralysis उसका भी अपन को evaluation देखना है then we will go for botulinum injection on the vocal cord for spasmodic dysphonia and after that we'll have a lunch break.
Okay, nice lineup of cases.
So we have a dysphonia case. You will just hear the symptoms.
You want me to tell? My voice pitch changes when I talk for too long. And by the end of the week, last month, it's not always, but last month, what was happening was that by the end of the day, my voice used to break. And this part, I've never had pain before. Voice used to break, that was okay. This used to pain like a pulling kind of pain, terrible pain over here. But the moment I give voice rest, like say in the weekend, I'm fine, absolutely fine. And I use a mic. So if I speak in this volume, I'm fine. But the moment I talk a little louder, then my voice goes completely.
So we will be doing a strobe for her and we'll see what is the mucosal wave pattern difference. Mike, so she's able to speak.
Mike. So Mike, you feel better because that is happens because of the.
We are not able to get the OT picture.
See, when you had a
We are
cold,
focusing the
when you had a,
endoscope picture. Okay. And then
viral
उस
infection,
OT2 में
something like
ओलंपस
that.
वाले को बोलो
Don't
3.9
overuse
mm
the
फाइबर
voice.
ऑप्टिक लगाएगा.
Avoid to take
ओलंपस
as much rest
3.9
as
mm
possible.
वहाँ फिट कर दो.
Because you will have a post-nasal drip.
और बच्ची को
At
लेना
the
है.
time of post-nasal drip, you are using your voice. Again, the voice will break, and it might become so. कभी भी बोलते हैं कि जुखाम में आवाज का यूज ज़्यादा नहीं करना है, especially viral जब फीवर हो, तो don't try to use it. This is your bread and butter. Yeah. And what has happened is you are using your accessory muscles of phonation. So you are using neck muscles. That is why you have a spasm and pain. By the end of the day, you will have that, and that is why the external jugular become prominent. The vein become prominent. At the time of lecture, with some writing work, then again speak. Take 2 or 3 sips of water, then again speak. Don't try to repeat the sentence. Same sentence. And if you don't have a mic, then try to walk and then take class. Like that. Not like standing at one place.
I use that voice amplifier, so I use it.
Yeah, that is the only way around.
So I noticed this one week.
And the other thing is what you said, LPR, the reflux is there. So reflux may be the posterior part of the larynx, it gets hyper contact. So that causes congestion, and that also is painful because that area of the larynx, the posterior part of the larynx is a sensitive part. It is painful. Otherwise, rest of the airway is not sensitive. So posterior part of the larynx, the arytenoid, where the reflux is happening, silent reflux. So that causes strained voice and painful at the end of the day. And for that, hydration is the one thing. Chai, coffee, cold drink, stop. Then 4.5 घंटे से ज़्यादा खाली पेट नहीं रहना है. Something you must eat. खाने और सोने में, हाँ, खाने और सोने में 1.5 घंटे का डिफरेंस डिनर के बाद. Don't lie down, huh? And overnight fasting should not be more than 12 hours. Pause. Pause is very important for teachers. Pause.
I might gag, I'm sorry.
No, don't worry. Stand.
So we are not getting the endoscopic picture.
टंग निकालिएगा मैडम. टंग जब जी बाहर. बहुत ज़्यादा नहीं बस. हाँ फोकस करो. चलो जी कोई बात नहीं. जीभ निकालो. जीभ निकालिएगा. Normally stroboscopy has to be done without the local.
Okay.
ई बोलिए ई ई ई ई ई थोड़ा वो करो. ई थोड़ा फोकस कर दो हल्का सा. वैसे कॉर्ड तो नॉर्मल है. कहाँ से होगा?
ये रिंग
अच्छा रिंग से.
हाँ बस हल्का सा
आपकी लिपस्टिक छूट गई. मैडम पे करेंगी आपको. नई लिपस्टिक देंगे गिफ्ट में. दे दो यही दे दो.
आपने बोला ना
कोई
मैं
बात नहीं.
सिंगर हूँ. मैं तो मतलब आई कैन नॉट हैव वो भी है. मैं सारे गामा बहुत उसके ऊपर मेरा वॉइस जाता ही नहीं कभी भी.
बॉन्ग सार जी भी करिए. माय वाइफ इज बंगाली सो आई नो दे आर इनटू आर्ट्स. हाँ अब बोलिए ई. हाँ ई लगातार बोलते रहिए. ई ई ई. तो प्रेस करो ना. हमें बोल रहे हो यार. ला स्प्रे दे दो. वैसे तो कॉट आप क्या बोटॉक्स देना है?
नहीं सर इसके बाद 2 पेशेंट हैं. एक ओपन कॉर्ड बच्ची को देखोगे.
हाँ वो तो वही 2 मिनट लगेगा.
नहीं सर उसको करके बोटॉक्स लास्ट.
कहाँ गया फुट पहले है.
हेलो सर बोटॉक्स वाले पहले ले लीजिएगा.
ई ई ई.
So this is the stroke picture you are getting. The mucosal wave
जोर से
movement.
बोलिए. ई ई ई लिफ्ट है पिच. माइल्ड सल्कस है लेफ्ट में. माइल्ड हाँ.
So do we also see a phonatory gap
Mild sulcus
sometimes?
is there, but she is not having an expiratory force.
Hello, Mahmuda, you are asking what are you asking?
Gliding.
So, ma'am, was there a phonatory gap also? Sometimes you could
There
see.
is sulcus. Sir is suspecting slight sulcus.
Okay.
Left side.
That's why this voice. सौम्या हमारी एक रूमिता आई हुई है. उसका ख्याल रखना.
Small groove हो जाता है.
हमारे पास एक भक्त आया हुआ है.
इनको LPR का ट्रीटमेंट. Gaviscon and हाँ बाकी I have explained her how to. 10 ml.
Any other way of 10 ml HS?
हाँ after meal. After. नहीं.
I request the delegates to keep asking questions so that it becomes an interactive session. Nitin sir.
Pause बताया, पानी बताया. हाँ सिर्फ हाँ. Short sentences. हाँ, और घूम के पढ़ाइए, राइटिंग बहुत ज़्यादा दे दीजिए अभी शुरू में बच्चों को, बस अब यही है।
A very popular teacher, how can she speak less? Thank you, sir.
Okay.
Okay. Thank
Okay.
you.
Okay.
Okay. Nice that you came. Sulcus इसका क्या करना है सर?
अभी कुछ माइल्ड है सर।
माइल्ड सल्कस है, तो इसे माइल्ड सल्कस लिख दो, माइल्ड सल्कस।
LPR, LPR।
आप तुमको देख के हम लोग को कॉम्प्लेक्स हो रहा है। हाँ,
अभी देखो थायरोप्लास्टी अगर हो जाएगा तो हाँ, नहीं अभी नहीं कंफर्म, मैंने देखा नहीं है पेशेंट देखा नहीं है मैंने।
मिली कि नहीं? You have got a beautiful girl, जिसको देख के मेरे को
ओके, स्ट्रोबोस्कोपी ना? या। So, regarding the stroboscopy, what we have been doing using a stroboscope. Hello?
Yes, sir. Yes, sir.
So, stroboscopy, as you must be knowing it, it is a strobe light. So, the basic concept of a stroboscopy, the normal image of any image in the retina, it lasts for 0.2 seconds. So we will have, we are not able to linger on that image if it is lasts for less than 0.2 seconds. That is a Talbot phenomena or Talbot law. So if the image is less than 0.2 seconds, it lasts for more less than 0.2 seconds, then it looks like a stable image. And what the strobe light does is, strobe light basically, it's because the vibration of vocal fold is very fast. In a normal healthy individual, it will be around 212 hertz, like that. And male patient, you know that pitch is towards the lower side around 105 to 115 hertz. In the female patient, it is more on the higher side, around 200 230 hertz. So the vibration is very fast. And to get a slow motion picture, we use a strobe light, so that the frequency of vibration of the flashing of the light matches with the frequency of vibration of the. Pardon?
Hello, sir.
Yes.
Sir, when do you intervene in a case of sulcus vocalis? In this case also there was a sulcus, you said?
Because normally sulcus, as been described, it has the grade of the sulcus decided. First, the sulcus. What is sulcus? Sulcus is basically a groove. It's a Greek term. So sulcus grade is decided on the depth of the involvement.
Yes, sir.
We all know that the vocal fold has got a epithelium. It has got superficial lamina propria, that is superficial layer of the superficial lamina, SLP, and then there is a intermediate and the deep layer, and
Yes,
there
sir.
is a muscle underneath it.
Yes, sir.
So what Professor Hirano in 1974, he has described about the body cover theory. So body cover theory is when, so body is basically the muscle and the cover is basically the
SLP.
SLP. And epithelium is one of the sheath which covers the whole of the vocal fold. So epithelium, we all know it is the outermost layer of the vocal fold, and the superficial lamina propria is a gelatinous layer, also known as the linkage space. So the sulcus, if it is up to the superficial layer, it is grade 1 sulcus. So how you will decide it whether the patient is having it grade 1 sulcus or it is going up to that, or grade 2 when it is going up to the intermediate and the deep layer. and grade 3 when it is going up to the muscle.
Yes.
So that is decided by stroboscopy and looking at the phonatory gap, the glottal gap is very important. So if it is a severe grade of sulcus, patient might have a gap of 2 millimeter or maybe more than that. Parts are moving, but there is a gap, and you can see a linear groove there over the vocal fold. So if the gap is too much, then you require a surgical maneuver. There are various procedures for it. Augmentation procedure, there are temporary procedures, temporary biomaterials are there, which can be injected in the SLP layer, and some people inject in the, after releasing the sulcus, inject in the lateral part, that is in the muscular component, so as to augment the vocal fold. And some people do it with the cold instrument. There is another procedure which has been described by Dr. Nupur, that is laser assisted procedure for sulcus, LS, LAR or what? LSAR. That is a laser assisted procedure for sulcus. So there are various procedures which has been described, but I found in my hands, I don't find any. It is most difficult situation to treat. Even the fat get absorbed after a few months and years. So it is initial cases, the voice therapy is the only treatment. And if it is very severe, then you have to go for, if the gap is too much, then you can go for a type 1 thyroplasty, and explaining that the roughness of the voice will always be there, but the tiredness or the breathiness will be reduced once you do the thyroplasty type 1. So
Yes,
what type 1 will do, it will approximate the vocal fold, but the roughness is there because the mucosal wave is affected. Mucosal wave is basically a rheological phenomena. It is the movement of the SLP over the, that is cover over the body. So the mucosal wave is created by the cover which is covering the muscular layer. So the vibration of that creates a mucosal wave. So mucosal wave are affected because of the sulcus.
Okay, sir. Thank you.
क्या करना है? जो बच्चे का सर्वन को बुलाना है, असिस्टेंट कहाँ गया? सर्वन, वो बच्चे को बैठा लो और पतला वाला स्कोप दे दो।
कंसर्न वगैरह के लिए बात कर रहे हैं, कंसेंट लेने गए और अब बात कर रहे हैं। अच्छा सर, बैठा के देखना है।
हाँ, बैठा के देखना कुछ नहीं,
बैठा के ले आओ ना,
बैठा के देख लेंगे। अरे हो जाएगा, बोलो
This is 3.9 and from here it is 3.6.
अच्छा 3.9
insertion tube, this part is 3.9 and the remaining all is 3.6.
नहीं, जरूरत नहीं है, बस इसका हाथ पकड़ना, स्कोप ना खराब कर दे, है ना? वेरी कॉस्टली। इससे छोटा कौन सा आता है?
इससे ना और ENF V3 आता है सर, V3 या V4, ये
2.4 ना, सेम विद पेंटेक्स।
छोटा डिपार्टमेंट है, जवाब बनाओ, रिक्वायरमेंट भेजो।
सौम्या, आप कहाँ हो? आप केस ले रहे हो? ठीक है, लंच का क्या प्रबंध है? हाँ, फोन करना पड़ेगा। अच्छा, मैं तो तुम एग्जाम हो गया तीनों का? हो गया है? हाँ, तो मैं आना ये ले लूंगी मैं। ठीक है, हाँ ठीक है। मन्नू का है? मन्नू कॉपी हाउस। So delegates, lunch will be served in 15 minutes. In the meantime, we are demonstrating a endoscopy of a small child. हेलो हेलो, हाँ एक मिनट, आपकी क्या प्रॉब्लम है बताइए, क्या होता है?
गले में बात करने में जोर लगाना पड़ता है और ये आवाज सही नहीं है।
कब से है मैडम?
3-4 साल हो गए हैं।
3-4 साल हो गए। शुरुआत कैसे हुई थी? बुखार तो नहीं हुआ था?
सर्दी हुई थी।
सर्दी हुई थी ना?
सर्दी में मेरी आवाज बंद हो गई थी। तो फिर
अभी क्या उस टाइम जब प्रॉब्लम हुई थी उस टाइम में पानी पीने में दिक्कत तो नहीं हो रही थी? पानी पीने में खांसी तो नहीं आती थी? उस टाइम में नहीं आती थी। और अभी क्या थकावट होती है बोलने में?
ताकत लगानी पड़ती है और ये आवाज भी सही नहीं आती है।
बेटा फोकस कर लेना।
मोटी मोटी सी आवाज आ रही है।
ये भी बढ़ गई है प्रॉब्लम, समस्या बढ़ गई है। Hello, you are focused.
Hello audience, we are showing the strobe of second case who is having dysphonia. She is a 50-year female having dysphonia since 4-5 years. It was started with a viral fever. Hello.
So for the stroboscopy we are using 70-degree telescope. One can use 90 also, but 70 is ideal for it. And there are two things also important. You have a lock mode, na? Lock mode, lock. हाँ, इसमें lock mode होता है ना? हाँ, lock mode. This is only for light on, light off. हाँ, अच्छा. So lock on, you can see the still also with it. जीभ निकालिएगा. And there is a collar also for signals. So this audio signal from the neck with it has been picked by the foot pedal. So frequency of vibration of flashing light matches with the frequency of vibration of the vocal fold. That gives the slow motion picture of the vocal fold. Otherwise the vocal fold vibration is very high. Though I cannot see that, and I will see it as a stable image. ई बोलिएगा, ई ई ई ई वेव नहीं बन रही. ई ई your foot pedal is not working. नहीं कर रहा है इसको क्या हुआ नहीं आ रहा. So what are the areas you have to look for? Hello.
Yes, sir.
So important areas which we have to look for is FO, the fundamental frequency. So in the strobe itself, you can see there is a display which shows the frequency of vibration of the vocal folds. Other thing is you have to look for the amplitude. The amplitude of vocal fold vibration. Third one is periodicity. Periodicity means the vocal fold are abducting in the same way. The other important thing is you have to look for the mucosal wave. Mucosal wave can only be seen with the strobe light, not like, I don't know whether this is not giving any flashing light. So one is FO, fundamental frequency. जी निकालिए. I will again try it. E. Look at the interretinoid area. आप कुछ मत करिए, आराम सांस लीजिए. So you have to look in the amplitude, that how much the cord is abducting and it is coming. अब बोलिए E. If you look at the right cord, the right cord, the movement is little bit delayed as compared to the left cord.
Yes, sir.
You can appreciate that. And the important other area you have to look for is the ventricle. Whether the ventricle is obliterated or not, whether ventricle you can see it openly. So in both the sides, you cannot see the ventricle. The false cord is covering the ventricular part. The other, now you see this. And धीरे से खासिएगा. अब बोले ई. लंबी सांस. अब बोले ई. This little bit delay is there on the right side. Right cord is jumping like anything, but left cord. Right cord little bit delay is there. E. Hey, false cord actually the covering the right true cord. Actually. Ventricle is obliterated. So there are few other things, other important condition in which the ventricle is obliterated with the hypertrophy of false cord. One of the commonest thing you will see in Indian condition is laryngopharyngeal reflux. So LPR patient will have a false cord hypertrophy because of the false cord hypertrophy, the ventricle is obliterated. So that is a finding. The other findings are there in LPR patient, and LPR is not on the history. LPR is diagnosis made on the finding we called as reflex finding score. So reflex finding score is not a case for thyroplasty. So LPR, there are reflex finding score, and there is a another scoring system which is based on subjective. From the patient itself, patient will tell about the. So important thing, this is all given by Belfasti, and in reflex finding score, you have to look for retinoid hyperemia or interretinoid pachydermia, something like a raised area in the interretinoid area, or if the interretinoid area is congested as compared to the other part. So this is one of the important and the common finding which you encounter in LPR patient. The other important thing you will see is sometimes there is a hypertrophy below the cord or the undersurface of the cord, which is known as pseudosulcus. So pseudosulcus is also very commonly seen. Once you start looking at it, you will see it very often. Third is obliteration of the ventricle by the hypertrophy of the false cord. So that is also is important finding in LPR patient.
Sir, what is your protocol for treating the LPR?
What is
your protocol for treating the LPR?
So ideally we should be investigated like that with the double probe pH study, everything, but we are not doing it. Only at few centers it has been done. But medically, we besides lifestyle changes like avoidance of some special food and position of sleep, eating habits, and what we are doing is we are giving a proton pump inhibitor with domperidone combination for minimum for 3 weeks, and alginate we give, that is commercially it is available like Gaviscon syrup. Gaviscon syrup that forms a raft over the gastric content, and it has got a carbonate with it, and that prevents the गोदी में लेके बैठो सलमान, बैठो.
So sir, you prescribe PPI for 3 weeks only?
Just I am coming. Just examining one baby. जरा सर पकड़ना है, एक जना सर पकड़ना है. लाइट ऑन करो, कहाँ गया? लाइट ऑन है? लाइट नहीं ऑन है.
बस आराम से आप बैठे रहो.
रिकॉर्ड करना, रिकॉर्ड करना, रिकॉर्ड करना.
Hello, this was a small child with subglottic stenosis, and sir will discuss what is the finding. Yes, sir.
See, this patient was operated for cardiac anomaly, and the child must be having a congenital subglottic stenosis. So at the time of surgery, during the time of intubation also, the anesthetist faced the problem in intubating this patient. So at the time of extubation also, they feel the same problem, and I think baby was tracheostomized. Yeah, tracheostomized, baby was tracheostomized, then baby was decannulated very well. And now what we have done is we have tried to examine it under, because there is some issue with the anesthesia. So we have examined it under local only, and local examination also you can do it if the patient doesn't have any severe respiratory distress. Even all the foreign bodies, if the patient is not having any respiratory distress, you can examine it under in office with a facility for resuscitation. But so what we saw in this patient is subglottic stenosis is there, and the scope which we used is the this is a pediatric scope of 3.4 mm. So 3.4 mm we are able to negotiate. What is the age of the patient?
6 years.
So age of the baby? 6 years. So 3.4 mm was easily negotiated through the subglottic. कोई जरूरत नहीं है, तो anesthetist guy will tell you. So there's enough space is there. There's not much of resistance was there. So maybe we can say that we are positive, and because patient has to undergo second cardiac surgery, so we can explain the patient attendant that they can undergo for second cardiac surgery with a consent for tracheostomy in post-op maybe. So, if there is no problem, because this looks like a grade 2 stenosis, no symptom, no surgery, no treatment. Maybe patient will have exertional dyspnea, but I don't think. Balloon tracheoplasty? No.
Thank you, sir.
हाँ मुश्किल
मैं शशिकांत शुक्ला प्रवक्ता हूँ भारतीय जनता पार्टी।
अच्छा।
एक साल भर्ती रहा, एक मैंने भोपाल, एक मैंने 5 मैंने चमत्कारी ढंग से बच गया।
अरे
मेरी आवाज चली गई, एक पैरालिस वीडियो दिया है मैंने।
अच्छा।
ये लेफ्ट पैरालाइज हो गया, तो
राइट
आवाज
राइट।
नहीं आ पाई।
ट्रेकोस्मी भी हुई थी क्या?
जी, ये नली डली थी, मैं कोमा में था, 86 दिन वेंटिलेटर में।
अच्छा अच्छा। और आवाज कब से परिवर्तित हुई थी?
वही बीच में खांसते खांसते इसी के बाद पैरालाइज हो गया। इसको ठीक करो साहब, मैं सीधा जाऊंगा।
हाँ
बोलना बताना डिलीट करना सब चला गया।
आगे जीभ निकालिएगा। ई बोलिएगा, ई ई
पैर से दबाओ
ई
आराम से बहुत अच्छा दिखा रहा है।
ई
So this was a
Hello.
Yes, sir.
You have seen the stroboscopy?
Yes, sir.
So this patient has a history of mucormycosis more than a year back, and then he was admitted at various places in India, even in Bhopal and Bombay and other places. Then in the period he was kept on, I think, ventilator पे रखा था आपको? He was kept on ventilator, then he was trachostomized, then his tracheostomy was removed, and since that time he was having this voice change. So if you look at carefully, it seems that this, I hope you have seen the strobe.
Yes, sir.
You have seen the strobe, no? So what I feel it, right cord is moving very well, and left cord is in the median plane, not in paramedian. It is in median plane, and it looks like might be he is not having a palsy. It is a fixed cord.
Yes, sir.
So because of the fixity, the pliability is not there. If you look carefully more, the vocal fold vibration, the vibration is also not proper. So we can repeat the strobe again. And now you again see it, and then you again correlate it. So because he is he uses his voice very often because he is a journalist, and he feels tired because of he has to speak a lot, and the right cord has to exert too much, and it is compensating for the left cord. But if you look at the left cord, it is in median plane, not in paramedian. जीभ निकालिएगा, आराम से रखिएगा, सांस लीजिएगा। अब ई बोलिए, ई। Now I'm putting the scope in the midline. E. Little bit movement is there, I think. E. 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 लाइए, स्प्रे देना। हाँ करिए. So it is a right cord which is compensating it. लाइए इसको दीजिए. कितने दिन वेंटिलेटर पे रहे आप? 84 दिन. वेंटिलेटर पे
वेंटिलेटर.
अच्छा नहीं, ट्रेकोस्टमी हो गई थी, छेद हो गया था आपके.
खाना से दे दी.
नहीं, यहाँ से वो देते होंगे, सांस आती होगी.
हाँ, जो भी सांस वो लगाए थे सब.
हाँ.
और वेंटिलेटर में थे.
जीभ निकालिए. लंबी सांस, सांस लीजिए बस. नहीं, कुछ टाइट मत करिए. अब बोलिए ई. Now here the cord looks little bit bored. E. Mid part is little bit. No, actually he will improve with thyroplasty. He will do it. He will improve it. E. 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 लोकल में होती है. लोकल में ही होती है.
अभी
कोई
चले जाएंगे फिर आपको
नहीं, कोई बात नहीं.
चिंता नहीं करिए, थोड़ा सा लोकल में होता है.
So
अब देखते हैं, आप करवाने के पहले हाँ बोले फिर बात करते हैं. सर एक केस तांबे जी हैं इंजेक्शन.
हाँ.
जैसे आरटीओ की आंख लॉस करने की होती है,
दूसरे ग्लव्स दे दो बेटा. नहीं,
नहीं
शाम तक नहीं छोड़ते हैं. यदि हमने आपका कुछ किया तो हमारा रूल है कि हम 24 घंटे तो रखें. ठीक है, हम 24 घंटे तक रखेंगे.
आता होगा जैसे आरटीओ का आता है, वो बैटरी लगा के
उसके बाद आ जाएगी.
हाँ, ऑन टेबल होती है, टेबल पे ही होता है.
नहीं, इसके बाद आवाज आ जाएगी.
हाँ.
ऑन टेबल फायदा होगा.
क्या कहना है?
उसमें कोई भी बैटरी से चलता है.
सिखा लिया.
उससे अगर करंट आ भी रहा है,
क्या है माता जी को?
दो मिक्सर ऐसे खराब हो चुके हैं पहले.
क्या हुआ है?
सर ये ओल्ड लेडी है, आपका एडवर्टाइजमेंट सुन के वॉइस की प्रॉब्लम थी तो इनके साथ ही किसी एक इंसान को बुला, क्या प्रॉब्लम है इनको.
क्या नाम है?
नाम क्या है हमारा?
सेंट्रल कॉज हो है. नाम बताइए. तो सेंट्रल कॉज.
नाम क्या है?
सेंट्रल कॉज लग रहा है मैडम. शी इज नॉट फॉलोइंग.
लक्ष्मण.
नहीं मैडम, ये सेंट्रल कॉज है. शी इज नॉट फॉलोइंग द कमांड. नहीं, कुछ नहीं होगा. लो वॉश पीस है ना, ऐसे ही दे दो बेटा. भिगो के दे दो. बेटा सेवलॉन में भिगो दो.
बाद में रिकॉर्डिंग कराऊंगी.
हाँ नहीं, अच्छा रहने दीजिए. फ्लेक्सिबल.
इनका कारण गले में नहीं.
हाँ, ब्रेन से रिलेटेड. इनका वो बना लिया बोटॉक्स. बैठा के होता है
दोनों नाच रहे हैं, रज्जू पागल हो गया, बोल रहा है ऐसे में तो केबल खराब हो जाएगी, एक बार निकाल के वहां ले जाए, एक बार निकाल के एंडोस्कोप के लिए भी बदलना पड़ेगा। नंबर तक सब भूल भाल गया, जो चालू दिखेगा उसको दिखाते रहेंगे, सब इधर उधर हो गया ना।
Hello. Hello.
Hello. Yes.
Yes. Now comes the main highlight of the event, Botox injection. Sir is preparing the patient. आप लोग को जो पूछना है प्लीज इंटरैक्टिवली पूछते जाइए. It will make the process more clear. What is the concentration? What is the molecule? What are the indications? So इसका abductor है. Adductor spasmodic dysphonia है. सर मार्किंग कर रहे हैं. पॉइंट पे सर बोल सकते हैं तो बोलते जाइए सर क्या कर रहे हैं.
Hello.
Yes.
Can we see his voice before that injection and it?
बोलो तांबे जी कुछ बोलो.
Hello.
बोलने में एफर्ट लगता है कई बार। हाँ, बोलने में एफर्ट लगता है।
He is telling बोलने में एफर्ट लगता है. Patient is telling बोलने में एफर्ट लगता है. Hello.
Yes, yes, yes.
Okay. Marking pen.
What are the markings, sir?
Sir, what are the markings?
Hello. Hello, sir. So, can you hear me?
या तो पोर्ट उड़ गया है या फिर केबल लंबी नहीं ले पा रहा। नहीं ऐसा तो हो नहीं सकता। 100 मीटर तो लेता है।
25.
Hello.
Hello, sir.
Yeah, sorry, my mic was off.
Yeah.
So this is a landmark. I'll just show you. This is thyroid notch. This is a cricoid superior border. So I'll be going through the cricothyroid membrane. So
So, can we see the stroboscopy before injection, sir? So, before and after can
yeah,
be
I'll
appreciated.
just go. I'll just show you everything.
Yes, sir.
So this is the ampule of the botulinum toxin which will be using it. And this is 50 unit. So we have diluted with saline in 5 ml. So 1 ml will have 10 unit. So 1 ml will have 10 units. So we are using 3 units on each side.
Okay.
So, but we keep 1 unit extra. Sometimes there is a spillover. So we keep 1 unit extra. So we have used a insulin syringe. This is an insulin syringe. We have loaded 0.6 unit. And then we have added little bit of distilled water to make it dilute. And then we'll be doing a flexible scopy. And then we anesthetize the airway using this. This
Right,
has got
sir.
a working channel, na? Yes. Keep it. So, Mr. तांबे जी कोई दिक्कत की बात नहीं है वो दीजिए because I don't use any gloves here. There is a purpose for it. Why I'm not using it? Because my assistant will be showing me and I'll be injecting it. And I have to have that tactile feeling that where my needle should go.
Right,
So
sir.
that is why I'm not wearing it. आप नर्वस मत होइए आप पसीना क्यों छूट रहा है आपके है ना मस्त रहिए आप ठीक है कंफर्टेबल
Sir, have you injected any local anesthesia or only spray and Jalkan jelly?
only spray. We will be using LP needle.
Yes, sir.
Normally, in my setup, I use sometime 1.5 inch 26 gauge needle, which the dental people use it. यहाँ पे नहीं होगी ना, 26 गेज की 1.5 इंच, 1.5 इंच वाली डेंटल सिरिंज, डेंटल निडल, सॉरी निडल निडल। हाँ ये बेस्ट है, दिस इज द बेस्ट। अरे यार हमें भी दे देना, और डालो। हाँ ई बोलिए अम्बे जी, ई। थोड़ा सा अब फिर बोलिए तांबे जी, ई। नहीं गिरा, ई। हाँ ठीक 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 है, बस आराम से सांस लीजिए। अब आप, पिक्चर क्वालिटी बहुत अच्छी नहीं आ रही है, वो 1.5 इंच वाली लगा दो। आराम से सांस लीजिए, आप टाइट मत करिए, है ना। आराम से रिलैक्स रहिए तांबे, है ना। आप पसीना छूट रहा है आपका, तो पंखा का लगवाएं क्या? आप घबराइए नहीं, आओ सर। लो इसको देना मैडम, मेरे को चेस्ट, अच्छा ये वो देना, ये ज़्यादा फेंक देना यार।
Hello. Sir, we just want to see that external picture also in the place.
Now you can see that I am inside it.
So you're going through the cartilage?
Yeah, you can see the needle.
Yeah, we can see the needle.
पिक्चर बहुत अच्छी नहीं आ रही है सर।
But endoscopic picture is not there. Sir. ये तो
अरे क्या कर रहे हो सरवन यार? नहीं, आराम से सांस लीजिए। So I am going into the same side.
कैमरे को मेन बनाओ ना। कैमरे को मेन बनाओ।
अरे सर हटाइए, बीच में हटाइए, कहाँ घुस रही हैं आप?
Sir, have you injected on one side?
Yeah, right side I have injected. Now I am going to the
Sir, we thought that the needle was little subglottic.
No, I am going up.
So we do not have that endoscopic picture now. Hello, sir. Srivastava, sir.
Yeah.
I just want to know, you're going through the cartilage or through the membrane?
No, through cricothyroid membrane.
Okay.
Proper करो.
Do we require a pre-op local anesthesia here also?
Actually, sir, proper करो. Yeah. So I'm coming from the above.
Sir, we can't see that endoscopic picture now. Now we can see that mirror. So can you enlarge that endoscopic picture?
Actually, he's थोड़ा नीचे जाके सक्शन करो. अंदर जाओ. सक्शन करो.
Sir, could you please describe in detail?
Yeah, I'm trying it actually. Vision is not very good actually.
Yes.
Problem is I'm not getting a very good vision. I don't know what has happened.
Jelly on the tip of that camera.
Yeah, I think I'm in the right position on the left cord.
Hello.
Yes.
Delegates, you can have lunch after this event. After this surgery, we'll have a break of 10-15 minutes.
Sure, ma'am.
So we are getting a nice image. Could you please describe along with it so it will be really good?
Yeah, I'm injecting into the thyroid muscle. I
Yes,
need
sir.
some more because little bit has been wasted. Give me look this botulinum toxin. Little. जल्दी दीजिए. नहीं. ऑलरेडी लगी हुई है, देख नहीं रहे आप लोग. अरे रे. रुक जाना एक मिनट. ऊपर करो. Now I am through the suprathyroid. Now I have injected it. So through this plane.
Yes, sir.
थोड़ा सा बोटॉक्स देना, स्पिल हो गया, निकालो ना। है, गिर गया। अरे आप निडल अंदर चली जा रही है ना। निकालिए। So now it has gone.
Hello.
Yeah.
So is it possible to give endolaryngeal also, this kind of injection?
Endolaryngeal also, but you require a special needle for it. There's no long needle is there for it. So there are two ways. One is through the cricothyroid.
Yes.
And other is through the
Thyroid.
Thyroid. So the last one was through the thyroid. I have turned the needle. I'll just show you the curvature. No. छोड़ दो सर. So the curvature is like this. If you are going above the.
When do we confirm that the
above
injection
the thyroid?
Yes.
Thyroid membrane. So curvature will be like this. But if you are going through the cricothyroid membrane, so initially after this injection, patient will have voice like this for 3-4 days, and after that patient might have a breathy voice. और एक चीज और हो सकती है कि पानी पीने में 3-4 दिन बाद हल्का सा खांसी आए, ठीक है ना, तो धीमे धीमे फिर पानी पीजिएगा। तो 2-3 दिन समस्या रहेगी, पानी पीने में लगेगा खांसी थोड़ी ज़्यादा आ रही है और आवाज़ थोड़ी आपकी लग रहा है एयर ज़्यादा निकल रही है, लेकिन 10 से 12 दिन के बाद आपकी आवाज़ नॉर्मल होने लगेगी। नेक साफ कर दिएगा। सो इनिशियली पेशेंट माइट हैव लिटिल बिट एस्पिरेशन because we have injected both the cords, and some people give only on one cord, and but since we are not using EMG guided, so we are injecting on both the cords under vision. On the left side, I'm not sure that whether it has really affected the thyroid muscle or not, but the right side will have a definite response. And even if one cord is weakened, then we'll have a normal voice of the patient for at least 3 to 4 months. So after that, we can think about other procedure like the procedure what I do is thyroid myoneurectomy with laser. So what we do in that procedure, thyroid myoneurectomy, we laserize at the posterolateral part of the larynx, where the nerve enters the inlet of the larynx. So lateral to the thyroid muscle, we laserize using a CO2 laser, and then both the side we do it. It has got its own failure also. 15% has got its failure from thyroid myoneurectomy, but it depends on the reinnervation which might happen after 18 months or 3 years like that. नहीं blood नहीं आएगा, blood नहीं आएगा. नहीं, he can go no medication. No medication. कभी 5 दिन कुछ नहीं लेना. 5 दिन बाद आप आके बता देना मैडम को, हो सकता है थोड़ी खांसी आए पानी पीने में, है ना. हाँ, और अभी 2 घंटे बाद कर रहे हैं. हाँ, अभी तो वैसी ही वॉइस रहेगी, अभी वॉइस वैसी ही रहेगी, अभी इंजेक्शन का असर आने में असर आएगा 3 दिन बाद 4 दिन. So
Hello?
thyroid at night, myoneurectomy.
इलास्टिक ब्लॉक करेंगे पेशेंट कंसर्न दे रहा है
दे रहा है।
Medialization thyroplasty
हाँ, लेफ्ट साइड ना, हाँ कर देंगे.
अनाउंस कर दीजिए आफ्टर लंच आई विल बी डूइंग
So after lunch, I'll be doing type 1 thyroplasty.
अंडर एलए
Okay.
Under LA.
Sir, how, just want to know, how do we know that the injection is there in the proper site? Like
Yeah.
when you went from that cricothyroid membrane, we were thinking that we are going little
Yeah,
down.
that is a big issue because there is no EMG guided. It is not a EMG guided.
Ah, sir.
So other thing you can do is you are asking about transoral approach.
Yes, sir.
Transoral also you can give. There is a aspiration needle is there with the bronchoscope. So once you buy the Olympus bronchoscope, it has, they usually provide a injection, the aspiration needle.
Yeah.
So that aspiration needle you can use it for injection purpose also. Like we give it for sulcus vocalis. In office we give Restylane to the patient. So that aspiration needle has got 3 ports. That is for basically FNAC or something like that. So that it is a wide bore needle.
That is a TBNA needle. That's a
Yes, TBNA, something like that. And that same needle you can use it for injection also.
Okay, sir.
So there is a one video in my YouTube channel. You can see my YouTube channel, that is there. Injection by that aspiration needle.
Okay.
The other way is which today I showed you. The other way, there is suprathyroid. Suprathyroid. Then you have to make more curvature into it. That is also a simple way to doing it.
So have you
And use this needle. What I use is there. I have changed the needle from LP needle to the 1.5 inch dental
26.
dental needle. That is because the working length is less. With the LP needle, the rotatory movement is there. So it sometimes you are trying to put it on the left side, the needle will go on the right side because of this thing. And if you use a wide bore needle, then there are chances of bleeding.
Yes, sir.
So you have to balance it. So I think this dental needle is better because the working length is less.
So what are the complications or sudden emergencies one can face after this? Is there any chance of breathlessness or hematoma? Like, have you faced anywhere?
No. Why? Patient is breathing normally, no problem. He might have a little bit aspiration, sometime coughing.
He will have little adductor weakness now, after doing
adductor
this.
weakness. Sarvan.
मेरी आवाज हाँ all the delegates please welcome for lunch. कोई एक जन यहाँ रहेगा ना?
Hello, audience. We have a patient of Parkinson's. He has slurring of speech, and we just want to see whether some pathology is there in the vocal cord or not, because sometimes he is able to speak and sometimes he is not able to speak. यही है ना problem? हाँ जी. Hello.
Yes, ma'am. We are here, ma'am.
You are hearing, no?
Yes.
Right.
But
Thank you, Mahmuda.
We are not getting the picture, ma'am. Ma'am, some of the delegates have left for the lunch. Some are here. Hello, OT team. Hello.
महमूदा
Yes, ma'am.
15 मिनट बाद अपन थायरोप्लास्टी टाइप 1 लेंगे. लंच के लिए ब्रेक ले लो. This is not a very, it is just for a academic reason that we are getting the vocal cord examined, whether there is some vocal cord pathology or not.
Yes,
for
ma'am.
speech. Okay, it can be paralysis, something like that.
Hello.
सांस की प्रॉब्लम आपको जो भी है लंग से कारण होगी, इसको बाहर शिफ्ट करवा गले के कारण है. विकी बाहर शिफ्ट करवा. दादा बाहर शिफ्ट करवा दो. उनके साथ के बच्चे को बुला लो. सर राजू सर.
Hello.
हमारी वीडियो आ रही है, स्टार्ट शेयरिंग कर कितने लोग बिना ठीक है
देखते होंगे So this lecture is very important for whatever we have did in the operating room, because this will help you, especially the residents, that that will help in assessment of the patient and also your results of surgery. The topic is laryngo score and laryngoscope. So what is a laryngoscore? Laryngoscore is what you see on from the patient. You get a data from the patient whether this patient is a case of a good laryngeal exposure or a case of a bad laryngeal exposure. Many times you must have faced this problem even in my practice also. Out of 100 cases, 1 or 2 cases I have to come out of operating room and say the patient that I'm not able to see the larynx because patient was having a poor laryngeal exposure and I'm not able to remove it. And so whatever way I can help you is by only charging for the anesthetic and hospital, and then you have to refer it to the other ENT or whatever you feel it like. So you should have armamentarium to deal with such difficult cases. And like day before yesterday, I had one patient where I did transoral laser surgery and I have especially written it difficult laryngeal exposure. After 3 or 4 months, it came with a residual growth. Then I have not given a single thought of it that I will do a second laser because I have faced the first. And I have that recording that this patient I have had a problem into it, though he doesn't have a recurrence at the anterior commissure. But because there was a recurrence, the residual disease is there, so I have not done any second laser into it. That is why I kept the strict follow-up in that case sheet that every month you have to count. So 4th or 5th month he showed a residual disease. Once I did NBI, then I said you have to undergo radiotherapy also. So success of transoral laser surgery is depend on many factors like intraoperative workup, experience of surgeon and team, post-operative follow-up, pre-operative diagnostic workup, imaging, patient selection, and adequate laryngeal exposure. So what I am going to talk about is adequate laryngeal exposure and what laryngoscope one should have it. I'm not saying you should buy Karl Stowe's costly laryngoscope. You can discuss with your local vendor like our Khalilkar Surgical and choose it accordingly, because they are just a makers and you have the mind there to tell the makers that I want this type of laryngoscope or this type of. If they are not making it, then you have to get it from the outside only. There's no question about it. But many things we have designed it, and many things I'll show you which we have made it. Laryngoscope also we have modified it. We have used a chest support also, which we are using it. So different type of things are there. So not going to the detail of what is this great about it. Laryngoscope is a term which has been coined by Piazza. He is a laryngologist from Italy, and He has visited many times in our place and our conferences, and almost I've met him 5-6 times, and he has developed a pre-operative clinical predictors of difficult laryngeal exposure for microlaryngoscopy. So what his concept is, DLE means anterior commissure. And what DLE, difficult laryngeal exposure, is with laryngoscope, which I showed you in the morning, laryngoscope. I'm having it. So if you are using a laryngoscope, you are not able to see the anterior commissure. So that is a difficult laryngeal exposure. Then in Indian context, Santosh Surgical makes a anterior commissure laryngoscope, which has been modified by the Dr. Lupun Delluka, but that has got a very sharp edges, very sharp edges. So we again requested him to make it a little bit more rounded, and the curvature is very acute. So if you see the slope of the laryngoscope, and if you see the Indian makers, the slope, either they make it very acute or the edges are very sharp. It damages the, starting from valvula, you can damage valvular mucosa, and the valvular mucosa damage, and there will be a lot of bleeding because valvula is supplied by the superior laryngeal artery either from the PE fold. So both are coming. So you have to be very gentle once you are using that laryngoscope. But I have faced a problem and I have to use patty then bipolar like that. So you have to be very gentle once you are using Indian made laryngoscope because these are very sharp laryngoscopes. So anterior commissure visualization in Boyce-Jackson position. So these are common scaling system 11-point score. All you must have read in Malampati grading system, and even many of you must have read the anesthetic. They are using Cormack-Lehan grading. Cormack-Lehan is almost the same, but except few things which has been added to simplify it. If you are doing a transoral laser surgery, like they have added previous treatment. So previous treatment is not of significance for the anesthetist, but it is significant for us. If you are doing a post-sedated patient for transoral laser surgery, you are prepared that this patient will have a woody larynx and it will be difficult for laryngeal exposure because you will not get that extension there, and that case will be a problem case. So prepare yourself for it. Rest of the things are very common, like trismus, teeth, mandibular prognathism, neck extension. We all see patient extension is there or not. So not going into the detail of each and every point. These are all theoretical things. Upper jaw. Edentulous patient is a good patient because you will get a good area and a good laryngeal exposure. Macroglossia, mandibular, micrognathia. Extension of the neck is very important. Flexion extension, 90 degree more than that is good case for it. BMI also one of the additional point which has been added into this laryngoscope. Modified Malampati score, you all know about it. 0 point, 1 point. These points have been described by the IASA. So you have to, you can do these things in your academic work for if you are taking a patient for surgery or someone who's doing a thesis work on it, so they can use it for that purpose. So class 0 class, the class 0 is AC visualization by large bore laryngoscope in Boyce-Jackson position without external counter pressure. Like today morning, my assistant was pressing from left piriform once I was working on the left side. So external counter pressure are required. Class 1 is anterior commissure visualization by large bore laryngoscope in Boyce-Jackson position with external laryngeal counter pressure. Third hand technique, people call it third hand technique. So you put a third hand and then you can see the anterior commissure. Then class 2 anterior commissure visualization by large bore laryngoscope in flexion position. What I was using is flexion extension position. Flexion of neck over the chest, but extension at the atlanto-occipital joint dot working position. Okay, so this is like this. So But if you have to do both the things in flexion, then it is a difficult laryngeal exposure. And this patient will require external laryngeal conturbation. 3 is you have to shift it to Dido laryngoscope to the small bore laryngoscope, like hypopharyngoscope. So in flexion position with and class 4 is impossible visualization of anterior commission. So many times if you have seen it, you have to shift to a hypopharyngoscope to look into the airway. But it is very difficult to negotiate 2 instruments simultaneously in the hypopharyngoscope because the bore is very small. In that case, you can do is what I have showed you. You can use a 70-degree telescope from the side of the scope and then use a malleable forceps, which Santosh Surgical it makes. So you can use that forceps which has got a band like this. So benign lesion, you can remove it using that forceps. So that is another way of doing the difficult airway surgery, but not for malignancy. Malignancy is going to recur, or residual disease will be there. So this is 4 parameters ranging from 0 to 17. Good laryngeal exposure will have a score of less than 6, and difficult laryngeal exposure will have more than 6. Even then, in difficult laryngeal exposure with more than 6, you are still able to do the surgery. So when laryngeal score value is less than 6, GLE was obtained, that is good laryngeal exposure obtained 94% of patient, and still you have a 6% difficult exposure. This is because of anteriorly placed larynx. So anteriorly placed larynx, sometimes it is, you will see it as easy, but still you are not able to get the, and when laryngeal score is more than 6, still you will be able to get a good laryngeal exposure in 60% of cases. So what is the impact? Why we are discussing about laryngeal score so much? Because we have seen it. Last week I have seen the case failed, the residual disease is there, and I was helpless because I can't say I will do the second laser because, but I have written in my OT notes that this was a case of a difficult laryngeal exposure. So I have to refer it for radiotherapy because I have seen that patient has got, after 4 months, I could see after healing, there is a residual disease was there. So impact of laryngeal exposure margin status, if you see this data from Piazza in 2016, 126 patient years examined, podectomies were done, 19 cases type 1, type 2, type 3, type 4, type 5. These all type of podectomies you must be reading in the laryngology books also. What are the types of podectomy? So if you see the group A cases, 95 patients, and group B has got 31 cases. Positive surgical margin, if you consider it, it is higher in group B with higher percentage of 41% with a positive margin. So this indicates that difficult laryngeal exposure, the chances you may leave the disease, you may left out the disease. So coming to the, what is the position of the patient? I told you in the operating room, what is the position of the patient? Flexion of the neck over the chest and extension at frontal-occipital joint. And it has been described by Chevalier Jackson's. So I'll just show you how to position a laryngoscope and what position one has to use. For an adult patient, I have showed you that the horizontal plane and the patient is around 15 centimeter. And there should be a pillow below the head. But for neonate, you don't require anything. Baby has to be lying in this position, and all the 3 axes will come in one direction. Oropharyngeal, pharyngeal, and the laryngopharyngeal axis will be in the same line. But for an adolescent baby, you may require a shoulder support, little bit of shoulder support to make all the 3 axes in one direction. And for an adult patient, you will require a pillow below the head. So this for an adult patient is not a good position. So this is not an ideal position for it because what you are going to see is very difficult to see the anterior larynx. If you see the arrow there, it is very difficult to reach the anterior commissure. But if you do like this, can you see that? Jackson advocated adult head to be raised 15 centimeters from the table, thus to make cervical spine straightened. And then there are less chances of subluxation. And then you extend the atlanto-occipital joint. So this position is like this, and then you extend it like that, and you will get a good laryngeal exposure. So like this, it is rotated. Atlanto-occipital joint, it is a correct position. And many of you anesthetists don't do the how to intubate it also. And many times, even now also, sometimes I have to make the patient like that. But still they say that I'm able to do it because one person is pressing larynx like this. And then you are putting the tube like that. And what happens is once you force the tube inside the larynx, your benign lesion will tear off. So it will go off like one of the part will be broken somewhere else and you are looking for that lesion. So it will be very gentle and position has to be very correct. So force vector should come in ventral and caudal direction. Like if you see in operating room, it is like this and we are lifting the lower lip like this. So the two fingers moving like this and we are protecting the lower tooth also and the lip. So one finger is protecting the lip and one is protecting the lower tooth also. And then we see the direction of the tongue and the tube. And we try to follow the tube because tube will come posterior to it. So force vector is the ventral caudal direction, and then we go towards the glottis, away from the upper teeth. So force should be on the lower jaw, not on the upper jaw. Force will come on the lower jaw, then you try to. You see the anesthetist, they lift the lower jaw first. So energy of this force comes not from the shoulders, it is come from the large muscles of the neck, like this, and leg. So your force is going like this, you are going like this, and then you elevate like that. So this is very important. And if the height is more, then we are more comfortable in putting that. So this is a direction of force which you have to use it. The force has to come from the legs. Other thing which I will just show you. This is a chest support which we are using it. I don't use this chest support because the force vector in this is on the upper teeth. What I am using is this one. And this Kalilkar is now manufacturing it for maybe last 4 years. So 4 years almost I have done more than 500 surgeries using this chest support. And this is a very good chest support. And no interference is there. And just you have to roll this. In this is not from the Kalilkar Surgical. This is from some other company. But here the roll is from here. But in Kalilkar's, this is known as gallows support. So gallows, you must be knowing about gallows. फांसी जो लगाते हैं, gallows. So same, the force vector is going in the lower teeth, not on the upper teeth. So once you rotate this screw, the laryngoscope moves like this. Up, अपने आप ऊपर जाएगा वो. So this is the advantage of using. And then once you are putting it, then you readjust with using a telescope there. Like morning I showed you how to readjust the laryngoscope, how much depth you require it. Like in malignancy, if the tumor is going into you will require to adjust the laryngoscope according to so depth of the laryngoscope is also very important. How much depth you want. Because your laryngoscope might damage the benign lesion or a malignancy and start oozing unnecessarily. So depth is very important. And various types of laryngoscope, you must be knowing about it. Clean saucer, commonest one, you get it from the Kalilkar Surgicals and Santosh Surgical. But sometimes it doesn't show the anterior 1/3 of the vocal cord. This is a problem with the clean saucer one. You have to press it with the third person has to press it. But DDO, there will be not any problem with it. This is a partial laryngoscope for any airway assessment. This is a very useful laryngoscope. Just put this parson because this parson has got a light carrier from above. So light cannon, you can use it, and you can attach it oxygen also from this port. So oxygen you can attach it, and you can oxygenate the patient, maybe, and then you can use a rigid scope and examine the airway very easily. This is a Parson laryngoscope. Water descending laryngoscope. Most of these laryngoscopes are manufactured now by Indian companies, so don't have to buy these costly 1.5 lakh to 2 lakh of laryngoscopes like that. Rooted, I have got it from Carl Store. This is of no use because we are using Indian make laryngoscopes. Lindom is very good. This is very good for the supraglottic airway. And if you are starting a laryngomalacia surgery, then there are 3 sizes of Lindom laryngoscope. So you can buy the pediatric one because this gives you both the views of the AE fold. And it fits very nicely in the vallicula. Very soft edges. So it fits into the vallicula, and your epiglottis will be anterior, and you can see AE fold both sides, and you can see piriform also. And it has got a wide bore at the distal end. So this, if you see the blade, this fits into this thing, and epiglottis will be elevated like that. It will go anteriorly. So this gives a panoramic view. And this is good for even if you are doing a lipoma surgery or something on the false quad. So this is a very good laryngoscope. But unfortunately, no Indian company is manufacturing this laryngoscope. It comes in 3 sizes. The Steiner one, Indian companies are now started manufacturing it. Dido, which I have discussed it, this is the ultimate. It has really changed my practice. So exposure, different type of exposure, you get it. Narrow bore laryngoscope, you are using hypopharyngoscopes in the range. So success of microlaryngoscopy depends on, beside the experience, reassessment, time to evaluate, and instrumentation. You should have a good bunch of laryngoscope to start a laryngology practice. Thank you. Any question, please? He was asking about some videos. So, videos. Eh? मैं देखता हूँ मेरा एक्चुअली क्या है एयरवे का वीडियोस है बहुत सारे मुझे फाइल ढूंढनी पड़ेगी थोड़ा सा टाइम के लिए इस वाली हार्ड डिस्क में उस वाली हार्ड डिस्क में याद नहीं आ रहा आई थिंक सी वन ऑफ और कोई पोर्ट है वॉल्यूम लगा दो तो लगाना Come with you. इसमें वीडियोस बहुत थी यार, हमें तो देखने का।
Sir, they're showing some videos.
क्या शेयर करें, कुछ क्लिनिकल शेयर करें?
हाँ, just show you the
एक्चुअली हम लोग क्विज भी कर रहे हैं।
क्विज
कर थोड़ा ब्रेक मिल जाएगा।
ठीक है।
अच्छा, आप बताओ, आप कुछ इंटरेस्ट
सब सर्च कर लेते हैं।
है ना? तो दीक्षा, कैन वी स्टार्ट अ क्विज? गायब 5 मिनट्स है, 5 मिनट्स। कम इन सब टीम आ जाओ, फटाफट बैठो। टीम भी भागना नहीं, तुम अच्छे बैठे हुए हैं। कम फॉरवर्ड द टीम्स। चैत्रा, तुम और राहुल एकदम टाइम से आए हो, क्विज में पार्टिसिपेट करना। यूट्यूब स्ट्रीमिंग चल रही है? हाँ, वॉइस जा रही है? सर हम बताएं, टाइप 1 थायरोप्लास्टी शेयर कर लो 5 मिनट का यदि हो तो, क्योंकि वो अपन दिखा नहीं पाए हैं सेलास्टिक ब्लॉक वाला, है ना? यदि वो होता वो आपके लिए बहुत सिंपल है तो आप रखते नहीं होंगे। सर मुझे एक चीज बताओ, आपको अभी क्या घर में जाके रेस्ट करना है, एक होटल में अर्ली डिनर रखना है, यहाँ पे नर्मदा रिवर है, नर्मदा रिवर देखना है, आराम करना है, अर्ली डिनर करना है, 5 बजे आए तो रिवर पास में है, जाना 8 o'clock आपको यहाँ से स्टेशन जाना है।
नहीं,
आप 9 बजे की ट्रेन है ना?
8:51।
तो अपन 8 बजे निकाल देंगे आपको गुलजार से, तभी आप जाओगे। आपको
ठीक है, नो प्रॉब्लम है, होटल में तो जाएंगे सीधे, या तो अर्ली डिनर कर लेंगे।
हाँ, अर्ली डिनर होटल करवा देंगे।
हाँ, या फिर हम वही स्टेशन पे कर लेंगे।
नहीं ना सर, कैसे बोलते हैं सर?
अरे
2-3 ENT वाला, नहीं ऐसे मत बोलिए। और
ऐसा कुछ नहीं मैडम।
सर मेरी बात तो मानिए, आप इतने सिंपल हैं, आ गए, छोटे से गेट टुगेदर किया है, रास्ते में ऑन द वे गुलजार होटल है। मैं चाहती हूँ कि वहाँ पे 6, 6:30 आप पहुँचे, 7 बजे यहाँ से निकलोगे, फिर अपन 7 बजे लेट हो जाएगा। हाँ, 7:15 तो वो मेनू आप वो उसमें पूछ रहा था, नॉनवेज लेते तो वैसा ऑर्डर कर।
नहीं ऐसा मत नहीं, वेज
मेरा प्योर वेज
नहीं, ऐसा नहीं है, हम आई ईट नॉन वेज।
तो ये नहीं सुना कि सर से पूछ लेना और डॉक्टर लेते हैं, जाम कर दूंगा।
Okay.
मुझसे आप बात कर लो। 2 पीस टीम कैसे हो रही, बाकी सब क्या नहीं तो ठीक से कराओ। नहीं तो जितनी टीम है ले लो बेटा, ऐसा लोगे तो वो फर्स्ट आ जाएगी, उनको कॉम्प्लीमेंट्री। चलो फटाफट रखो टीम। हाँ, टीम बनाओ, बिठा दो सर, सुना दे फिर भी सुनाओ।
One of the tricks of what we are using it, I showed you about the airway.
एक चेयर पे गैप।
Anesthesia. So this is one of the way you can do it using a cannula. Suspending the larynx, you see the high flow is there on the nose.
Okay.
So this is one way. The other one is, if you see this, our innovative anesthetist is there. So what we are using is a balloon. So this balloon is a cardiac balloon. So you must be knowing about the balloons. There are the airway balloon are basically CRE balloons. So What is CRE? CRE is basically controlled radial expansion balloon. So it causes radial expansion, and Indian manufacturers are Medical Life Sciences, which they have started manufacturing airway balloon. So they are now available in India. So you can use it. Initially, I was using it as a cardiac balloon. So I used to get a cardiac balloon for peripheral vessels. We get a large size of balloon. So normally for trachea, we require a size of, for pediatric age group, 7 to 8 mm of expansion we require, and the length depend on the stenosis. So every balloon has its own specification. Like controlled radial expansion CRE balloon have got its own. It has been mentioned burst pressure of the balloon. So you have to see that what is the burst pressure of the balloon, because you will be using a manometer, and you should not use too much so that you cause a burst. And there is a complication which is known with the trachea, that disjunction of trachea. That is, you have the rings has got separated. So the pressure has to be controlled, and there are two ways they mentioned it. One is by pressure. If you don't have a pressure, then they mention the volume, how much volume you can use in that balloon. So in Medical Life Sciences, they mention both the things, the volume also and both the things. On my website also, in my website, that is airwaysurgery.in, I mentioned about the what are the specifications are there for the metal type of balloon, what are the specifications which are there for the cardiac balloons. So cardiac balloon, they have 3 ports in cardiac balloon. If you look here, this I'm using is a cardiac balloon. Now you see this is a balloon, and this is the proximal end of the balloon, and there is a side port into it. So what I have done is in this balloon, so what I am doing in this balloon, one way I have kept for the expansion, the liquid is there. So liquid I am injecting to expand the balloon. The other port is connected, and it goes distal to the balloon. This port, this goes distal to it. So this port I have attached to the oxygen supply. So oxygen flow one way will be there. Even if you inflate the balloon, the oxygen will flow distal to the stenotic side. But one we have to remember that the duration of expansion should not be too prolonged, because and the flow of oxygen should not be more than 1 liter. It should be less than 1 or 0.5, because the gases expulsion is not there. So you will be expanding the alveoli gradually. So initially we are using it, then our anesthetist has calculated the volume accordingly. Like how many seconds you can do this, because then the saturation will not fall, especially in compromised air. So because you are distilling, you are oxygenating the patient and maintaining the oxygen flow, which is not possible in this barrel balloon, because barrel balloons are CRA and they don't have an external two-way like cannula like this. So this is our innovation which we were using it, and we have not reported any complication using this, and almost in 80 to 90 cases we have used it in last 10 years. Now we have shifted just last year, and this year also we are using this Merrill, because he is giving a special rate to me, and plus we are getting insurance cases. Now we are able to buy it. Otherwise, it is very difficult to get a balloon from Boston, because this costs around 70,000 rupees. So this I am getting it from cardiology. So you can also request your cardiology friend to get for you. But these are our peripheral balloons. So this is another way of using a jet. You see the tri-way is there, 4% is attached here, and there is an oxygen port attached here. So with the oxygen jet, the local is going into the bronchus. So Once you suspended the larynx, then because delivery of local anesthetic in the lower airway is difficult. How you will deliver it? It is difficult to deliver it. So you need a jet of local anesthetic agent. So this suction cannula, we are using it and using it below the parts to anesthetize it.
Sir, which would be recommend the beginners to study for airway and specific?
For airway, I think the Bible is one could be. One is Munier's Pediatric Airway book. This is a very old video, but I'm trying to get the new one because you can use the carburetor. You can do with the carburetor. Because many of my, even one of my very good friend, he's also a airway patient like me, Shashi from Artemis. He's using carburetor for vital potency. This one.
It's a PowerPoint actually.
Actually, PowerPoint. Not with the fans, but was video with the smoke detector. हाँ पीपीटी में नहीं चल रहा है you share the screen ना how the videos are not shown
Sir, चाय लेंगे please.
ले मैडम समोसा नहीं
स्टार्ट करिए फिर स्टार्ट करके
बेटा टीम से करवा लो.
हाँ
टीम ए आपने टीम बी ये फिलिप सीखा है क्रिएट करना है कि दो पे क्यों करना है अच्छा वो तो है कलेक्शंस तो टीम ए बी एंड सी ठीक है अब आप लेते जाओ रैंडम क्वेश्चंस हाँ रैंडम फिक्स कर दो और बाकी एक क्वेश्चन सर से ले लेना ठीक है दीक्षा स्टार्ट देखो तुम्हारे पास 4 राउंड है ना दो क्वेश्चन इक्वली है एप्लीकेशन सुनो सब अपनी चेयर लेके आ जा दो प्लीज ये कोई वीडियो कॉल नहीं देख पाएंगे आज दीक्षा बहुत स्लो हो गई 5:30 हो गए दैट इज द टाइम YouTube में ट्रांसमिशन नहीं होता है मैंने जल्दी करो जल्दी क्वेश्चंस अगर मैंने सेट कर दिया तो सही होगा इसमें
Hey, you can use this. Sorry. You want to use this? I'll take this. Not to it. Yeah, leave it. Sure. Thank you very much. What is this? आप यहाँ बैठो है ना नॉलेज में
तो रूल्स क्या है बता दो फटाफट पास होगा भी नहीं Please introduce yourself.
Representing college hospital. First in teaching assistant.
Good evening, everyone.
I'm Dr. Shivani, representing PROC Warrior.
Good evening, everyone.
Team one कौन सी है? Sir, team A first है, ये not include each other. कौन सी? ताला.
Preetha Anjali Karo. Actually, welcome all of you. All the three teams are very. All the you will be having 30 seconds for each round. Okay, last round will be buzzer round. You will have two questions. Only two teams will get to answer for that round. Let us all start. Team A, first question is for you.
पासिंग का क्या रूल है पास होगा क्वेश्चन तो 10 मार्क्स से 5 हो जाएगा और थर्ड पास इज फ्री बट यू कैन आंसर ओके
30 seconds each. I will be again, we will be getting 30 seconds for each question. Okay. Let us start. Team A, this question is for you. A preterm baby presents with a fluttering high-pitched inspiratory strider, which resolves on prone positioning of the infant. The ideal picture is shown above. What is the answer? Yes, your answer is right. It is laryngomalacia. It is characterized by inspiratory high-pitched strider on the right. The supraglottis is deep with floppy omega-shaped epiglottis that collapses on inspiration. Congratulations, team A. This next question is for team B. Kessler syndrome. It is characterized by bifid epiglottis, laryngotracheal cleft, falling dactyly, cutaneous indactyly, imperforatinous and seizures. No, your answer is wrong.
Thousand syndrome.
Again, it is wrong. Team A. Sorry, what did you say? Sorry. Please use the mic. Krausen. No, it's not. Oh, the time is on. It is Paris-Hall syndrome. It is caused by GLI3 PHS mutation. It is characterized by a spectrum of disorders involving bifid epiglottis, laryngotracheal cleft, polydactyly, and syndactyly. Next question is for team C.
Gases syndrome caused by chromosome 5p deletion, characterized by cat-like high pitched cry, microcephaly, intellectual disability, and hyperlevels. Okay, your time is up. Yes, you are right. The Strategic syndrome, also known as cat-like syndrome. Okay. So with this, we are done with the first round. And the first round, team A scores 15 points. Team B is at 0 and team C is also at 0. Okay, so the so this is the question for team A. Identify the condition for larynx.
साइड में आंसर दिख रहे हैं, तुम इसको फुल स्क्रीन करो या इसको नीचे करो, क्या करो?
Okay, sorry. This is the question for team 2 since the team B in the last round scoreless. Okay. So a 40-year-old male patient presented to the clinic with complaint of gradual and progressive hoarseness of voice. He's a chronic smoker and on ideal, the picture is shown in red. Yes, you are right. Laryngeal edema is also known as smoker's larynx. It is a polypoidal degeneration of vocal cords with fluid collection in the laryngeal space. So the next question is for team C. Identify this condition. 5-year-old child with history of high-grade fever, sudden dyspnea is admitted to the ICU. An X-ray of the lateral view neck shows this image. Yes, you are right. The seriograph shows as also known as the thumb sign, and it is seen in acute epiglottitis. It is an emergent condition which requires urgent ICU management. So the next question is for team A. Identify this condition. A 22-year-old rock band singer visits him with a complaint of foreign body sensation with throat, Pubophonia, and inability to sing in high pitch. What is the condition? Your time is up. Question passes to team B. It's wrong. Okay, it is wrong. It is vocal cord popping. So we are done with this round, and at the end of this round, the scores of all the teams are Team A at 15 points, Team B with 10 points, and Team C with 10 points. Now we are going to go to the third and the final round. In this round, it is a history round and also a buzzer round. So you have to raise your hands. Okay, so only 2 questions will be there. There will not be any third chance. So please be vigilant. And you will be getting 10 seconds to answer this round. Everybody's ready? Identify the stapler surgeon. The clue is a pioneer in laryngology. A prominent instrument used in direct laryngology is named after. Team A. Yes, you are right. It is 7 Jackson. He was an American pioneer in laryngology. The Chevalier Jackson distant illuminated laryngoscope and the famous Chevalier Jackson sign are said to be named after him. The next question. Teams are ready. This is the last question, then the final one. Identify the surgeon. Clue that he is known as father of bronchoscopy, has a pair of pharyngeal wall named after him. Team B. Team B raised their hands first. Dr. Gustav Killian, you are right. He was the first person to perform bronchoscopy in the year 1897. And the Killian say since the inferior constrictor muscle is said to be named after him. So with this, we are done with the PG quiz. On the round, the final scores will be.
So final score will be declared by Dr. Nanoria sir and Dr. Bansal and all them, and they will just
Sir,
they will not
Dr. Laryngology sir and Dr. Abhitha sir, I request you to come and announce the results.
First, B and C.
Team B, team A, then B, then C.
Number first. 25. 25. जी क्विज में टीम ए टीम का नंबर 25 है, बी के 40 है और सी के 10 है.
So winner team A
The winner of the quiz round is team A with 25 marks. Artist, congratulations team A.
Congratulations.
First runner-up. And the first runner-up is Dr. Soumya and Dr. Himankar from NSCB Jabalpur. Congratulations. And team C, please join us on stage. Please. Thank you everybody for participating. I think being a sport is what matters the most.
Team C को भी applaud join कर दीजिए sir. Participation is also the most important. But सबके साथ एक फोटो है, मुझे आपका टीम क्विज मास्टर खड़ी हो जाओ. दो उल्टा हो गया हो. नहीं सर आप बीच में आ जाइए ना. जैसे बॉयज एंड गर्ल्स जैसे आपको बीच में लेना चाहिए. सर बच्चा किस पे? तीन बच्चे इधर, तीन बच्चे, चार बच्चे उधर. Thank you so much, sir.
हेलो जी बताइए.
बेटा वो दीक्षा
आप किससे बात आप मुझे कोई से पढ़ें.
दीक्षा उनका सीधी पर
इसका खोल के देख लिया मुझे सर से पूछ रहा वेब एक्समैन ये भाई चालू पता है मुझे पता है मुझे मत पता है आई नो दैट विद इन शेयरिंग वो फोन भी कर लेंगे पर से जाते तो तो पास की पंख के मैं पर दे दी जब से शेयरिंग जो देंगे तो कर ले मेरा पता नहीं क्या होगा मैम जॉइन हो सही करेंगे ना तो बस शेयरिंग ऑप्शन बंद कर लेकिन जब मैं निकल जाऊँ मैं निकल जाऊँ दीक्षा शेयर हो रहा है मैम शेयर तो हो ही रहा है सर शेयरिंग हो रहा है सर
हेलो टेल मी व्हेन टू हाँ मैंने तो ज्वाइन किया है करो हाँ क्योंकि अभी अभी आपका हो गया ना ये आई हैव ज्वाइंड ऑलरेडी हाँ आई वाज जस्ट अवेटिंग योर थिंग फॉर शेयरिंग सॉरी शुड आई स्टॉप शेयरिंग माय हेलो हेलो
मैम मैम you can start sharing your screen ma'am
okay can you hear me excuse me
नहीं मैम हमारा
can you hear me
प्लस करना है क्या? मैम की आवाज है मैम की
Yeah. Am I audible?
तुमने बोला स्टार्ट किया also. तुमने बोला बाय स्टार्ट मैम can you hear us ma'am?
Yeah, I can hear you, but I don't think I'm audible to you.
We are not able to hear. Ma'am, your voice is not coming. Ma'am, we are not able to hear you, ma'am. Stop sharing the screen. Will get certificate see after the signature because NSCB inspector ने sign नहीं किया. अपन लोगों को करेंगे फिर आपको प्रिंट करवा के दे सकते हैं. नहीं भी देना नहीं करना ठीक है. इसमें कनेक्ट नहीं किया. हेलो नहीं कहाँ
Let me just check the audio input. I'll just stop sharing 1 minute.
अच्छा सर ये बहुत अच्छा है आप प्ले कर क्या बोलना है डॉक्टर मेरे फोन से बात कर रहे Manish is able to hear us, but I am not able to hear her. अरे बेटा वीडियो ऑडियो नहीं है वीडियो तो चल रहा है.
Can you hear me now?
I hear you, ma'am. Please
Hello?
go ahead.
Now can you hear me?
Yeah, we can hear you.
Okay, but I don't know whether my computer sound will play then. Let me see. I'll start sharing.
When you share, click share computer audio also. Tick the mark.
Yes, yes.
मैंने ना चाबी ले लो ये सर का सामान में निकाल में आप देखिए ना मेरी आँख है.
Okay, let's see.
कुछ कनेक्ट करते हैं एक्स्ट्रा.
Did you hear that sound?
We heard.
You heard that sound, na? Chime. Okay. So, hello, good evening, everyone. I hope I'm audible now and my screen is visible.
Yes, ma'am. Please go ahead.
Yes, okay. Thank you so much, Dr. Sachdeva. And I've been going through the session all through the day, and it's been a wonderful session that you have organized, right from the lectures and the operative demonstration, the stroboscopy, and the wonderful quiz that your PG students participated in. Okay, so should I go ahead with the presentation? Hello?
Yes, ma'am.
Yes, please. One of you can keep yourself unmuted so that I can get some feedback. Okay?
Sure, ma'am. Sure, ma'am.
Yes. Okay, so I'm Dr. Anaga Joshi. I'm a professor at Sion Hospital, which is Lokmanya Tilak Hospital, and a consultant at Exchange Reliance Hospital. So today I'll be speaking on glottic insufficiency. Now let us see what is glottic insufficiency. So it's basically the inappropriate escape of air during phonation due to the incomplete closure of the glottis. 1 minute, I'll just reduce my window. Okay. So the patient typically has dysphonia and aspiration. So what are the causes? It could be vocal fold immobility due to either vocal cord paralysis or vocal fold paresis or cricoarytenoid joint fixation. The patient's voice, did you hear that?
Yes, ma'am.
Aphonia, as this patient had. The other reasons could be vocal fold atrophy or soft tissue deficiency, either again due to de-innervation, which can cause atrophy of the vocal folds, or age-related changes such as in presbylarynges that we can see in this rigid laryngoscopic video, and tissue loss because of ablative surgeries or destructive vocal fold procedures, vocal fold scars, sulcus vocalis deformity, as is seen on this video, where there is you can see bilateral sulcus with a gap. The patient, apart from having a
गणेश विकास मंडल टाटापुर लैन सोशल नगर एमजी रोड धारावी मुंबई 70
it is not only breathy, but it's very rough. So this is typically seen in sulcus vocalis. So what are the treatment options which are available to us? We can give voice therapy, surgery in the form of either temporary buccal fold injection or permanent procedures like again buccal fold injection with different materials, or laryngeal framework surgery or surgical treatment for sulcus. Now, traditionally, we have been following the norm of wait and watch policy. Now, what is that? Wait, a watchful expectancy for the vocal fold for the phonation to return or for the other vocal fold to compensate. This is typically what we do in unilateral vocal fold paralysis, which, yes, to a certain extent, we can do. And the patient has a very breathy voice. He was a patient of vocal pulmonary Cox with left vocal cord paralysis. And after a period of 6 months, we had a complete recovery of his voice. So this has been followed traditionally. And if there was no improvement, then we would go ahead for laryngeal framework surgery or some permanent injection augmentation. But this has been replaced by early temporary medialization. What happens when you do have a watchful expectancy that you wait for that period of 6 months? What happens during that period? Patient has persistent hoarseness, persistent aspiration, he has inability to work, especially in voice professionals, and persistent difficulty in communication. Reinnervation does not restore the useful movement of the vocal folds because of the syn kinesis, that is a non-selective innervation of adductor and abductor muscles. So what happens is that the muscles that perform the opposite functions contract simultaneously, resulting in the immobility of the vocal fold or hypermobility. So even if there is re-innervation, there is syn kinesis, so there is no effective movement of the vocal folds. Also during the wait, sometimes you can get a good compensation, but very often you get a very supraglottic hyperfunction. You can get vocal folds granulomas because of the hyperfunction, or you can have a vocal fold atrophy due to long-standing innervation. What are the advantages of the early medialization? So it gives you immediate reduction in the aspiration, improved ability to cough and communicate, especially in voice professionals. What generally happens when there is a vocal fold paralysis, there is instability of the arytenoid. So the arytenoid tends to sag down along the cricoid because of the lack of the muscle control over that. So early medialization will stabilize the arytenoid and allows for a better resting position once the synkinetic reinnervation is complete. And the paralyzed vocal fold is medialized, and there is a vibrotactile stimulation from the contact of the contralateral mobile vocal fold. So what is the course of action in cases of unilateral vocal fold paralysis? So if the patient presents early and has aspiration, desires a better voice, or is a voice professional, you would go in for temporary immediate injection laryngoplasty. But if there is no aspiration, there is no dysphonia, patient does not, or if the patient does not desire, refuses for early medialization, you can continue with the voice therapy for 3 months. Or if the patient presents late to you, say like after 6 months to a year after the onset of paralysis, or after optimum speech therapy, or after temporary medialization, there is again hoarseness or return back to the hoarse voice, then you can do type 1 thyroplasty with or without arytenoid rotation. So what would be the ideal material for vocal fold injection? It has to be biocompatible, easily injectable, or removable easily, readily available with minimum preparation of time, and biomechanically it has to be similar to the vocal folds and resist reabsorption and migration. There are a variety of vocal fold augmentation materials used. Most of them either are so temporary, like gel foam, they just last for a month. The other products Zyplus or Symetra, Radius Voice Gel, and collagen-based products are not available with us. So hyaluronic acid gel, that is in the form of Restylane or Hyloform, is readily available, and this is the material of choice, what I use. And for permanent medialization or a longer lasting medialization, autologous fat would be the best option, because Teflon is, as you know, is not to be used as it causes granuloma, and the calcium hydroxylapatite is not available to us. Hyaluronic acid has excellent biocompatibility, and there is no inflammatory reaction, and is closest matched to the native vocal fold viscoelasticity. So how will you augment? That is, the injection has to be given at a point just lateral, where the transverse line from the tip of the vocal process. So that this is the tip of the vocal process, which meets the superior arcuate line. So at the just lateral and anterior to this junction, you have to inject. And the second point of injection would be at the mid-membranous region. The depth of injection should be 3 to 5 millimeter, and injection into the rinky space, that is the superficial lamina propria, has to be avoided, and a certain amount of over injection is recommended, as some amount of it could be resorbed. So what is the technique? You need to first give topical anesthesia in the form of laryngeal gargle, that is patient through a curved cannula. You have to drip 4% lignocaine while the patient is phonating. So that anesthetizes the larynx. Or you can also inject into the cricotracheal membrane and ask the patient to cough. So that also anesthetizes the larynx. So this is how the position of that's me. That is this. I am injecting transthyroid by the transthyroid technique, and that's my assistant who is holding the flexible laryngoscope, and there's one more assistant who is stabilizing the patient's head. So the patient is in a sitting position, and the TV trolley and the monitor is behind the patient. So this is, I'm just showing injection through the thyroid technique, transthyroid through the transthyroid membrane. So this is the skin marking. That's the thyroid notch, and this just above the thyroid notch you would inject. This is the point of insertion of the needle. So the needle, 1.5-inch needle, 25 gauge needle, is bent at two sides, one at 45 degrees at the hub, and again at 45 degrees around 1 to 1.5 centimeters from the tip of the needle. So the final needle is perpendicular to the syringe. So the needle will emerge through the petiole of the epiglottis. And with this technique, you can inject bilaterally also. So it's very convenient. So here you are injecting just lateral to the superior articulate line and just anterior to the vocal process at a depth of 3.3 to 5 millimeters. And once you start injecting, you will see that the vocal fold has started pumping up. Sorry. Okay. You can check the patient while phonating, and you can optimize the amount of injection that is to be given. So typically, if for a smaller phonatory gap, around 1 cc is enough. But for larger phonatory gaps, you need to give 2 cc of the solution. So that this is the rigid laryngoscopic video of the patient before injection, and that is after injection.
Shakuntala Jain, Chairman. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12,
Patient's
13.
voice operatively.
मेरा नाम शकुंतला है 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15
There is
16 17.
immediate restoration of voice. There is improvement in the maximum phonatory time. This is the patient has a high pitched sound, and that is also corrected with the injection. Other approaches can be transthyroid. This is what I do nowadays with the onset of COVID. It is much easier. There is no exposure of the needle inside the larynx. And in younger patients, it is very comfortable and very easy. Can be cricothyroid or transoral, or sometimes if the patient is not cooperative, then you can give a trans microlaryngoscopic injection that is under general anesthesia. Injection laryngoplasty is cost effective, minimally invasive, performed transorally or can be performed transorally and in the as an office procedure, done under local anesthesia, and you can re-inject again if there is reabsorption of the injection material. As I said, if the patient has a reversal of the hoarseness, or patient presents to you late, 6 months to 12 months after the injury, then you can do a permanent medialization in the form of thyroplasty, where you create a window in the thyroid cartilage and insert a silastic implant inside to medialize the vocal folds. So typically the window size is 5 millimeter to 8 to 10 millimeter in females, and for males it is 6 millimeter to 12 millimeters. The window is placed 5 millimeter posterior to the from the midline in case of females, and 6 to 7 millimeters from the midline in case of males. And there has to be at least 3 millimeter distance from the lower margin of the thyroid cartilage. And the window is marked. Now, this case was a elderly gentleman, so I had to drill the cartilage to remove because it has ossified. And then you check for the amount of medialization which is required by assessing the patient's voice. This is the silastic block which needs to be trimmed. So the amount of medialization required is judged, and the silastic block is carved and trimmed accordingly. So this you judge what is the amount of anterior medialization which is required, and the posterior medialization, and the silastic block is inserted. You check by doing a fiber optic laryngoscopy. So this was the patient's preoperative visual laryngoscopic video. This is the post-operative video. So while at the level of the true cords and not at the level of the false cords. This is the patient's voice.
एक लांब श्वास घ्या आणि असा म्हणा.
Thyroplasty can also may require anterior reduction if there is a larger posterior glottal gap. This is so that the vocal process rotates more medially so as to close the posterior glottal gap. Now, this was regards patients with vocal hold paralysis. Now, what do we do with patients with sulcus vocalis or scarring or presbyophonia? They have bilateral lesion. There is no chance of spontaneous recovery, so they need some permanent treatment. There is loss of in sulcus and scarring. There is loss of the superficial lamina propria with phonatory gap, and you have to reconstruct the SLP along with medialization. So, what are the options that we have? We can augment with fat, that is, fill up that gap with fat, or inject fat, or medialize the vocal folds with fat, or with some permanent medialization material, or do a surgery for the sulcus, which is Pontes or modified Pontes. So what are the different for basically fat, you need to first harvest that fat, and there are different techniques for fat harvesting. Either you can remove it as a monoblock. This is used when that fat as a block is to be inserted into that sulcus pocket, or you can do liposuction and aspirate the fat and then process it further by centrifugation. Or you can remove a block of fat and then dice it and mince it into small pieces and fill up the syringe with for injection. So this is why liposuction, where you take the fat by liposuction and then centrifuge it and then fill up the syringes with the fat. Fat is injected. It's a similar technique. It's only that the fat injection cannot be done under local anesthesia. One, because you need to use a thicker needle for that, and to harvest the fat, patient needs to be under general anesthesia. So, but the technique of injection into the vocal fold is similar. So you insert the needle just lateral to the vocal fold, that is the superior arcuate line, and let the vocal fold medialize it, get medialized. The difference between is that you really need to overcorrect very much, more than 50% of overcorrection. There's over injection is required with fat because temporary medialization. One is because although it gets reabsorbed, whatever some amount of which of the permanently, okay, and only thing is that we cannot predict how much of it will get reabsorbed. So you have to inject so much so that the vocal fold gets medialized right till the midline. Then the second option that you have for sulcus is that you can do fat implantation. Now, what is fat implantation? This is a little tedious procedure. You have to first take an incision, that is, do an epithelial cordotomy, that is, taken after infiltration, subepithelial infiltration. I hope all of you can appreciate the sulcus, which is there bilaterally. So once you take a epithelial cordotomy incision, the sulcus is elevated off from its insertion, either if it is inserted into the vocal ligament or it's inserted stuck to the muscle, underlying muscle. And you create a pocket, and into that pocket, you insert fat. Once you have inserted fat, that epithelial cordotomy incision has to be sutured with 6-0 vicryl. Now, this is the most difficult of the procedure, where you it's difficult to take sutures inside the larynx. So apart from the fat implantation, I have you can see that I'm also injecting fat laterally to medialize the vocal fold. So in this procedure, you're creating a superficial lamina propria, recreating the SLP, as well as medializing the vocal fold. So the drawback of this procedure is that it takes a very long time for this vocal fold to heal. So this is
दीपाली शिवाजी परंडा जुतारा रोड शिवाजी नगर नंबर 2 गणेश सोसाइटी मुंबई पश्चिम.
This is the patient's voice preoperatively. It's just a little because the voice will not be absolutely normal. In sulcus, it's really difficult to recreate the entire superficial lamina propria. So there has to be a very guarded prognosis when you're operating on a sulcus patient. So if there is very minimal hoarseness, don't take up the patient for surgery. This is the patient's post-operative voice.
माझे नाव दीपाली शिवाजी परंडा. माझं ऑपरेशन 10 जानेवारी सायन्स हॉस्पिटलमध्ये झालं. 1 2 3 4 5 6.
We got a very satisfactory result with fat implantation as against fat injection, because we have found that the fat injection causes it gets absorbed when the patient's voice comes back to the original state. There was improvement in the voice analysis also, as you can see here. The advantage of fat is that it has excellent biocompatibility. It's inexpensive, as you know, the ample amount of is found with every patient. It is similar in viscosity to the lamina propria, does not disturb the vocal fold vibration, even if it is injected into the superficial lamina propria. But the disadvantage is that it decreases in volume in the early postoperative period, and the degree of post-resorption differs, and it depends upon the condition of the fat which is injected and requires a long time for harvesting. There is as I said, there's a risk of reabsorption and needs a skin incision for the fat harvesting and general anesthesia. So now there's again here nowadays we have sort of revisited the earlier principle or technique which was suggested by Ponte. There is a slicing mucosa technique which I do for the sulcus, is where you are cutting the tension lines to the or the scar tissue so as to yield a free mucosal vibration. So the principle is that you interrupt the fibrotic or tension lines, and the where you take, so this was actually not the ideal case because the sulcus was going right till the muscle. That I think during a discussion there was a discussion on sulcus vocalis. So this is sort of a type 2B, where it's going right till the level of the muscle. So you take a cordotomy, raise the sulcus, and once you have raised the sulcus, so that is freed from its attachment underneath, then you take horizontal or perpendicular incisions so as to break the scar tissue or the tension lines. And you also have injected fat laterally. So what has happened now, there is a raw area now, but what will happen is that there will be re-epithelialization over the raw area, which will help in sort of, we have seen that the yielding a free mucosal vibration. Now there is a modified technique as suggested by Dr. Nupur, that is a laser assisted sulcus release, where instead of cutting with cold instruments, you take laser cuts horizontally. Now this particular technique does not require a lateral cordotomy incision, and you need not elevate the epithelium from its bed. So you just take horizontal incisions, and this does the same job as with the cold techniques. So this was the patient's preoperative wise.
1 2 3 4 5 6 7 8 9 1 2 3 4.
And this was after the.
मेरा नाम अमनी सिंह है, मैं विरार की रहने वाली हूँ, मैं एक हाउसवाइफ हूँ. मेरा
Unfortunately, I couldn't get the laser surgeries, but this was just with the cold instruments. Although at the end of the surgery, it looks very ghastly, as even I thought what I had done to this patient, but I was pleasantly surprised with the patient's voice post-operatively. And this is the post-operative strobe of the patient. You can see that the mucosal wave has returned. Can you see that?
मेरा नाम अमनी सिंह.
This was again. You can see the mucosal wave coming back to normal.
यादव है, मैं मानपुर की रहने वाली हूँ, मानपुर मंडला. मेरा नाम सुनीता यादव है, मैं मानपुर की रहने वाली हूँ. 1 2 3 4 5. मेरा नाम सुनीता यादव है, मेरा नाम सुनीता यादव है, मैं मानपुर की रहने वाली हूँ.
Okay, so sometimes you have seen that the laryngoscopic really very bad. I mean, you are wondering what is wrong with the patient, and this is the time when the stroboscopy is very, very essential. So you can see that the mucosal wave is completely absent at this particular region. So there is a lot of scarring, and this is how you would. This is very, very important. The stroboscopy is very important when you want to give a prognosis to the patient regarding the surgery. So there, here you can see that there is loss of the lamina propria, due to which the mucosal wave is absent, and which causes severe dysphonia. So that has given excellent results. If nothing else,
My name is Gopal. My address Sri Ganesh Vikas Mandal, Tata Power Line, Social Nagar, MG Road, Dharai, Mumbai 17.
Yeah, very found a reasonable voice in this patient. So to conclude, the take-home message is early medialization immediately corrects the patient's vocal as well as aspiration problems, while still allowing for the spontaneous recovery to happen. Injection laryngoplasty is a minimally invasive procedure and can be carried out as an OPD procedure as well. And hyaluronic acid is a preferred material for temporary medialization with its very good properties. And type 1 thyroplasty with the silastic block is least expensive, precise. It can give precise medialization and is longer lasting in cases of when you need permanent medialization. In fact, insulin is a graft material for permanent injection. 30 to 40% will get reabsorbed, and hence you need to overcorrect. Hello, sorry. Excuse me, I think you're not mute. Yeah, and treatment of sulcus involves fat augmentation or fat injection as well as excision of the sulcus with the slicing technique. So thank you very much. And I would really like to thank the organizers for this workshop for inviting me to take this lecture. And thank you very much and wish you all the best.
Anatha, it was so mesmerizing for the audience, all pasted, no one taking a lid down. So I think you need an invitation for Jabalpur also. And these students might be visiting you. So beautiful, so fine surgery you are doing. And really, I would like to know the slicing technique in detail. Very nice. It is your hands which are blessed with the beautiful brain behind it. And thank you for joining at this Saturday evening. And we have really enjoyed it thoroughly. So thank you so much. Thank you. Wish you to be connected. And thank you so much. Bye.
Thank you. Bye-bye.
So, Dr. Srinivas Kishore, I will take only 5 minutes for e-poster and then you can start. So only e-poster, 4 participants are there. They'll participate in 5 minutes and they'll go ahead. Thank you for being with us, sir. Come on, start. E-poster लगा चलिए. और 4 e-poster वाले रुकोगे भी आधा घंटा जाना है. So, sir, Dr. Srinivas, first I will do your case and then we will do the e-poster, right? You have to come out of the practice. Huh?
Either ways is fine, Dr. Kavita.
No, sir, I think, no, sir, you finish it because students are sitting here. We can do it later. Thank you. So, share.
All right. Do you want me to start my presentation then?
Ji, sir. Ji, sir.
All right. Are you able to see my slide deck?
Yes, sir. Yes, sir. Yes, sir.
All right. Good evening, everybody. First of all, please let me know if I'm very clear and audible.
Yes, sir, you are clear and audible.
All right. First of all, let me thank the department for giving me this opportunity to interact with you today and share my little experience with pediatric laryngology with you guys. And I see it's a very august gathering, and I would like to keep it as interactive as possible, so that at any point in time, if any of you have any doubts or any questions, you can interrupt me and we can take it in a short discussion format. But if it requires further explanation, I will probably take it at the end of my talk. So with that kind of an introduction, let me introduce myself. My name is Dr. Srinivas Kishore, and I am the Director of ENT Services and Sleep Apnea Services at AIG Hospitals in Hyderabad. We at the department have different subunits, and we get a fair share of pediatric and neonatal work. So the title that I'm going to talk to you about today are two. One is I'm going to talk to you about laryngeal clefts, and two, I'm going to talk to you about webs, and that's the title that I gave ma'am. So the title is going to be laryngeal clefts and webs. So the first I'm going to talk to you about laryngeal clefts, and then I will talk to you about webs. So second. So what are laryngeal clefts? Laryngeal clefts are actually, unfortunately, a rare clinical occurrences, but nevertheless, we as ENT surgeons should know to pick it up when it's there. So by definition, laryngeal cleft is a congenital condition in which there is an abnormal communication between the larynx and the esophagus, because there is an opening in the posterior laryngotracheal wall, which basically is allowing food and liquids to pass from the esophageal lumen into the airway and hence causes aspiration. So as you can see in this introduction, you know what is happening and why and how these patients would present to us. Since it's a congenital condition, the babies would present pretty early based on the severity of the cleft. Now, here is a beautiful diagram very clearly describing the different types of laryngeal clefts. Initially, it has been the clinical system has been coined by Benjamin and Inglis. It's called the Benjamin and Inglis system. Now, there are 4 basic types of clefts: cleft type 1, type 2, type 3, and type 4. And each one of them are very clearly you can make out that. Let me just show you. Now, this is type 1 cleft. Now, type 1 clefts are usually almost subclinical in their presentation. Unless there is an obvious problem, these kids don't present, and I will show you a video how difficult it is sometimes to differentiate it from laryngomalacia. A type 1 cleft is basically a cleft. It's a deep notch between the arytenoids, but the cricoid is perfectly intact. In type 2 clefts, you can see that the notch between the arytenoid or the interarytenoid notch is gone deeper. And here you can see that there is a defect in the posterior lamina of the cricoid cartilage. When this becomes further deeper, it can be called a 2B. That means if the cleft is involving the posterior wall of the cricoid up to the base of the cricoid, it can be called a 2B. A 2A is in between that means midway in the cricoid cartilage, and a 2B is to the base of the cricoid cartilage. Type 3 is a deep wedge, is a deep cleft bypassing the cricoids. That means the posterior wall of the cricoid is also defective, and so is the posterior wall of the membranous trachea. And type 4 are deep clefts extending right from the cricoid apex up to almost up to the level of the carina. And you can see here very beautifully there at the level of the thoracic inlet. This is going beyond the level of the thoracic inlet. Here it is not up to the level of the thoracic inlet, but it is way past the lower border of the cricoid cartilage. So I've put a picture here for you just to know the difference between a simple laryngomalacia and a type 1 cleft. How would you know? It's very difficult to know just clinically. You will have to put some kind of a probe to actually try and see and make a wedge between the in the interarytenoid space, insinuate this particular instrument so that you can actually see that there is a cleft. Now, I've also noted down a couple of syndromes here. These syndromes are the ones that are usually manifest along with laryngeal clefts. This is something that is important for you postgraduates because these are some things that can come out as questions. So 2 take-home points in this particular slide. The system of classification, which is the Benjamin English system. The second thing is that you need to know the different types of laryngeal clefts. And number 3, you need to know the different syndromes that laryngeal clefts are associated with. And number 4, the most important point, how do you differentiate a type 1 laryngeal cleft or any laryngeal cleft from a bad laryngomalacia? It is through this a probe test wherein you can put in a metal probe, wherein you can actually put the probe.
For making us feel enriched.
Can I continue?
Yes. Yes, sir. Yes, sir. Please continue.
Yeah. So the take-home points from this particular slide are these 4 points. Now, how do these kids present to us? They actually can present with a myriad of symptoms, but amongst them, the most common are cough, especially while feeding, recurrent respiratory tract infections. This is a symptom that type 1 clefts usually present with, because we won't be knowing child will have recurrent lower respiratory tract infections, and most of the time we would be missing. This is because there is no obvious cleft. You won't have that particular history of classical cough while feeding. They would, however, present with recurrent lower respiratory tract infections. And ignoring these recurrent lower respiratory tract infections, children may or babies may present with respiratory distress and frank aspiration. So type 1, type 3 and type 4 clefts are usually they present with swallowing dysfunctions, whereas type 2 clefts, because these are the clefts which are neither obvious nor they are too light. So these are the ones that present with stridor. So it's again very important, dear colleagues, junior colleagues, for you to understand that even though these 4 are the primary symptoms with which babies present to us as pediatric otolaryngologists, you need to know that which are the type of the clefts that present with swallowing dysfunctions and which are the clefts that present with stridor. So you need to understand that stridor doesn't necessarily mean only laryngomalacia or cord palsy or subglottic stenosis. Even cleft babies do present with stridor, especially the type 2 clefts. So in approximately 58 to 68% of patients with laryngeal clefts, there is often an other congenital malformation that is there. So whenever you see a laryngeal cleft, always look for another comorbidity that would present, because 58 to 68% is pretty high. Usually, these anomalies are in the gastrointestinal tract, like esophageal atresia, or tracheoesophageal fistula, or intestinal malnotations. So you don't have to look farther; they are in the vicinity. So when there is a child of laryngeal cleft, always look for associated problems in the GIT as well. And they are pretty high in incidence, about 58 to 68%. So here is a flexible laryngopharyngoscopy of a patient with let me play this. Are you able to see the video?
Yes, sir.
Are you able to see the video? Yeah. So let me just, this is on a flexible FLP that you can see that there is a notch here. And this is in rigid scopy. Very obviously, this is a type 2 cleft, wherein you can very clearly see the defect. This baby is intubated because patient presented with severe distress. And you can see when I'm lifting the endotracheal tube up, and you can actually see the entire defect. There is a defect between the arytenoids. There's a deep wedge between the arytenoids. Now, how do you go about treating these patients? Usually, if it's a type 1 laryngeal cleft, injection of hyaluronic acid itself or Hylase injection is good enough. Injecting Hylase will give you pretty good sort of closure of that defect. And if the child is presenting with feeding difficulties, or if the child is presenting with recurrent cough, this simple injection will give a lot of relief to the patient. However, from type 2 clefts onwards, something has to be done. Just giving an injection will not be enough. You need to go ahead and do either an endoscopic repair or an open repair, basically based on the severity of the problem. So here is a video of a repair of one of the clefts. This is a type 2 repair. I have put it in fast forward so that it doesn't eat up into our time. This is into almost, so here I'll describe the video for you. I put a pleject. I'm using a coblation to create a raw area in the mucosa covering the arytenoids. And it is very important to release the arydioepiglottic folds as well, because when you do the surgical intervention, if you don't release the arydioepiglottic folds, it's very difficult to get that mucosa to close. So you can see that I'm using a simple laryngoscope, an anesthesia laryngoscope. So I've created a raw area between the arytenoid mucosa, and then I'm closing it with acryl sutures, or you can also use 4O PDS sutures. It is very, very important to start from inside out. And you can see how I'm going ahead and making multiple sutures. At least 2 sutures have to be made so that you will get adequate closure. Now I'm trying to put in a third closure as well. The most important point is that you should not be tightening the knot too much. So it is important that you close it, but tie the knot, but the knot should be snugly fit. So you can see how the defect, we have closed the defect. And I'm using neuropathies here. And again, we don't want too much tension. That's why I release the arydioepiglottic fold there. And now you can see the entire, see there is a bleeder there in the AE fold, which we completely closed. I'm also creating a raw area in the lingual surface of the epiglottis to create a glossoepiglottopexy. So this is another video again. This is in slow motion. You can see that we have created a raw area here. It's very difficult to suture in that area. So this video is for you to sort of understand what we did in fast forward there. And you would be also, you see the raw area and the arydioepiglottic folds, because unless you release that, you will not be able to get a good closure. Okay, so my colleague is holding the laryngoscope, and I would take a bite, come out, and then, are you able to follow? Okay, let me just And you can see how we are holding. This video is for you just to understand that. And this is a knot that I have put. Okay, and also I was telling you that the knot should not be too tight, so that because if the knot is too tight, the mucosa will get necrosed below and cause problems, right? Just to approximate, you can see the esophageal opening there, and this is how you tie the knot. This is the post-op image of how these babies heal beautifully. There, you can see, even though there's a little bit of as if there is some mucosa holding the arytenoids together, but yeah, the symptom relief is very dramatic. So there are certain pearls that I want to discuss with you. The most important is excessive force and inferior pressure in the posterior glottis may lead to incorrect diagnosis. So you shouldn't be putting too much force when you want to diagnose these clefts. Adequate endoscopic exposure of the cleft is vital for success. If exposure is limited, an open approach is any day better to do than an endoscopic approach and closure. It is of paramount importance to completely remove the mucosa at the apex of the cleft to prevent any kind of residual bridge of mucosa, because if there is any kind of a bridge of, if there is a mucosa that is left behind, then it won't heal properly. And the first suture is the most important suture, then that should be placed at the inferior extent of the cleft. And most importantly, while placing sutures, care must be taken not to inadvertently involve the mucosa or epiglottis, because again it can bleed and cause problems. This is as far as the clefts are concerned. I'll go through the webs also for you. Again, the classification by Cohen. This is type A, B, C, and D based on the extent of the larynx that is involved. Type 1, there is 30% of glottis, no subglottic extension. The treatment plan is observe. You don't have to operate. Type 2, 35 to 50% of glottis and subglottic extension is minimal. You can decide between surgery or observation. Type 3, 50 to 70% of glottic obstruction with very thick subglottic involvement. Definitely, you will need to do a surgery with a tracheostomy. Type 4, 75 to 100%, that also you will need to do surgery and tracheostomy. So here is a patient with laryngeal web. You can see beautifully the type 3 laryngeal web. And this is how we go about treating this. This is a microlaryngeal wand that we are going ahead and dividing it. There are different ways to do it. And if you remember, in type 3 webs, there is significant subglottic extension. So there is a subglottic extensions which you have to remove. And this is how it is. So in this is an endoscopic and open approach. You can see that we have completely divided the web. And after the web is completely divided, it is important that you identify a small, like I said, this requires a tracheostomy, and we have done a tracheostomy for this baby. To identify the extent of the, see, you can put this needle, and once we put the needle, we know that whether we have dissected it exactly in the midline or no. And then you can see now that in this patient, we have put a keel, which is endoscopically and externally. It's a hybrid technique. The keel is the most important thing. Why we need the needle is we are using a knife to can't exactly do a laryngophilia so that put the keel. Yeah, so that's about it. Let me just, if there are any questions at this point, let me stop sharing. Are there any questions?
Yes. Sir, it was a very informative talk, and like the students, for them it is a new concept of cleft, and they are seeing it probably first time in the screen. And I think now when they will encounter that the endotracheal tube is going in esophagus, they will understand that this is a cleft they are dealing with. It's a beautiful thing. Yes, repair of it will be very tough. So videos of that we should watch more. And thank you so much for joining. And it was our pleasure to.
Invitation.
Thank you, sir. Thank you. Bye-bye. So thank you, Dr. Sriharsha. Only posters are left, and you have been with us since morning, and I'm so thankful to you. Diksha, start the posters.
Thank you, ma'am. Thank you very much.
Thank you. I want 5 minutes more so that these posters also go.
Sure, ma'am. Sure.
Right. Thank you so much.
I would like to request all the candidates who are going to present the posters to please come and sit in the front chairs. I would like to request Dr. Kavita Sachdeva ma'am and Dr. Ravindra Bansal sir to kindly chair this session. बाकी दो कंटेस्टेंट्स अच्छा यही दो हैं You are Varsha and she is what is your Sir, Shriyarsa sir, I'm not able to control from my desktop this.
We didn't, I didn't put anything. Just, you can do it.
So Irfana will be joining you after 5 minutes. Irfana, after this you will be having lecture from your point. We are just completing with 4 slides. Okay.
Sure, sure.
Ma'am, एक second. हो गया
Present this one है जब हमको present करो वहाँ बैठ के. What is your case?
शैलेश का है मैं आ जाऊँ आ जाओ सीख
डॉक्टर
Good evening, everyone.
लैपटॉप भी आ रही है वॉइस.
Good evening, everyone. This is a case of laryngeal. This is a rare case of primary laryngeal vocal cord actinomycosis in a middle